Good morning, Dr. Sanjay sir. Should we begin? 669.
Good morning, everyone. Welcome to the second day of DOS Scientific Program. I welcome all the participants and our esteemed judges, Dr. Sanjay Chaudhary, Dr. Rajesh Sinha, and Dr.
Hi, good morning, everybody.
Good morning, everyone.
Hi, Dr. Ritika, how are you?
Good morning, sir. Good, sir.
Hi,
Good morning.
Sina. Hi, how are you?
Good morning, Ritika. Good
Ah.
morning, Rohit Chaudhary.
Yeah. So, all set? Shall we start?
So, shall we? Yeah, I think we should start. So, Sony,
Yeah.
you coordinating or what?
Yes,
Nee,
sir.
confirm. Yeah. You're starting, Sohani? Yeah.
Okay, so let's start.
Yeah. I'll just get my phone.
So let's start the refractive surgery free paper session with the first presenter, Dr. Rishabh Grover, who will be speaking on evaluation of functional vision and corneal changes after myopic laser in situ keratomiliosis. Dr. Rishabh, please start your screen share.
Good morning, everyone. Am I
Morning.
audible?
Yes.
Yeah. Sony, I just want to ask you one thing. How will you do the marking?
Sir, the Google spreadsheet has been given to all the judges. And marking
Where
will
is
be.
the spreadsheet?
It has been mailed to all the judges, I think. It has been mailed.
Sir, it's come by the email from Hardik.
It has.
Okay, okay. So we have to fill it up and mail it to whom?
Dr. Namrata.
Okay, okay.
A very good morning to everyone. My topic for today's free paper is evaluation of functional vision and corneal changes after myopic classic. There are no financial disclosures to be made. Examiner, as we all know, works on the principle of ablative photodecomposition. Due to various reasons, standard LASIK, the microkeratome LASIK is still one of the most widely used for refractive surgery procedures. And even despite the advancements made like the femtosecond LASIK coupled with topography and aberration-based corrections and SMILE, this study will be a part of a larger picture consisting of series of studies that we'll undertake at our hospital on similar pattern on femtosecond LASIK and topo-guided LASIK as well as SMILE in future. So the objectives of the study was to evaluate pre and post LASIK functional vision, corneal changes on pentacam, and possible correlations between such changes. Objective parameters of functional vision do not always correlate with patient satisfaction. Therefore, we included VFQ 25 score as developed by National Eye Institute. So it was a prospective study comparing pre and post LASIK data after 3 months of LASIK. Functional vision was assessed using Snellen visual acuity, Pelly-Robson contrast sensitivity, and VFQ 25 score. Corneal changes were compared using pentacam. Inclusion criteria included patients between 18 and 40 years of age, myopia with or without astigmatism, stable refraction for past 1 year, corneal thickness more than 500 microns, and keratometry readings between 40 to 47 diopters. Exclusion criteria included monoocular patients, patients with any form of corneal ectasias, any dry eye diseases, patients with spherical equivalent of more than minus 12 diopters in either eye, patient with any other significant vision affecting ocular condition, autoimmune or systemic diseases, pregnant and lactating women. Clinical results in our study were recorded at 3 months post LASIK and was statistically analyzed. Pentacam examination measured the following parameters. Same surgeon operated using the same treatment nomograms. Minimum post-LASIK thickness was targeted to be 300 microns or 60%, whichever is being higher. SBK flap of about 110 microns was made. Optical zone and transition zone was set considering the pupil size and planned residual bed thickness. No intra-op or post-op complications were noted in 3 months of follow-up. Sex and age distribution was as follows: 60% of patients were females, rest 40% being male. 60% of patients were between 19 to 26 years of age. The spherical equivalent ranged from -2 diopters to -10.5 diopters. Visual acuity improved from pre-LASIK BCDVA of 0.04 on logMAR scale to post-operative LASIK UCDVA of 0.02 on logMAR scale. On visual function questionnaire, showed a statistically significant improvement in the mean score from 86.41 to 88.03. Contrast sensitivity decreased from a mean of 1.8 to 1.61. Average keratometry, as expected, reduced from 43.65 diopters to 39.63 diopters. And the change was statistically significant. The average keratometry of posterior corneal surface changed from -6.32 diopters to -6.28 diopters. The asphericity value changed from -0.36 to +0.42. The change again was statistically significant. The asphericity value of posterior corneal surface changed from -0.14 to -0.1. The point to note here was the posterior surface remained prolate. The pachymetry reduced from 539.97 microns to 471.15 microns. These are the various parameters and their correlations. The correlation between contrast sensitivity and change in anterior surface Q value shows that the amount of positive shift in the Q value is correlated to the reduced contrast sensitivity score. The amount of refractive error corrected is correlated to the amount of positive shift in the Q value. So to summarize, the uncorrected distance vision after 3 months of LASIK was better than the best corrected pre-LASIK vision. Patient satisfaction was analyzed by VFQ-25 scoring system, which showed significant increase in the score. There was a significant deterioration in contrast sensitivity noted, being statistically significant. The Q value of both anterior and posterior corneal surface showed positive shift post-operatively. The anterior corneal surface changed from prolate to oblate. The posterior corneal surface remained prolate after LASIK. As already mentioned, there was a significant decrease in contrast sensitivity, and change in Q value of anterior corneal surface correlated to the amount of refractive error corrected. Thank you.
Thank you, Dr. Rishabh. Judges would like some comments.
Rishabh, it was a nice effort, I would say. Just one point that, I mean, these things are there in the literature now.
Yes, sir.
So what additional point that you could get from this paper?
So basically, as I said, that this will form a part of a larger series of studies which I'm going to undertake, comparing the standard microkeratome LASIK and its validity in today's in current times, because it is one of the most cost-effective refractive surgery available today. So I'm going to compare it with the upcoming studies which I'm going to undertake, like with the topo-guided LASIK and with possibly even SMILE in future.
Okay, good.
Okay, before we call the second candidate, Sohini, can you please email us the form for marking?
Yes, sir. Yes, sir.
Rajesh and Ritika, you got the form?
Yes, sir, I've got it. If you can search, it's come by Hardik at RX events. Should I forward it to you, sir?
Yeah, please. That
It
would
has
be
been it has been sent actually. I'll forward it again to.
nice. Thank you, Ritika. Yeah.
Okay, let's move on to the next presenter, Dr. Samira Hassan, who will be speaking on to evaluate the changes in central corneal thickness, keratometry, and refractive error after in laser situ keratomiliosis. Dr. Samira, please your screen share.
Good morning, all of you. I'll just take a second. Can you see the screen?
Yes.
Okay, sorry.
Yes, Samira.
I'm Dr. Samira Hassan from Government Medical College, Srinagar. I'll be presenting my paper titled to evaluate the change in central corneal thickness, keratometry and refractive error after LASIK in myopic eyes. LASIK is a lamellar laser refractive surgery in which the excimer laser ablation is done under a partial thickness lamellar corneal flap. The microkeratome uses an oscillating blade to cut the flap after immobilization of the cornea with a suction ring. Microkeratomes cut the lamellar flaps with either a superior or nasal hinge and can cut up to the depths of 100 to 200 microns. The excimer laser is used to reshape the surface of cornea by removing the anterior stromal tissue. The process by which the excimer laser removes the corneal tissue is non-thermal ablative photodecomposition. The aims and objectives of the study were to measure the changes in CCT after LASIK, to analyze the changes in refractive error following LASIK, to analyze the changes in keratometry following LASIK, and to evaluate the effect of preoperative keratometry on refractive outcome after LASIK. The study was conducted in Government Medical College, Postgraduate Department of Ophthalmology, over a period of 1.5 years, prospective observational study that included 174 myopic eyes, accounting 89 patients. The patients that were included age more than 18 years and less than 40 years, a stable refraction change of less than 0.5 diopter. In last year, pre-operative cycloplegic spherical refraction between -1 to -8 diopter of myopia and 3 diopter of astigmatism. Pre-operative best corrected visual acuity of more or equal to 6/9 and estimated RST of at least 250 microns. These patients were excluded: keratoconus or form of history keratoconus, CCT of less than 450 microns, unstable refraction, preocular or corneal surgery, connective tissue disorder, pregnancy, breastfeeding, and severe dry eye. Preoperatively, a complete ophthalmological medical surgical examination as well as history were taken. Assessment of UCVA, BCVA, cycloplegic refraction, fundus examination, tonometry, biomicroscopy, specular microscopy for CCT, and corneal topography was done. Patients who were using the contact lenses, soft contact lenses 2 weeks and rigid contact lenses 4 weeks, patients were instructed to discontinue the use. And CCT was measured by the non-contact specular top cone SP and topography with the Atlas Zeiss machine. Pre and post-operative K was taken as flat plus T by K, and the change in K, delta K, that was calculated as pre-operative minus post-operative average K. LASIK was performed using 1 plus microkeratome that created a flap of 9 to 9.5 mm with an intended thickness of 100 microns with a nasal hinge, and the excimer laser was done with MEL 80. Post-operative patients were put on moxifloxacin 0.5 and dexamethasone 0.1 4 times a day for 1 week, and artificial tears 6 times for 6 to 10 weeks. Patients were followed on first post-operative day following LASIK first week, first month, and third month. And at each visit, UCVA, PCVA, specular microscopy, and non-contact specular microscopy and corneal topography was done. This is at our center where we perform a LASIK. The suction ring is being placed, the microkeratome placed, creating a nasal hinge. The vacuum is released. The flap lifted gently. This is the laser, progression of laser. The hydration of interface to the flap imposed. Then with the other eye in a similar procedure. Results. Our study included 89 patients. Most of the patients were females that approached at 56.17%. And in this study, 87.35 patients had a spherical equivalent of -6 diopter, and only 12.65 patients had a spherical equivalent of more than 6.6 diopter. Actually, we have taken a moderate myopia of up to -8 only. That's why we got most of the patients in the -6 diopter. Out of 141 eyes achieved Snellen's activity of 6/6, 26 eyes, 6/9, and 7 eyes had a vision of 6/12 to 6/18. 167 eyes out of 174 eyes attained a visual acuity of Snellen's of more or equal to 6/9 with a significant P. In this study, we categorized the pre-operatively, we categorized the patients into 3 groups according to their keratometry. The group A, B, and C. A having the slightly a flatter keratometry of 40.12, B 44, and C 45. And the post-LASIK mean spherical equivalent that we saw more towards the myopic side in the patients who pre-operatively had a flatter cornea of 40.12. This table shows the mean change in the delta K. The average, there was more of the change in the delta K in the patients who had more of the pre-LASIK spherical equivalent, and they equally had the more residual refractive error.
Dr. Samaira, your time is up. Please try to wind up.
Okay. The conclusion is that LASIK improved the visual acuity of more 6/9 in 95.57% of the eyes. CCT and keratometry significantly decreased immediately following LASIK, but a further change over a period of 3 months was insignificant. The flatter corneas had a tendency towards undercorrection, and greater the degree was of myopia, the greater was the change in keratometry, and greater were the chance of undercorrection. And LASIK remains a popular choice of myopia for patients, particularly among females. Thank you.
Thank you, Dr. Samaira. Judges would like to make some comments.
Yeah, sure.
Mother, anything you noticed in very flat corneas other than undercorrection? And if undercorrection, how much of undercorrection did you note in very flat corneas, the 40.5 category?
In 40.5 category,
how much of undercorrection did you note as a principle compared to this the normal or the steeper corneas? You said there was undercorrection in flat corneas, right?
Yes, sir. So it was
so how much
minus 0.75, but
that was an average 0.75.
It was an average. It was an average. minus 0.75 was an average. The patients we categorized in this keratometric group.
And could you explain any reason for that?
The reason could be because the flatter cornea it does not have that much of surface area as have the steeper corneas. So when the laser is ablated, maybe there's a repetition of the laser spots, or they could be because the interface is hydrated, and maybe a flat cornea can retain more of the moisture, and then again that impedes this laser. There could be these possibilities of.
Could it be possible that the flap size is small, the ablation area exposed is small, and the hinge is also taking away a good chunk of the area?
Yes,
So probably you didn't get a full profile of your ablation on a flat cornea.
yes, sir. Yes, sir. That's what surface area I told, that they have a small surface area as compared to steeper, because the flap size is less, and definitely the nasal hinge that takes up.
Right. Thank you, Samira. Can you move on to the next?
Thank you, sir.
Any comment from any other judges?
No, it's fine. Fine from my side.
Okay, let's move on to the next presenter. Dr. Ankita is not there, so Dr. Smith Snehal will be presenting on management of smile ectasia using tissue addition and pocket cross-linking, initial experience in 4 eyes.
In the meantime, can you please send me the evaluation form? I haven't received it as yet.
So
Sir, I have emailed it, but I sent it at the email address that I've written in the
Yeah,
chat.
I have received it. I've just now received your mail, Ritika. And
I have, Ritika, can you do it on drchaudhary@gmail.com, please? DR Chaudhary.
उसी
हाँ
पे
जी,
किया
उसी
है।
पे किया है।
हाँ जी
अच्छा,
सर।
चलो, I'm waiting.
and marking has to be done out of 10. Ritika, it's not mentioned there.
So this is all that I got. I'm marking out of 10 only. I think that will
Okay,
make it.
okay.
Even
So
I'm doing
that's
that.
the reason why I asked that we all three of us will do uniform way, no?
Yes,
Yeah.
sir.
Okay.
Sir, have you received the form?
No, not as yet. I'm just waiting. Can you do it again, please, Ritika? DR, then Chaudhary, CHAUDHARY @gmail.com.
Sir, yes. DRCHAU.
चौधरी की स्पेलिंग चेक कर लेना चौधरी कई बार वेरिएबल होता है
हाँ CHAUDHARY.
सर इसी पे भेजा है सर.
अच्छा एक बार थोड़ा सा और ट्राई कर लीजिए otherwise I'll ask somebody.
Sure, sir. I'll actually send it twice. I'll send it again.
ठीक है राजेश सिन्हा तुम भी एक भेज दो यार.
मैं भी कर देता हूँ
आप भी कर दो सर.
Yeah. Thank you so much. Yeah, can we go on? Yeah. Smita Snehal.
Yes, sir. So good morning,
Smith, yeah.
chairpersons and my dear friends and colleagues. The topic of my presentation is management of smile ectasia using tissue addition and pocket cross-linking. My co-authors, Dr. Sri Ganesh and Dr. Sheetal Brar, are consultants to Carl Zeiss Meditech. There is, however, no financial interest in the subject matter of this presentation. So ectasia after smile is still reported, though we consider smile to be biomechanically more stable as compared to LASIK, because we are not cutting the Bowman's membrane and preserving the strongest part of the cornea, which is the anterior part. So there have been 5 such case reports, and the management of smile ectasia, which has been published, is APO of collagen cross-linking using Dresden protocol with or without intracorneal ring segments. So the purpose of this paper is to describe an innovative technique for the management of smile ectasia with tissue addition and using smile-derived lenticules and pocket cross-linking. So this was an exploratory study where we treated 5 eyes of 4 patients with a mean age of 25.8 diopters. All patients had mild to moderate ectasia, and there was an improvement in the corrected distance visual acuity of at least 2 lines. So this technique is essentially based on a technique called femtosecond intrastromal lenticular implantation described by my co-authors Dr. Sri Ganesh and Dr. Sheetal Brar for treatment of keratoconus, wherein they combine this technique with accelerated collagen cross-linking. So we thought that the same concept can be used for treating smile ectasia, because essentially smile ectasia is essentially a keratoconus developing in a normal eye that has undergone refractive surgery. So we obtained an IRB approval, and after taking informed consent from donor as well as recipient, we planned both the procedures essentially on the same day. The donor lenticule were collected from patients undergoing smile for myopia correction, and the lenticules were implanted on the same day. So this is how the preparation of the donor lenticule is done. The lenticule is stained with riboflavin dye placed on a Teflon block, and it is punched in the center to create a donut-shaped annulus. And this is the recipient eye where the old smile pocket is opened, following which riboflavin 0.25% is injected, and it is allowed to soak for 2 minutes. After washing the dye, then we implant the lenticule using a T-shaped inserter and center it to the center of the corneal apex. Following this, the eye was subjected to accelerated collagen cross-linking in pocket. So we are not doing any de-epithelialization. So the patients are comfortable and there is no delayed healing or chance of infection. And the protocol used was 18 milliwatts for 5.8 minutes, delivering a total energy of 6.3 millijoules. So these are some of the cases that we treated using this technique. A 24-year-old female with moderate myopic astigmatism underwent SMILE. 3 years later, she presented with ectasia. When we looked at the pre-op topography, we actually found that this patient had formifrustic keratoconus, which we overlooked because at that time, this is actually one of our initial cases where we thought SMILE to be biomechanically more stable. And since the patient had a good RST, we went ahead and did SMILE. So we planned and we performed tissue addition with pocket cross-linking for this patient for ectasia management, and post-op 1 year, as you can see, there is a 4.5 diopter flattening in the steep K. And also as seen on ASO clinical photo, the lenticule was well centered and stable, and there was an improvement in the corrected distance visual acuity as well. This is another case with moderate high myopic astigmatism. The patient underwent both eye SMILE. His preoperative topography was normal. Even the bad display was normal. 3 years later, he presented with both eye ectasia. This is the ectasia in the right eye, and this is the ectasia in the left eye, as evident on topography. So we performed a SMILE. We performed tissue addition pocket cross-linking again for this patient. And as you can see, there's a 6.2 diopter flattening in the steep K in the right eye, and 5 diopter flattening in the steep K in the left eye with improvement in corrected distance visual acuity. This patient later divulged that he had a history of habitual eye rubbing. This patient again came to us for a second opinion. She was a high myope and had underwent bilateral SMILE. At presentation, when we diagnosed her to have left eye ectasia, and we again performed pocket cross-linking following tissue addition, and there was a 4.5 diopters flattening in K1 and K2 observed. An ASOCT clinical photo again were showing the lenticule to be well centered and stable, and an improvement in the corrected distance visual acuity. So this is how it is supposed to work. In ectasia, you have a central steep portion and a flatter mid-peripheral part. An addition of donut-shaped tissue elevates the mid-periphery and steepens steepening it and causes relative flattening in the center, improving shape. Also, the collagen cross-linking leads to stabilization of ectasia. Thus, in conclusion, this is the first case series of SMILE ectasia managed with tissue addition and pocket cross-linking. Also shows another application of SMILE-derived lenticules, and it seems to be a feasible option to treat SMILE ectasia. There is no risk of extrusion or infections like intracorneal rings, no pain, delayed healing like conventional cross-linking, and the procedure is reversible. Should rejection occur, you can anytime remove the lenticule and implant a new one. However, we still need longer follow-ups to establish long-term safety, efficacy, and effects on corneal stabilization. Thank you so much for your kind attention.
Thank you, Dr. Smith.
Smith, that was a wonderful presentation. Really excellent, very innovative.
Thank you, sir.
So that takes care of both the stabilization of ectasia and correction of myopia associated with ectasia. Right, Smith?
Yes, sir. Because how we how we choose the lenticules are based on the spherical equivalent of the eye that is undergoing SMILE.
Yeah. So that was my question. How do you decide the thickness of the lenticule? That means you remove the lenticule from a healthy eye. So do you match it that if you are removing a lenticule of 2 diopters, you would use a 2 diopter lenticule for the correction of myopia induced by ectasia?
So the thickness is not altered. Basically, it is only the spherical equivalent that is taken into consideration.
Mhm. So any criteria of, suppose you have a residual of 3 diopters of myopia because of ectasia.
Yes, sir.
So what would be your criteria of choosing a lenticule? From a patient, you're doing a 2 dioptic correction or a 4 dioptic correction or a 6 or a 8?
So we will choose the lenticule based on the spherical equivalent only. Thickness is not a criteria in all the cases we have done as such. We have initially done this procedure using lenticules that were preserved. So preserved lenticules, we noticed that there was some decrease in thickness, and also the quality of these lenticules deteriorated. And we did not have any rejection as such in this series. However, in the hyperopia series, wherein these lenticules were again implanted to treat hyperopia, there was one case of rejection out of 30 cases that we treated for smile hyperopia.
Okay. Right, Smith. Wonderful presentation.
Smith,
Thank you,
I have one query.
Yes, sir.
How long is your follow-up?
So as of now, we have not seen any rejection in all the follow-ups that
No,
that are
I'm not
done so
asking
far.
for
Yes, sir.
rejection actually. The reason
Yes,
is
sir.
that, intrastromal lenticule, when you implant, then what happens that the initial flattening that you get, it gradually reduces with time because of the thinning of the stroma.
Yes, sir.
I have noted in my own series. So one thing I would like to know that how long was your follow-up and whether the flattening remained the same over that period. I mean, it depends on the duration actually.
Sir, of these 5 cases, as of now, we have had just 2 patients who came back to us for follow-ups. 3 of them have not yet followed up. So of those 2 cases that we have, one was this bilateral patient. So he is doing fine. And even the other case is doing fine, sir.
Okay. And the minimum thickness in all the eyes was more than 400?
Yes, sir. It was more than 400.
Okay.
One more question. We normally see that a lot of post any ectasia refractive surgery is more decentered, particularly in LASIK. You've treated a lot of central cones. Did you see a difference in decentered ectasias in terms of, more inferior steepening versus the central? Because you're treating them with like a symmetric donut, right?
Yes, ma'am. Yes, ma'am. As of now, all the cases had a central cone. So in that case, we don't have any experience with decentered cones, ma'am, as such in this case series.
Because classically, ectasia is more inferior.
Yes, ma'am.
And you had central which fit well with the donut, but the other kind of cones may not fit as well.
Yeah, completely agree with Dr. Ritika, because in our series also in some of the slightly decentered cones, the elevation increased in those areas. So that was an issue. Okay.
Yes, sir. Thank you, sir.
Thank you. Good study.
Yes, sir. Thank you, sir. Thank you so much.
Okay. Dr. Raghav Malik is not there with us. So we move forward to the next presenter, Dr. Arish Garg, who will be presenting on corneal densitometry after accelerated collagen cross-linking using riboflavin dye with HPMC.
Am I audible?
Yes.
I've received the form also, Sina. Thank you so much.
Okay. Finally, you received.
Yeah.
Is my screen visible, sir?
Yeah, Rushi, carry on.
Good morning, everyone. So I'll be presenting our data on corneal densitometry after accelerated collagen cross-linking using HPMC riboflavin dye. We don't have any financial interest. Now, thanks to the Bunsen-Roscoe law, a lot of studies comparing the conventional and accelerated cross-linking protocols for efficacy in halting progression have shown that accelerated protocols are just as effective as conventional protocols in halting progression, especially the 9 and 18 milliwatt protocols. Also, we see that with the demarcation line is deeper when the duration of irradiation is more and the intensity is lesser. And this cross-linking depth, the post-cross-linking haze depth is more in the central cornea and shallower in the peripheral cornea. Also, recently, a lot of interest has been generated in isotonic HPMC riboflavin because it prevents intraoperative thinning of this cornea by swelling the stroma and hence allows cross-linking to be performed in thinner corneas as well. It has also been found to have a faster diffusion rate of riboflavin. Hence, we started to apply milliwatt protocols and started noticing that after uneventful cross-linking, at 1 month, the post cross-linking haze instead of the center part was more in the mid-peripheral zone and in the mid-stromal area concentrically, which made us to question as to what differently we were doing in our protocols. Now, since corneal densitometry is easily and conveniently available and has been extensively used to study the post-cross-linking haze, we decided to go ahead and study the densitometric pattern and progression of post-cross-linking haze using accelerated protocol and HPMC dye. Now, ours was a retrospective case series in Tertiary Care Hospital on patients getting operated with progressive keratoconus between July 2018 and September 2019. And those patients who had a thinnest pachymetry of more than 350 microns were included, which yielded us 30 eyes of 26 patients. All the patients underwent a measurement of uncorrected and best spectacle corrected visual acuity preoperatively, postoperatively 1 and 3, 6 months, along with mean spherical equivalent, corneal topography, and specular microscopy. Then all the patients had undergone epithelium off procedure with riboflavin dye using with HPMC 1.1% instilled every 2 minutes for 10 minutes, followed by continuous UVA radiation at the 18 milliwatt for 5 minutes rate on Peschke machine. And at the end of procedure, the bandage contact lens was put and topical FML was tapered over 12 days. Our outcome measures at 1 month, 3 months, and 6 months were refractive outcomes, keratometric outcomes, corneal density, and endothelial cell density. The corneal densitometry was measured in grayscale units on Scheinfeld tomography pentacam, and it was taken as the objective measure of corneal haze. Statistical analysis was done using paired t-test. So coming to the refractive outcomes, we saw that there was no significant change in the logMAR UCVA and mean spherical equivalent at 1 and 6 months. However, we did see some worsening of the best corrected visual acuity at 1 month, which returned to preoperative levels at 6 months. Keratometrically, there was no significant change in K1 and Kmax at 1 month and 6 months. However, we did see some amount of steepening in the K2 at 1 month, which again returned to preoperative levels at 6 months. The specular microscopy did not show any significant change in the endothelial cell density at 3 months, which deemed it to be safe. Now, the densitometric data showed us that the mean total density in the 0 to 2 mm and the 2 to 6 mm annular zone showed a significant increase at 1 month postoperatively, which was maintained at 3 months, and it came back to the preoperative levels at 6 months. Clinically, as well as densitometrically, we were able to see 2 types of patterns of haze. In 18 eyes, we saw haze in the posterior cornea of the central 2 mm zone and the anterior and central part of the mid-peripheral zone, which is in the 2 to 6 mm zone, as evidence as shown in the slit lamp photo, which showed the corresponding changes in the corneal densitometry. And on ASOCT, the demarcation depth was as low as 400 microns, as deep as 400 microns in the center and 300 microns in the periphery. Whereas the second type of haze that we were seeing was the regular haze in the localized in the central and anterior part of the 0 to 2 mm zone of the cornea. Both these patterns of haze was at 1 and 3 months visit and resolved completely at 6 months. And in this, the demarcation depth was at around 360 microns, which is actually much more deeper than what has been reported in earlier studies for accelerated protocol. And also there was no correlation of this pattern of haze with the preoperative pachymetry. So we know that riboflavin in the cross-linking acts as a photosensitizer for the induction of cross-linking as a protective agent by absorbing the UVA radiation. We also saw, but there have been studies which show that HPMC causes a faster and a deeper diffusion of riboflavin versus dextran. So is it possible that using HPMC can cause a deeper level of haze as compared to dextran? And also we know that conventional cross-linking gives even a deeper level of haze than accelerated protocols. So in our study, we did not see any significant change in the endothelial density, but we would need to also evaluate conventional protocols with conventional cross-linking protocol with HPMC dye to see if there is any endothelial damage happening. So to conclude, the accelerated cross-linking with HPMC dye shows a distinct deep stromal and mid-peripheral haze, maximum at 1 month, persisting at 3 months, and resolving completely by 6 months without any significant difference on endothelial count. Our study is limited by a small cohort of patients. We've not done any confocal. We can do a confocal microscopic study to see the exact depth of the histological changes of haze. And since corneal densitometry does not give the exact demarcation depth, it would be interesting to note its correlation on ASOCT as well. So what was known is accelerated cross-linking produces a shallower demarcation line compared to conventional cross-linking, and riboflavin with HPMC, it maintains corneal thickness during cross-linking, and it may have a deeper and faster rate of diffusion compared to dextran riboflavin. And what this paper adds is that accelerated cross-linking with HPMC dye shows a deeper level of stromal and a slightly shallower mid-peripheral haze at 1 month, resolving completely by 6 months without any significant endothelial damage. And further studies would be required to look at possible endothelial damage with conventional cross-linking with the HPMC riboflavin dye. Thank you.
Thank you, Sneha. That was a wonderful presentation. Any questions?
Yeah, any occurrence of late haze?
No, sir. There were whatever haze was present at 1 month, that only resolved at 6 months. We did not see any late haze or any delayed onset or even persistent haze.
Okay.
Any other comments? Okay. Dr. S. Arjun is not there with us, so we move forward to our next presenter, Dr. Mohammed Asif, who will be presenting on predictability of post-operative ICL vault using MIOCT in patients undergoing ICL for myopia.
Is my screen visible?
Yes.
Yeah.
Yeah.
Good morning, everyone. I'm going to talk about the predictability of post-operative implantable columnar lens vault using intraoperative OCT in myopic
Can you be a
eyes.
little louder?
Sir. I'm going to talk about the predictability of post-operative implantable columnar lens vault using intraoperative optical coherence tomography in myopic eyes. There is no financial disclosure. And a slight introduction, phakic intraocular lens is a very safe and effective modality in treatment, especially in patients with higher refractive error, and those are not amenable by ablative procedures or in patients with abnormal topography. So the most important factor in determining the success of this is the vault of the phakic lens. So ideal vault is 250 to 750 microns. The vault is the distance between the posterior surface of the implantable columnar lens and the anterior surface of the crystalline lens. So in this, we have evaluated intraoperatively using microscope integrated OCT, and which is Lumera 700 and Rescan 700 from Carl Zeiss, and which has an integrated spectral domain OCT basically with a wavelength of 840 nanometer. And this helps in acquiring around 27,000 A scans with an axial resolution of 5.5 microns and a depth of up to 2 mm. So there are various studies in literature in which they have evaluated, they have tried to predict the post-operative vault pre-operatively, and they have derived various prediction and correlation analysis. Like there are so much, and this is a summary of them. A study by Lee et al. And you can see such a complex formula has been derived to predict the post-operative vault. Similarly, Chen et al., Igarshi et al., and everyone had their own correlation analysis and had their own formulas for the predictability of post-operative vault in the pre-operatively. But the one problem with all these things was the predictability was not very close, and there was a mean error. So there was significant mean error. The only formula which was very close to the in prediction of post-operative vault was the NK formula, which was derived by Nakamura et al. And in this, he has derived a pre-operative correlation analysis for sizing of the ICL, optimal size of the ICL. So basically, your vault is dependent on the size of the ICL. So indirectly, it helps in determining the vault of the ICL. So in this study, we have implanted ICL V4C in our setup, and the informed consent was taken from all our patients, and ethical clearance was obtained. And the inclusion criteria in our study was age more than 21 years, myopia more than 8 diopter, or any degree of myopia with abnormal topography, and the patient should have a stable refraction for at least 1 year, and IOP less than 21 mm of mercury, and anterior chamber depth more than 2.9 mm, and endothelial cell density of more than 2500. So 40 eyes of 20 consecutive patients undergoing ICL implantation were prospectively evaluated. The vaulting was measured intraoperatively using MIOCT. The ICL lenticular relationship was dynamically assessed throughout the surgery. And the post-operative vaulting was measured using ASOCT on the same day at 6 hours, day 1, day 2, day 3 and 4, 1 week, 2 week, and at 4 week. The uncorrected and best corrected distance visual acuity, IOP, and anterior chamber and posterior segments were all evaluated in all the cases. So how did we measure using MIOCT? So we measured using a 9 mm cube, which was acquired for analysis. The height of the cube is actually displayed in the Callisto as a 2000 microns or 2 mm cube, and it is used as a measure to assess the intraoperative vaulting. So basically a ruler can be used to measure the vaulting from the OCT scan displayed on the screen of the Callisto, and the readings are in millimeter, and it is later converted into micron by multiplying it by a factor of 7.5 microns, because the minimum resolution of the ruler is 7.5 microns. So basically in this you can see the cube size of 2 mm. So you can see in this in the first image A, the height of the OCT cube displayed on the Callisto eye as measured by the ruler corresponds to around 2000 microns or 2 mm, and it is used for calibration of measurement values. And intraoperatively the vaulting is compared, and it is assessed by a ruler, and later we have intraoperative vaulting measured was also by we have using an image processing software, and we have correlated the distance, the intraoperative vaulting that has been calculated, and the vaulting is measured by ASOCT, which is shown in figure D. So the results, the mean refractive error, mean spherical equivalent in our cases were minus 9.65 with a standard deviation of 3.26 diopter, and the mean wide to wide in our patients were 11.76 with a standard deviation of 0.39. The mean central vaulting noted intraoperatively was 584.5 with a standard deviation of 210 microns, and post-operative vaulting in this you can see at 6 hours it was almost the same as the intraoperative vaulting, which was measured using ASOCT, 595.8. At day 1 there was slight increase to 612.8 because of the aqueous production, which adds to the altered aqueous dynamics in the after placing the ICL inside the eye. And at 1 week, again the vault reduces to 578, and at 4 weeks it is again 574. So after 1 week and at 4 week, it's almost negligible difference was there. So the intraoperative OCT, then we found that the intraoperative OCT over predicted in 80% of the patients. The over prediction was ranging from +2 to +66 microns, and the mean over prediction was 3.39%. So intraoperative OCT under predicted in only 20% of the patients. So majority of our patients, it was slightly over predicting in the range of +2 to +66 microns. The under predictions was in the range of 2.43%, and the overall the intraoperative OCT was over predicting by 1.93% to the final vault at 4 weeks. So we compared the intraoperative with the final 4 weeks vaulting. So with this data, we did a correlation analysis, and post-operative vaulting could be predicted using the formula 8.84 plus 0.96 into intraoperative vaulting. And this formula, when we applied, we got a mean error of vault estimation around 12.99 with a standard deviation of 11.91 microns. So in those eyes which have been under predicted, there were 8 eyes in which out of 40 eyes which has been under predicted, the vault intraoperative vault was less than 350 microns in 7 out of 8 eyes. So basically in our study we found out whichever had an lower vault intraoperatively, in those cases there was under prediction, whereas if it is a normal vault, if it is a higher vault, it is always over predicting. So the limitations of our study was a small sample size, And there can be slight individual variations because of the improper removal of OVD during the surgery that can add to the vault, increased vault intraoperatively. The position of the ICL also matters, like as seen by one of the studies in literature, where they said like the vaulting decreases when the haptic, one of the haptic is in the sulc, is over the ciliary zonules, and one is not over the ciliary zonules, and it is increased when both the haptics are over the ciliary zonules. So basically the position of the ICL haptics could affect the vaulting, and this correlation analysis and prediction formula has only been developed, so verification of the formula is still being carried out in the second phase. And this is one of the study in which they said like the intraocular positions of the ICL could change the post-operative vaulting. The conclusion, intraoperative OCT is a good tool in our study, we found out, and it is very useful in predicting the final post-operative vaulting. Thank you.
Thank you, Dr. Asif, for that excellent talk. Judges, comments?
Yeah, Asif, that was a wonderful talk. In fact, the concept that initially the vault is low and it increases after the first day to the week. Here we have shown that it in fact is decreasing at 1 week at 4 weeks, right?
Yes, sir.
So it is a concept which is questioning the usual concepts which are accepted by us. But the study is good. It is very convincing.
Yes, sir. Thank you, sir.
Dr. Asif, how is it going to help you in your clinical practice? Like will it be applicable in modifying your management pattern and modifying your clinical practice?
Yes, sir. If the patient in on table, if you're seeing a high vault, and basically as surgeons we sit temporally and try to place the ICL temporally. So the sulcus to sulcus diameter of the temporal horizontal sulcus to sulcus is shorter when compared to the vertical sulcus to sulcus. So basically on this basis, if the patient is having a higher vault intraoperatively using MIOCT, and if it is a non-toric ICL, you can rotate the ICL on table to a vertical position. So we can have a predictable and a better vaulting post-operatively. And if it is a toric ICL, then rotation would not be possible. And if it is like a very high vault, like more than 1100, or in an ICL with a very low vault, like less than 100, you can on table expand the ICL, and you can like resize it and evaluate him for a better ICL sizing at a later moment. And if some surgeons, if they are preferring to do bilateral surgery at the same setting, and if one eye is done and it is having a very low vault, instead of proceeding to the other eye in the intraoperatively, you'll be able to decide whether to proceed to the other eye or not based on the vaulting of the first eye. And in a very borderline cases, if it is like around 200 or less than 250, more than 100, but these patients you can keep in a very close follow-up, and you can observe the vault in the post-operative period. These are few of the uses of this prediction of vaulting using MIOCT.
But Asif, have you noted that when you're finishing up with the surgery on the table, if you
Yes,
keep the chamber hard or you fill it up too much, then you are pressing the ICL down and the vault is less.
Yes, sir.
And when the IOP comes back to normal, the ICL tends to come up. So
Yes,
at
sir.
what stage were you taking your IOCT readings to correlate with the actual IOP pressures and the actual position of the vault?
Yes, sir. This is a very key factor. This plays a very important role when you are measuring. So basically, in all our cases, we measured after complete viscoelastic removal, after formation of the anterior chamber, and hydration of the wound at the end of the procedure. Where you found like a normal IOP is there, you have reached a normal IOP, and you have hydrated the wound. There is no wound leak, and anterior
Yeah,
chamber
but
is
how
well
do you
formed.
ascertain the normal IOP? Is there some kind of a measurement by which you say, okay, now the IOP is 20, and this is the point I should measure the vault? Because if your IOP is, let us say, 30 or 35 or 40, then your vault would be less.
Yes, sir. Yes, sir. Absolutely, sir. But in normal clinical scenarios, in at the end of the surgery, how we do measure the by slightly indenting with a blunt cannula or anything over the cornea. We just try to clinically assess the intraocular pressure. Okay, this seems normal, but it's just a clinical and inter-observer variation could be there, but
right.
could slightly predict it is in the normal range of IOP.
Right. Very nice.
Asif,
Very nice
in any case, did you use pilocarpine? Because that
No, sir. Routinely
depends
we
on
don't
vault.
use pilocarpine. Actually, pilocarpine could also reduce the vaulting, but in our
Yes.
case, in none of the patients we use pilocarpine, sir.
Yeah. Okay.
Okay. Right.
Good study.
Thank you, sir.
We now move on to the last presenter of this session, Dr. Hushaydar Kharas, who will be presenting on resolution of rare and early epithelial ingrowth post-LASIK by flap lift, a case series.
Yeah, hello, good morning. I'll just take a second to share my screen. Yeah, hi, good morning, everyone. My today's paper is on resolution of rare and early epithelial ingrowth by post-LASIK by flap lift. It is a case series of 5 cases. Introduction is the incidence of epithelial ingrowth in LASIK interface is constitutes to around 1%, and it presents as a spectrum. So it's from, its presence is being minimal and causing no interference in the vision to involving the central pupillary area. And etiology uses of mechanical microkeratome for flap inadequate adhesion of the flap over the stromal bed, thus creating a fistula to allow creation of the epithelial cells. The peripheral presence of the epithelial cells is required for the normal healing, and however, their presence in the visual axis poses a threat to the visual. A case series of 5 patients presenting with the OPD was noted, and the patients underwent an uneventful LASIK surgery. The first one was BA6 pre-operation and his visual acuity dropped to 612. This was a high myop with BA of 6.9 pre-op, and after undergoing he presented with grade 3.
We have lost
Yeah.
the speaker. There was some connection.
Yeah, probably.
Sorry, internet connection was stable over here. I'm sorry. Can you see?
Yeah, I can hear your voice, but it's all cracked up and we can't see the video.
I'm very sorry, my internet connection is not, very good now. Can you see my slide? Can I continue?
No, you have to share it first.
Sir.
Share screen.
Dr. Hushaydar, we cannot see your slides. Yes, we can see.
Yeah, we can see your slide now. No. It got cancelled again.
Am I audible?
You're
Yes,
audible, yeah.
but your
But
screen.
we can't see your slides.
Just a second, sir. Can you see them now?
No. Yeah, we can see it now.
Yeah, okay. Very sorry for the interruption. There is seems to be something.
No problem, no problem. Please continue.
Yeah. So
Can you go to the slideshow?
Full screen mode.
Yeah. Is it? Hello.
Your voice is breaking.
Yeah. Okay. So can I am I audible now?
Yeah. Go ahead.
Yeah. So the case 3, it was a moderate myope, and just a second. And with DCV of 6.6 preoperatively, he underwent a LASIK, and he's presented with grade 1 epithelial ingrowth and 2 weeks after the operation. The case 4 was a moderate myope 6.6 pre-op, and he underwent the LASIK surgery, and he presented with grade 3 epithelial ingrowth in both eyes, and this was after 1 week, and his visual acuity dropped to 6.9. The final case, the 5th patient, moderate myope with 6.6 in the right eye and 6.9 in the left eye pre-op, and he presented with grade 1 epithelial ingrowth in the right eye. Vision was 6.6 and grade 3 in the left eye, and after 2 weeks, the vision dropped to 12. You can see here there are the index of the epithelial cells and the same, and most of the patients at grade 3, the remaining at grade 1 epithelial growth, and the grade 3 patients, their vision had dropped lines, and patients had an intervention with the lab and an MMC of 0.02%. So 10 eyes have grade 3, and
You're again off screen, Taras.
Dr. Hushedar, you can mail your presentation to us.
I'm very sorry, my net is not good this now. Can you hear me?
Yeah, we can hear you. Your voice is a little broken, but can you share your slides?
I already shared, sir. Are you not able to see them?
No.
Just a second, sir.
Maybe because of the connection, it's snapped.
Yeah.
I guess so, sir. I guess so.
So in the meantime, if we hear you out, Dr. Hushedar.
Yes, sir, I can do,
So
but,
what did you do? How was it resolved?
see the epithelial ingrowth?
Yeah.
So we did a flap lip and we did a scraping of those epithelial cells. Can you see my slides now, sir?
No.
Sorry,
So
sir.
you
So what we
scraped
did
it?
was, but we scraped them and we used the mitomycin C for 0.02%. And then and the thorough washing of the stromal bed was done, and a BCL was placed over the eye, and the patient was then followed up for the next day for the 14 days, and after 1 month, and then again after 3 months. So we there was complete resolution of these epithelial cells was noted after a period of 3 months, and we did not do anything for.
Okay. Your voice.
Hello, sir.
Yeah, we can hear you now. Yes, Hushedar,
So
carry
for
on.
grade 1, we didn't do anything. For the grade 1, we didn't do anything. We just observed them closely, and they did not progress. So we have not done any intervention in those patients. But for the patients where we use the mitomycin, so there was a complete resolution in all the 5 patients, in all the eyes which are grade 3.
And they did not recur.
No, sir, they did not recur. But the patients did not come after follow-up for 3 months, sir. So we don't know after that.
So what was the primary cause of the epithelial downgrowth? And why do you think the epithelium did not grow in again from the same point?
Because of the mitomycin, I believe, sir, that because it is an antifibrotic, the epithelial cells, there was no recurrence of the epithelial ingrowth, and the cause I think, sir, because we use a microkeratome over here, so that is one of the reasons.
So the microkeratome is one of the reasons, because the edge becomes very thin, and that is how the
Very thick,
epithelium can
yes, sir.
creep in, right? But then
Yes, sir.
that factor still stays the same for a recurrent epithelial downgrowth.
Yes, sir. But sir,
Yeah,
in
but-
these patients, we did not notice them. So after 3 months, unfortunately, the patients have not come for follow-up yet.
Okay, right.
So
Right. This is a great finding. So it's very encouraging, and I think most of us are already doing this.
yes, sir.
Right. Anything which you could think of a little beyond what you've already done? Have you thought of sealing the edges with glue?
Yes, sir. We thought of that, but because of the financial constraints and the consultants over here, they do not like to use it. So we just use mitomycin C, sir.
Oh, okay, right. That was wonderful. That's really good, Visheda.
Thank you so much, sir.
Yeah.
Dr.
Thank you.
Spina,
I'm
any
very sorry
questions?
for the internet connection, sir.
Yeah.
No
No
problem.
issue. I just want to ask you one question. Since you had a case series,
Yes, sir.
could you get something in common amongst all these patients that resulted in epithelial growth? Because all these were done by microkeratome. You have done
Yes, sir.
surgeries in so many other cases also. So
Yes, sir.
there has to be something common in between these patients to have great growth. Since these were primary surgeries only, no resurgery was done. So what was something that was common in between any issue that was acting as a risk factor for these patients?
Was it
Patients
a
were 30, 30
primary
and one
incision
of
with the
them was a
blade?
type 1 diabetic. So
Do you use a
yes,
blade
sir.
for one
We do
patient,
not
or
have
do
a
you
femtosecond
reuse it?
laser over here.
One eye, one blade, or one blade, two eyes?
One blade, two eyes, sir.
And this was in the first eye or the second eye?
This was in the second eye, sir. Some people had both eyes. Some of the cases had unilateral cases.
Okay. Dr. Sinha, could you give do you think of any possibility of why it happened in these people?
No, but I just wanted to know what can be the factor. There can be, of course, as you said, that the blade can be a factor if it's blunt, if it has been reused. That is one. Apart from that, if
So one of the patients was a type 1 diabetic, and most of the patients were the age group of 30. So that was one of the textbook risk factors. So
no, another risk factor, which is also textbook, but has been noted also in our series also, some of the cases, that if you have EBMD, epithelial basement membrane dystrophy, in such cases,
membrane dystrophy. Okay, yes, sir.
if you have done LASIK in those cases, particularly the microkeratome LASIK, then the risk of epithelial ingrowth is very high in those cases. So that is why I wanted to know whether there was any risk factor that was in between these patients, because whatever you did was all right, all correct.
No, sir, none such
For
noted,
one
sir.
patient, you did the same
Yes,
for
sir.
all these. So that's why I wanted to know what can be the reason.
What was the flap thickness that you used,
No, sir,
Dr.
there was no such.
Dr. Visheda, what was the flap thickness that you used? 90 or 130 head? Sorry?
Sir, 130.
130.
130, sir.
Yeah, okay. So
Yes,
you're safe there also. You have enough tissue there.
The EBMD has been shown to be a major risk factor in some of the, epithelial growth, which was initially overlooked and then later on found to be having EBMD, and it resulted in epithelial growth. So that is why that is also one factor.
Right. I think that was really good, Khushida. Thank you so much.
Yeah. Thank
I
you.
think
Nice
yeah.
series.
Yeah. Thank you, my colleagues,
Thank
Dr.
you so
Sinha,
much, sir.
Dr.
Thank you,
Ritika
sir.
Sachdev, and thank you all the participants. The presentations were really very good. Now, what are we supposed to do? Take a picture of this and send it to conferences at DOS?
So you can share the Excel. When you open it and fill it up, it will say share via email. I have mailed it to Dr. Namrata.
Oh, okay. Right.
Okay.
Thank you.
Thank you so much, judges and all the
And
participants. We can conclude this session.
Thank you, Sohini, for
thank you
coordinating.
so much.
Thank you,
Thank
everyone.
you.
It's 10:30.
Yes, good morning everyone to all the participants and our esteemed judges, Dr. A.K. Amitav and Dr. Shweta Chaurasia. We don't have the first four presenters with us, Dr. Ashok, Dr. Shivdev, Dr. Saman Zamir, and Dr. Robin Jain. So we'll begin with Dr. Smith Shah, who will be...
Can you repeat the names, please?
Dr. Ashok Kumar Meena, Dr. Shivdev, Dr. Saman Zamir, and Dr. Robin Jain.
So they will not be presenting?
Ma'am, if time permits and if they join eventually, we can give them an opportunity.
Okay.
So we'll begin with Dr. Smith Shah.
Our other judge is not there, so can you
Yes.
just make a call and inquire?
Yes. Ma'am, I have asked the moderator team to contact him.
Okay, so should we wait for him for 5 minutes, like?
For 5 minutes, we can wait, ma'am.
Can all the participants switch on the camera? So I welcome all the participants in this free paper session. So meanwhile, you can just introduce yourself once. You're not audible.
Dr. Smith Shah, yeah. You are not audible.
Hello.
Yeah.
Shweta ma'am.
Yes, yes, you're audible.
मैम डॉक्टर दूसरे जज है ना वो नहीं आ सकते क्योंकि वो दूसरे सेशन में बैठे हैं कैन यू हियर मी ठीक है
There's a lot of echo.
Ma'am, the other judge, Dr. A.K. Amitav, he won't be joining us because he is judging some other session.
Okay, okay, fine. So we'll begin it. So just introduce yourself once, check your mics, and you have to keep the time. You have to be careful about the timing because the negative marks will be there for if you exceed the time. So all the best to all of you. Just you can introduce yourself and start. So I would like to invite first Smith Shah, right?
Yes, yes.
Smith Shah for the topic.
For the topic, incidence and risk factors of retinopathy of prematurity in high-risk preterm, types and time of intervention with outcomes.
Yeah. You can start. You can start sharing your slides.
Okay. I'm Dr. Smith Shah. I'm junior resident at M&J Western Regional Institute of Ophthalmology, Ahmedabad. The topic of my presentation is incidence and risk factor of retinopathy of prematurity prematurity in high-risk preterms, the time and type of intervention with outcomes. So retinopathy of prematurity is a challenging cause of childhood blindness among the premature babies, which is caused by disorganized growth of retinal blood vessels, which causes retinal fibrosis and detachment. All the preterm babies are at high risk for ROP, and very low birth weight is an additional risk factor. Since the incidence of ROP is observed worldwide because of the improved survivals of low birth weight and premature babies all over the world, the combined effort of pediatrician and ophthalmologists is required for the timely intervention of the disease. So the growth of embryonic arteries begin at the 3rd month of pregnancy and ends at about the birth. The stages of evolution are defective in premature babies, and the growth of vessel is either stopped or unusual, which makes the vessels fragile, which can cause to visual impairment in severe cases. It is a preventable disease and responds to the treatment appropriately if diagnosed in the early stages. But in cases of delayed diagnosis and treatment, it may lead to severe complications and ultimately blindness. It is a multifactorial disease, and the important risk factors are preterm delivery, that is before the 32nd week of gestation, birth weight less than 1500 grams, apnea, infection, intraventricular hemorrhage, respiratory disorders, certain cardiovascular disorders, blood transfusion, vitamin E deficiency, and the increased blood carbon dioxide and increased oxygen consumption with decreased pH. Timing is one of the important factors that makes the treatment successful in ROP. The vascular endothelial growth factors plays an important role in the development of the new vessels, which plays an important role in the pathogenesis of the disease. So the objective of the study was to study the incidence and risk factors and in the high risk premature babies, and to assess the outcomes as favorable or non-favorable after various time and type of intervention. The study was a prospective and non-comparative observational and interventional study, which was carried out at M&J Western Regional Institute of Ophthalmology from December 2016 to August 2018. The Institutional Ethics Review Board has approved the study, which was adherent to the tenets of the Declaration of Helsinki. All the high-risk preterm babies which presented at the institute from birth weight of 500 grams to 2 kilograms and gestational age less than 34 weeks were screened for ROP at 4 weeks after birth or 4 post-conceptional age, whichever was later. Neonates with birth weight more than 2 kilograms were also screened if they were under the high-risk category. The screening was done with the help of a binocular indirect ophthalmoscope with the help of a Krysik scleral depressor under topical anesthesia and dilatation. The retinopathy was graded into stages and zones as per the ICROP classification, and management was decided on the basis of the screening. The timing of the intervention was as follows. The stage 1 zone 1 ROP laser was given within 72 hours. Stage 2 ROP zone 1 laser was given within 24 hours. Stage 3 ROP zone 1 immediate anti-VEGF, and stage 4 anti-VEGF. In zone 2, stage 1 and stage 2 observed, the patients were observed. Stage 3 zone 2 patients laser or anti-VEGF when indicated. Stage 4 zone 2 ROP was referred for surgery, and no intervention was done in stage 2, stage 5 zone 2 and zone 3 ROP. In the cases of AP-ROP, immediate anti-VEGF injections were given. The anti-VEGF injections were given in operation theater under aseptic precautions. As the antibody binds to the VEGF inside the eye almost immediately, a rapid response was observed as compared to the laser. The laser treatment was done with the help of 810 nanometer red laser with the help of a laser indirect ophthalmoscope under aseptic condition. The avascular retina beyond the reach was ablated using the confluent medium intensity burns over one session. Topical antibiotics were given as and when required. The patients were followed for a period of 3 years for detailed ophthalmologic examination and management as per the need. The results, incidence of ROP in 208 high-risk infants was 77.88%. Moreover, ROP was also found significantly in infants weighing more than 2,000 grams or a gestational age more than 32 weeks when they had associated with high-risk scores as described above. The risk factors predisposing to ROP were oxygen therapy, intensive care admission with ventilation, continuous positive airway pressure, maternal eclampsia, eclampsia, use of blood products, apnea, septicemia, and multiple pregnancies. Out of the 162 infants who had ROP, 29.62% had ROP with zone 1 vascularization, 62.96% had ROP with zone 2 vascularization, and 7.40 had ROP with zone 3 vascularization. About the types of treatment, 114 were kept under the observation with close follow-ups, 22 needed anti-VEGF, another 22 needed laser intervention, and 2 were explained the nil visual prognosis. The timing of intervention, 12 out of 22 were treated on the presentation, 22 within 1 week. And for laser treatment, 8 of 22 were treated on presentation, of the 22 within 2 weeks, 2 of 22 between 2 to 4 weeks, and 8 of 22 after 4 weeks. So this is just a graphical representation of the result. Talking of the outcome, 21 out of 22 who were given injection anti-VEGF had a favorable outcome. 18 of the 22 of the laser photocoagulation had a favorable outcome, and 87 of the 114 who were kept under observation, a favorable outcome was noticed. So the ICROP classification was published in 1984, which described the terminology of ROP. In 2005, a second committee revised the original ICROP. The location of the disease was described in zones, that is zone 1, 2, and 3. Extent was expressed in clock hours of involvement, and severity was expressed in stages. That is, stage 1 is the line of demarcation, stage 2 is the demarcation ridge, stage 3 is extraretinal fibrovascular proliferation, stage 4 was partial RD, and stage 5 was total retinal detachment. Plus disease was a separate entity which denotes the presence of increased venous dilatation and arteriolar tortuosity with later signs of iris vascular engorgement, impaired pupil dilatation, and vitreous haze. The type of ROP was not initially mentioned in the ICROP classification, but it was based on findings from the ET-ROP study. So the type 1 ROP was a high-risk disease which requires urgent intervention. The zone 1 type 1 ROP is, the type 1 ROP was zone 1 any stage ROP with plus disease, zone 2 stage 3 ROP without any plus disease, or stage 2 or 3 ROP with plus disease in zone 2. Type 2 ROP was defined as a low risk ROP, that is zone 1 stage 1 or 2 ROP without plus disease, zone 2 stage 3 ROP without plus disease. So they can be kept under observation. Talking about the screening criteria, we considered all the high-risk preterm for screening where birth weight was not a strict criteria for the screening. As per the studies by Chaudhary and Chawla, yes, Pama.
Smith, you have already exceeded your time, so just wind up your results and discussion.
The main screening criteria which was basically used was the birth weight was not the strict criteria. So all the preterm babies or babies with more than 32 weeks of gestational age were screened irrespective of their birth weight or the gestational age, as the incidence of ROP in developing countries is more seen with birth weight more than 2000 grams. And that's the anti-VEGF injection and laser photocoagulation are the effective modality options for the control of ROP, and timely intervention is the key to success in ROP. That's the references. Thank you.
Okay, so what was the lacuna in literature which made you conduct the study?
It was just to compare the results with the laser and the injection anti-VEGF that we used to compare the results obtained with both of them. And we obtained similar results with both ROP as well as the injection anti-VEGF.
Was surgery done in any of your case?
No surgery was done. Most of the preterm babies.
Your stage 4A ROP having more than 6 clock hours of RD.
Yes. There were no babies with stage 4 ROP. There were no infants which fall under that screening criteria. Either the patients were kept under the observation, and many of them were explained nil visual prognosis, and no surgical intervention was carried out in any of them.
Okay. So I invite now the next speaker.
Dr. Divya Agarwal, who will be speaking on predictors of surgical outcomes of lens-sparing vitrectomy in stage 4A retinopathy of prematurity.
Good morning, ma'am. Am I audible?
Yeah, yes. You're audible.
Ma'am, are my slides visible?
No. Share your screen.
Good morning, everyone. I'm Divya Agarwal, Senior Resident RP Center. So I will be presenting my paper on predictors for surgical outcome in lens sparing vitrectomy in stage 4 of retinopathy of prematurity. So as we all know, stage 4A of retinopathy of prematurity is an advanced ROP disease for which surgical treatment is necessary. And there are very few studies in the literature in the world which have demonstrated success of vitrectomy or any other RD surgery in cases of 4A of ROP, in stage 4A of ROP. So regarding review of literature, very few studies have demonstrated success, and in those studies, not much have described about the predictors of success of lens sparing vitrectomy. So lens sparing vitrectomy is now one of the standard treatments in stage 4A of ROP. So the literature does not clearly distinguish between different stage 4A ROP presentations. As you all can see, these are all the presentations in which macula is on and there is partial retinal detachment. But you see here, in this case, there is extensive tractional retinal detachment, whereas in this case, there is a localized traction. So all of these have been clubbed together as single stage 4A ROP, and there is no study which have determined the predictors of stage 4A ROP. Also, most of the cases are referred late, and the causes of late presentation need to be ascertained. So I did a study to study surgical outcomes across entire spectrum with the objective of, primary objective was to study the predictors, and secondary objective was to study the reasons for occurrence or late presentation of stage 4A ROP. So we enrolled, it was a single arm prospective interventional study. So we enrolled stage 4A ROP babies who followed the strict inclusion criteria, and anyone who is unfit for general anesthesia or there is stage 4B or 5 ROP were excluded. So we included 45 babies, 65 eyes, which included our inclusion criteria, and all of these underwent lens sparing vitrectomy under general anesthesia. At the turn of final analysis, only 43 babies could be assessed. But mind you, this is the highest sample size in the literature of these number of eyes of which were operated for stage 4A of ROP. So baseline parameters in our case study series, it was zone 2 was much more predominant, and there was presence of plus activity. So plus was present in more than 50% of our babies. And importantly, around 15%, that is 9 out of 61 eyes, didn't receive any prior treatment. So this is a part of medical legal negligence on the part of ophthalmologist. So that is why the ROP progressed in those cases. As far as surgery is considered, lens sparing vitrectomy was done, and we did around 42%. Both the eyes were operated in the same time. So immediate sequential bilateral vitreoretinal surgery was performed, and most of the babies we could only achieve good outcome with single surgery, and only 19 eyes out of 61, that is around 30%, needed one more surgery. And most common indication of the surgery was vitreous bleed followed by persistent traction. So we determined the functional outcome as regressed or ROP sequelae and progressed, and we obtained around 65% cases the ROP regressed after surgery, stage 4A traction was released. In 25%, the eyes went into ROP sequelae, and in 10%, it only progressed to stage 5 ROP or stage 4B ROP. So our final post-operative outcome was whether macula is attached or detached, or whether there is any progression to stage 4B or 5 ROP. So as far as our functional outcome was considered, it was structural outcome. It was noted that 90% met with favorable outcome. So when we did a post hoc analysis, we found certain predictors which were associated with good or poor outcome. So as we can see, the gestational age more than 28 weeks, that is the babies who have more gestational age, are having a good post-operative outcome as compared to those who are born less than 28 weeks. Also, those babies who have got hemoglobin more than 10 have better outcome as compared to those who have less hemoglobin. And preoperatively, presence of plus disease is the single most important ocular predictor that if present shows poor response to the surgery. And as far as TRD location is considered, we found that inferior TRDs were found to have poor prognosis. And TRD extent less than 7 clock hours, as we all know, the less the amount of traction, the less will be the less will be the traction on the macula, and the more will be the post-operative success. So the TRD extent in which it is less than 7 clock hours was found to be having good post-operative outcomes. And 2 of the patients needed lensectomy because of extensive TRD and high TRD, retrolental TRD. So then in those cases, those 2 were associated with poor outcome. And we did around 21 resurgeries in 61 eyes, 33% we did resurgeries, but out of that, we saved around 80% eyes. So only 20% eyes had persistent retinal traction. So this was a representative case, a stage 4A ROP baby with gestational age 34 weeks. And you can see how well the retina is settled post-op 12 weeks. So we also determined the reasons for advanced ROP, and to our surprise, apart from late screening, no or late treatment were also the important causes for advanced ROP presentations. And the major reason for late ROP screening was not that it was not advised by the ophthalmologist. The main reason was that child were unstable. So in stage 4A ROP, we found that in our study group, the average amount of NICU duration of stay was more than 1.5 months. So 45 days to 50 days, the baby was sitting in the ICU, kept under observation, and therefore the child was unstable to get screened for ROP, and there was no in-house screening facilities in most of the centers. And also after that, due to unstable nature of the baby, the parents were poorly compliant to get the child to screening. And reasons for late treatment, mostly there are same, because the child was screened late, that's why he could not get treated in time, and also the child was unstable. So my conclusion is that lens sparing 25 gauge or 27 gauge pars plana vitrectomy has got good favorable outcomes in current management of stage 4A ROP. In our study group, we found around 90% favorable outcome, and these predictors such as bigger babies or preoperative hemoglobin more than 10 gram per deciliter or TRD extent less than 7 clock hours are suggestive of good outcome. So we can prognosticate the child and take up the child earlier for surgery, and also these can also help in prognosticating the outcome to the parent. And predictors for poor outcome are persistent plus disease, inferior TRD, need for lensectomy, and any postoperative complications such as posterior vitreous bleed or persistent traction. Thank you.
Okay, how was your study different from the previously described study, and what does it add to the literature?
Ma'am, previously described studies have maximum sample size of around 30 eyes, and they have all clubbed stage 4A ROP into a single entity. They haven't subgrouped it into on the basis of extent of tractional retinal detachment or presence of plus disease or localization of TRD. So these various predictors we have, first of all, we are the first study who have analyzed these all predictors. And we have also found in our analysis that some of these predictors are important in prognosticating the disease. So this lacuna is that these predictors were not previously described. And secondly, the reasons for late ROP presentation, because in West, surgical treatment for ROP is minimal because there the babies are treated much early. In our case, we get more of advanced ROP presentations, and we are one of the few centers who operate such babies in a large amount. So when we analyzed the reasons, we were quite shocked because the babies were late screened and there was late treatment. And the major reason was not that the ophthalmologist did not advise screening or the pediatrician did not advise screening. The reason was that child was unstable and the child had prolonged NICU stay for which he could not, or he or she could not attend screening.
Okay, it's a very nice presentation. So now we will move on to the
next presenter, Dr. Tanvi Gaonkar, who will be presenting on retropupillary iris claw lenses versus scleral fixated lenses using Goretex in children with large subluxations. Dr. Tanvi, please unmute.
Yeah, is my screen visible?
Yes.
Good morning, everyone. My name is Dr. Tanvi. I'm a postgraduate resident at Guru Nanak Eye Center, New Delhi. I'll be presenting a study of retropupillary iris claw lenses versus scleral fixated lenses using Goretex in children with large subluxation. So I have no financial disclosures. So management of subluxated lenses varies from optical correction in low grades of subluxation to lens removal and intraocular implantation in higher grades. The intraocular lenses that can be implanted include anterior chamber IOLs, iris claw IOLs, and scleral fixated IOLs. Now, the scleral fixated IOLs could either be sutured or it could be sutureless. The technique of sutured SF IOLs has evolved from the use of 10-0 Prolene in the past to the use of 8-0 Gore-Tex currently. However, there is paucity of literature which documents the safety of Gore-Tex in pediatric eyes. Also, there is no consensus on which of these techniques is the best for early visual rehabilitation in children. Hence, we did a study which compared the retropupillary iris claw IOLs versus sutured SF IOLs using Gore-Tex in children with large subluxations. And we also assessed and compared the IOL tilt in the two groups. So we conducted the study over a duration of 1 year in Guru Nanak Eye Center. 28 patients with large subluxations of more than 7 clock hours were randomly divided into two groups. Group A underwent retropupillary iris claw implantation and Group B underwent SFIOL implantation using 8-0 Gore-Tex. So our primary outcome was best corrected visual acuity in logMAR, and the secondary outcomes were assessment of IOL tilt, mean change in astigmatism, and the median operating time. We included all children in the age group of 6 to 18 years with large lead subluxations of more than 7 clock hours. We excluded all patients who had any gross anterior or posterior segment pathology or those who had any gross anterior segment trauma. So this was a surgical technique in Group A. Just a second. So we marked the cornea at two diametrically opposite points at 3 o'clock and 9 o'clock, followed by a pars plana lensectomy and vitrectomy. This was the iris claw IOL that we used, and the arrow showing the claw mechanism into which the iris tissue was enclaved. A superior clear corneal incision was created, and the iris claw was inserted into the anterior chamber along its shortest diameter. Once in the anterior chamber, it was rotated horizontally. It was slipped posterior to the iris and enclaved in the mid-peripheral part of the iris using a Sinskey hook. This is the photo at the end of the surgery showing slight pupil ovalization and a patent peripheral iridectomy. In Group B, we marked the cornea at two diametrically opposite points, followed by the creation of 4 sclerotomies, 2 on each side. So 2 sclerotomies were created, 3 mm from the limbus and 5 mm apart. And so also done on the other side. This was the SFIOL that we used, showing 4 eyelets. A Gore-Tex suture was used, which was cut into half, and each half was threaded through the adjacent eyelets on either side. Once this was done, a clear corneal incision was created, and the suture ends were externalized through the corresponding sclerotomies. Once this was done, we placed the IOL into the anterior chamber, and after ensuring adequate IOL centration, we tied the sutures on either side. So we observed that at the end of 3 months, the best corrected visual acuity was better in Group B as compared to Group A. However, it was not statistically significant. We measured the IOL tilt at the end of 3 months using the ultrasound biomicroscopy by a method described by Loya et al., in which we measured the distance between the iris pigment epithelium and the IOL in both the vertical and the horizontal meridia. And if the difference was found to be more than 100 microns, the IOL tilt was considered to be significant. So we found that at the end of 3 months, Group B had a higher number of IOL tilts as compared to Group A. However, this difference was not statistically significant. There was a significant change in the post-operative astigmatism from the pre-operative value in both the groups. However, on comparison, this change was not significant. And the median operating time showed a statistically significant difference between the two groups, with Group B showing a mean operating time of 90 minutes as compared to Group A, which had 40 minutes. So these are the pre-op photograph of Group A showing a superior subluxation. Post-operatively, we can see that these are the enclavation sites where the iris claw IOL has been enclaved into the iris with a patent peripheral iridectomy. And this is the corresponding UBM image of the patient showing a well-centered IOL. This is in Group B showing a subluxated with a cataractous lens. Post-operatively, we can see that the IOL is well-centered, and we can see on the corresponding UBM image as well. So the choice of IOL to be implanted in children is a challenge, as early visual rehabilitation with minimal complication is the ultimate goal. So if you look at the complications of the two groups, retropupillary iris claw IOLs can either have spontaneous disinclination, pupil ovalization, or pigment dispersion in secondary glaucoma. Among these complications, we had 8 out of the 14 patients in Group A having pupil ovalization, but this was not vision threatening. Similarly, SF IOLs have an increased intraoperative manipulation, especially at the vitreous base. Therefore, they are known to have complications like retinal detachment and suprachoroidal hemorrhage. An IOL tilt can occur, especially in sutured SF IOL techniques. And there can be suture-related complications like suture breakage and suture degradation, which is responsible for late IOL dislocations. Among our patients, IOL tilts were noted in 4 out of the 14 patients. However, the rest of the complications were not noted. If we compare the advantages, retropupillary iris claw IOLs are technically simpler with lesser complications and an earlier visual recovery. On the other hand, SFIOLs are a time-tested method. They're not dependent on the integrity of the iris tissue. Hence, they can be implanted in conditions like aniridia, traumatic mydriasis, or areas of iris atrophy. Also, compared to retropupillary IOS, SFIOLs are placed in a more physiological position. So I would like to conclude that both the techniques provide good visual rehabilitation and IOL stability in children with large subluxations. However, retropupillary iris claw IOL being technically simpler and has a lower operating time. Therefore, we can recommend it in subjects with high risk of retinal detachment, like Marfan syndrome, high myopia, and the presence of peripheral retinal degenerations. Thank you.
Okay. So, what is the take-home message in your study?
And the take-home message is that when we compare these two, now, ma'am, there is a lack of studies which have given us a general conclusion of which IOL is to be used in children. So in our study, we found out that retropupillary and SFIOLs both are comparable in children. And SFIOLs, although they are known to have more complications, our study did not show any such complications because we had a thorough preoperative fundus evaluation of these patients. Many of our patients were Marfan syndrome, homocystinuria, were already predisposed to retinal detachments because of their genetic basis. So we did a very thorough fundus evaluation, and some of our patients also had some retinal degeneration. So they were well lasered prior to the surgery. So hence we found that the complication rate in both the groups was almost equal and that they are comparable in children.
So you advise any of these lenses?
Sorry, ma'am?
So you advise any of these lenses?
Ma'am, I advise both of them are equally efficacious in children, according to our study.
Okay, so no ACIL was used in any of the...
Ma'am, we did not use ACIOLs. There are certain studies which show that ACIOLs are also beneficial in children, but there are certain studies which show that they are associated with long-term complications. So, ma'am, we had not used ACIOLs.
But your age was inclusion criteria for the age was up to 18 years.
Yes, ma'am.
So children, like it's teenagers, it's not children that, I mean, the age group was little on a higher side.
Yes, ma'am.
What were the limitations of your study?
Ma'am, the limitations of our study was a short follow-up period. We followed up the patients only for a period of 3 months. So complications like suppose significant IOL tilt or decentration or dislocations were not noted at the end of 3 months, but we need a longer follow-up period for such a condition. Also, retropupillary iris claws are known to cause pigment dispersion in secondary glaucoma. So at the end of 3 months, it is not possible to comment on that.
But nice photograph with the UVM. It's well nice study. Okay.
Thank you, ma'am.
We move on to next topic.
Move on to the next presenter, Dr. Vaidehi, who will be presenting on pinealoblastoma or malignant neuroectodermal tumor in a known case of alternating exotropia with high hyperopia in a 6-year-old child.
I need to share my screen.
Yeah, share your screen.
Yeah, this one second. I'm having some. Is it visible?
Yeah.
Okay, good morning, everyone. I am Dr. Vaidehi Sathe, resident DY Patil Hospital, Navi Mumbai. I'll be the presenter, and the co-authors are Dr. Harsha Pagad and Dr. Neeta Shanbag. My topic for today is pinealoblastoma or malignant neuroectodermal tumor in a known case of alternating exotropia with high hyperopia in a 6-year-old male child. So the aim of this paper was to highlight the remote possibility of a space-occupying lesion in the brain in children already diagnosed and following up for squint with refractive error and who present with recent onset headache. So in introduction, headache is the most common somatic complaint in children. Sorry, is the screen sharing still on?
It's on, but it's not on full screen mode.
Better?
Yeah.
Headache is the most common somatic complaint in children. Evaluation will include a detailed history and a detailed general ophthalmic and neurological examination. Classification of headache by the International Headache Society is primary and secondary. Primary headaches include migraine headaches, tension headaches, and cluster headaches. Secondary headaches could be idiopathic in nature due to structural anomalies, any metabolic changes, or other abnormalities. Now, in pediatric patients, red flags for when they complain of headaches would be any complaints of worst headache of the patient's life, any recent onset headache, any increase in severity of an existing headache, a headache that would awaken a patient from their sleep, morning headaches associated with severe vomiting, and headaches which increase on straining. Coming to the case, a 5-year-old male child presented to our OPD with history of outward squinting of right eye noticed since 6 months, 1.5 years ago. On examination, the child was not cooperative for vision. Hirschberg test showed a 15-degree right eye exotropia. Alternate cover test showed freely alternating exotropia of 15 degrees. Extraocular movements were full and free. Cycloplegic refraction revealed a +6 diopter sphere and a -2.5 diopter cylinder at 180 degree in both eyes. Dilated fundus evaluation was within normal limits. So the child was given glasses and was asked to review after a month for reassessment of the vision and the squint. In the 9-gaze photo, you can see that there is a right eye 15-degree exotropia with no discernible A or V pattern. But the child followed up 1 year later. On presentation, vision with Snellen's chart in both eyes with glasses was 618. Prism bar cover test was 30 prisms Bayesian for distance as well as near. Extraocular movements were full and free. Fundus examination was normal. And cycloplegic refraction was the same as the last time. So the child was asked to continue the same glasses and the parents were explained about the need for surgical correction of the squint. But they did not follow up soon and they came back only 5 months later. On presentation, the mother said that the child was complaining of new onset of headache associated with vomiting and eye pain, which was more in the morning. So on examination, vision with glasses was 624 in both eyes. Pupils were central, circular, and reacting to light in both eyes. Color vision on Ishihara's chart was 16 by 16 in both eyes. And fundus examination did not reveal any papilledema. So the child was asked to get a CT brain orbit and to review with the reports with the pediatric department. Now again, the patient didn't get a scan done soon and neuroimaging was only done 2 weeks later. On neuroimaging CT, it revealed findings suggestive of a heterogeneously enhancing mass lesion in the region of the pineal gland and posterior third ventricle, splenium of corpus callosum, and the adjacent parafalcine left parietal lobe, with nodular foci of central calcification within that were causing obstructive hydrocephalus with periventricular ooze. Findings were suggestive of neoplastic etiology, possibility of a pinealoblastoma or a germinoma. Fundus examination at this point revealed early papilledema in both eyes with splinter hemorrhage in the right eye. So the child was then referred to the pediatric neurosurgeon for further evaluation and management. So now what are the challenges we face in children? Since we depend largely on the parents' history and observation, the history can often be limited. And there is no role for routine neuroimaging in primary headaches. So a detailed history with sufficient time and patience will help us to reach the diagnosis of these space-occupying lesions, which could be life-threatening, with the aid of neuroimaging in children. So in conclusion, intracranial tumors are the second most common type of neoplasm that we see in children, and they can present as secondary headache. So a meticulous history coupled with a high degree of suspicion and timely neuroimaging can help in the early diagnosis of these life-threatening lesions. So any pre-existing squint or refractive errors should not deter the pediatric ophthalmologist from further investigations in a child presenting with some fresh complaints. Thank you.
Okay. So did you check for?
Yes, ma'am.
Did you check for the, squint? Orthoptic evaluation was done when the patient was, can you stop sharing your screen?
Yes, ma'am. Yeah.
So, did you do a orthoptic examination when you diagnose the patient with pinealoblastoma?
At that point, since already the time had become late, like 5 months already had passed. So after that, once we referred the patient to the pediatrician, the child never followed back.
No, when you referred the patient, or when the patient came with headache, did you do an orthoptic evaluation?
Yes, ma'am.
So was there any abduction deficit or something like that was there?
No, at that point, there were no restrictions in the extraocular movements. And the 15-degree exotropia was the same as last time. So there were no changes in the values of the deviation, even on PVCT.
What was the age of it? Was the child?
When he presented to us, he was 5 years, and over the
5-year child will present, because you told in your presentation that patient presented with exotropia for the last 6 months.
Yes.
So the patient did the patient give history of any diplopia in the beginning?
No history of diplopia, and the history was given by the parents. So the child never, they didn't give history of diplopia. No.
So your hyperopia along with the squint was just an incidental thing which was there, right? It was nothing related with the pinealoblastoma.
No. That diagnosis came later. That prompted us to then advise neuroimaging, because the headache did not. It was a recent onset headache. That is why we advised neuroimaging for this.
But your headline says that pinealoblastoma in a case of exotropia. The exotropia has nothing to do with the pinealoblastoma.
No.
Yeah. Okay, we can go to the next presentation.
The next presenter is Dr. Pawan, who will be presenting on congenital primary aphakia.
Good morning, everyone. Am I audible?
Yeah, you are audible and your screen is visible, but your
This is off. Okay.
video is not.
Video and audio is audible?
Everything is perfect. You can go on.
Okay. Good morning, everyone. I'm Dr. Pawan Garde. I'm a resident in MNG Institute, Ahmedabad, and I'm presenting my case of congenital primary aphakia with my co-authors of Dr. Kalpit Shah and Dr. Chandra Chaudhary. So aphakia is complete absence of crystalline lens in the piriform fossa, and it can be either congenital or acquired. Congenital aphakia is described in two forms, basically primary and secondary. So what were the materials methods? We took a proper clinical history, slit lamp biomicroscopy, refraction, fundus examination, and B-scan ultrasonography was done for this patient. So the case one, a 7-year-old male child presented to us with a history of diminution of vision in right eye since birth and history of deviation in the right eye since 6 months. There was no other significant ocular history. Patient also had difficulty in listening and speaking, and he had undergone some ear surgery 1 year before, the papers of which were not available. There was also a history which was suggestive of developmental delay in the child. There was no significant birth history, and there was no history of any consanguinity in the parents of the child. On examination, patient was uncooperative for visual acuity examination. The both eye cornea were clear, pupils were reacting to light. On orthoptic examination, cover test showed right eye to be an exotropia of around 20 degrees with hypertropia. Eye movements were full with horizontal rotatory nystagmus. The patient was dilated with hematropine 2% and refraction was done. These were the refraction results in the both the eyes. As you can see, there was almost plus 13 this in the right eye. On fundus examination, both eyes were within normal limit. The fixation of in the right eye was absent, whereas the left eye had central steady and maintained fixation. So when we examined the child on the slit lamp, we saw that there was absence of the lens and there was posterior capsule, but it was not completely formed, but it was just a remnant of the posterior capsule. So the diagnosis of aphakia with remnant posterior capsule was made. The patient was operated for posterior temporal IOL with a good post-operative result. This was the first case. Then we had a second case in another 3 months where a 7-month-old child was presented with a complaint of white reflex in the center of both of the eye since birth. Initially, the patient was diagnosed as a congenital cataract and was referred to us. There was no history of trauma, foreign body, or any ocular surgery. He had history. The baby had a history of congenital heart disease, which was bilateral optimum secundum and mild valvular stenosis, and bilateral mild pulmonary artery stenosis with moderate sized patent ductus arteriosus. Birth history was insignificant. There was no history of any consanguinity, and the baby did not have any history of NICU admission as well. On examination, patient was uncooperative for visual acuity assessment. Patient had white reflex in both eyes with rest anterior segment being normal. The patient was dilated with metropane and refraction was done. These were the refraction results. The remnants of the anterior and posterior capsules were found to be covering the pupillary area, giving the white reflex. Central fundus of both the eyes was within normal limits. There was no crystalline lens found in both the eyes on B-scan ultrasonography. Based on the findings, patient was diagnosed with aphakia. Patient's relative refused for the surgery and patient was prescribed with aphakic corrective glasses. So coming to discussion, there are two forms of congenital aphakia have been described. The primary aphakia, the lens placoid fails to form from the surface ectoderm in the developing embryo. And this can be diagnosed if a proper prenatal ultrasound is done, because around the 27th day, the lens placoid starts forming. The secondary aphakia, the more common type, is the developing lens is spontaneously absorbed. So there might be some lens metals remaining, but the fully formed lens is not present. Both the forms of aphakia are usually associated with other malformations of the eye, such as aplasia, dysplasia of the anterior segment, microphthalmia, aniridia, retinal dysplasia, or sclerocornea. All these other associations are not present in our cases. Congenital primary aphakia results from early developmental arrest around 4th to 5th week of embryogenesis, prevents the formation of majority of lens structures. In previous some studies, FOXE3 gene has been identified in the affected individual, and prevalence is found to be 1 to 5 in every 10,000 live births. So, which is a very rare thing. And so in some studies, they have described it as autosomal recessive. So my take-home message is early identification of treatment of such cases can really go a long way in helping the child to see better and help in his visual rehabilitation and prevent complications like stimulant deprivation, amblyopia. These are my references. Thank you.
Okay, can you show me the reflex, white reflex, which we're talking again? White reflex, and why was there a white reflex there?
Ma'am, in this, when the patient had pupil, the non-constricted pupil, it had a white reflex, ma'am. No, here I have a dilated picture, so I do not have the picture of the white reflex as such.
Okay, was genetics done in your patients?
Ma'am, the patients refused for the genetic study because it almost cost around 5,000 rupees and the patients were not from affording background.
Did you do any family pedigree?
Sorry?
Did you do any family pedigree?
A family pedigree was done, ma'am, but it did not have any significant this to the study. It did not show. It was a routine study, not have any significant.
Was UBM done in your case to show the absence of lens and?
Yes, ma'am. UBM was done in our cases.
So you have not shown any pictures?
No, ma'am. The record was I did not get that records while making this presentation.
All the other structures were normal?
Yeah, all the structures were normal. As I said, ma'am,
You have
the
shown it in your presentation.
sorry.
You should have showed in your presentation.
Yes, ma'am. Yes, ma'am. That one B scan and UBM was missed from my presentation. So,
Okay, we move. I think we have one more.
The
We have
presenter
finished.
was absent. He has joined back, Dr. Robin Jain.
Okay.
He will be presenting on study of incidence and risk factors of ROP in a tertiary care newborn unit in central Gujarat.
Yes, hello, ma'am. Hello, good afternoon, ma'am.
Good afternoon. Switch on your
Am I
camera.
audible?
Yeah. Share your slides and switch on your
Yes.
camera.
Hello, ma'am.
Yeah,
My
you're
slides are
audible.
visible?
Yeah, your slides are visible.
Yeah, okay. Good
Put on
afternoon.
full screen.
Yeah, good afternoon, everyone.
Go to full screen mode, bottom right.
Yes.
Bottom right.
Bottom right. Okay.
Yes. And turn on your video. Yes.
Yes, is it on? It is on, right?
Yeah, it's on.
Yeah,
Go ahead.
hello. Yeah, my topic is study of incidence and risk factors of retinopathy of prematurity in a tertiary care newborn unit in central Gujarat. The retinopathy of prematurity was also known as retrolental fibroprasia by Terry in 1952, who related it with premature birth, and the term was coined by Heath in 1951. It is the disorder of development of retinal blood vessels in premature babies, and the normal retinal vascularization happens centrifugally from optic disc to ora serrata, and the vascularization of nasal ora is completed by 36 weeks and the temporal by 39 to 41 weeks of gestational age. And then the incidence of ROP in India is increasing because of the improved neonatal survival rate. Out of 26 million annual live births in India, approximately 2 million are less than 2000 grams in weight and are at risk of developing ROP. In India, the incidence of ROP is between 38 to 51.9% in low birth weight infants. So the screening guidelines are, according to the American Academy of Pediatrics, the guidelines are infants with birth weight less than 1500 grams, gestational age of 30 weeks or less, infants with birth weight between 1500 and 2000 grams, or gestational age 30 weeks with unstable clinical course. And in Indian scenario, the screening guidelines, which are the birth weight less than 1700 grams, gestational age at birth less than 34 to 35 weeks, and duration of oxygen exposure. Infants born in less than 28 weeks and weighing less than 1200 grams are particularly at high risk of developing severe form of ROP. And also it includes the presence of other factors such as respiratory distress, sepsis, multiple blood transfusion, birth defects, multiple births, then apneic episodes, interventricular hemorrhage, increase in the risk of ROP. In these cases, screening should be considered even for babies who have more than 37 weeks of gestation or birth weight is more than 1700 grams. First screening should be of gestation, and screening should be done earlier. It can be done. Hello.
Yes, you're
Hello.
Hello.
You are audible.
Yeah,
Go
yeah.
ahead.
Screening should be done earlier, within 2 to 3 weeks if the gestational is less than 28 weeks or the birth weight is less than 1200 grams. And in this, the screening should be done by a well-versed ophthalmometrist, and also use indirect ophthalmoscopy. And ideally the child should be fed 1 hour prior to the examination. And we use 1% tropicamide and 2.5% phenylephrine combination for pupillary dilatation, and we use it in interval of 10 minutes for 3 times. Then few conditions like punctal occlusion should be done mandatorily after installation of the drops to reduce the systemic side effects, and the excess drops should be wiped out to prevent it from it getting absorbed by the cheek skin and producing symptoms. It also results in development of tachycardia or hyperthermia of the baby if proper care is not taken. And if the pupil is still not dilating, we should suspect plus disease. Repeated installation of topical drops should be avoided to prevent the systemic problems. And sterile Alfonso speculum is used to retract the lids and the wire vectors for gentle depression. So the inclusion criteria in this study was gestational age less than 34 weeks, birth weight 1750 grams less than, then high risk babies who were already on oxygen supplementation, respiratory distress, convulsion, anemia, septicemia, pneumonia, hyperbilirubinemia, and hypocalcemia. Infants with ROP was recorded in these categories. Then the retina consultant had screening all the infants and with proper technique and care. And this study was conducted between March 2019 and December 2019. And the time and diagnosis and the stage of ROP with risk factors were recorded. So in this, we found out that a total of 484 eyes of 242 infants in NICU were examined, and out of that, 38 infants with ROP, and we got an incidence of 15.7% in this study, and there was no significant age gender predilection here. And infants with ROP that comprise of less than 1000 grams were 32%. Maximum was between the range of 1000 and 1500 kilograms. Then between 1500 to 715 grams, it was 18% incidence. And the mean age was 31 weeks, and the range was 27 to 34 weeks. The infants who were for the requirement of laser treatment were approximately 28 weeks with a range from 26 to 30 weeks. And the incidence was seen more in zone 3 than zone 2. So the comparative study. Less than 1000 grams, it was 32%, 1000 to 1500, 50%, 15 to 1700, 18%. Stage 1 was 18.4%, stage 2, 45%, maximum was in stage 2 category. Then stage 3, 26, and stage 4 and 5, 15%. And there was 48% male and 52% females. In discussion, severe ROP is a life-threatening condition if untreated leads to permanent vision loss with personal and professional problem. In India, it was average 1 in 1000 children are blind, and the incidence of ROP is reported to be quite high, around 50%. But in our condition, it was 15.7%, maybe due to the better reporting. The patients who reported here were of higher socioeconomic group with better facilities for delivery and antenatal care. So this is an urban institute, and which is caters to the urban population with low to average income group. And as a result of these factors, many infants born in this facility presented with less prenatal risk factors and subsequently an overall low incidence of the disease. The guidelines should be recommended, which is weighing less than 1700 grams or presenting less than 34 weeks of gestation. The infants with other risk factors should also be screened properly. And the most common age range for was 15,000 to 1500 grams. So our data also demonstrate that if the American guidelines were used for screening of ROP, then many of the cases would go undetected. So there is need for more utilizing the Indian data and then coming up with a better criteria. Also, some studies suggest that if antenatal steroids are used in more frequency, then it decreases the severity of ROP. So the comorbidities among the study population that had ROP, in which we found out that maximum was linked to RDS and apnea of prematurity. Then it was prematurity itself, and then it was sepsis, hypoglycemia, and seizures.
Your time
With
is already
the duration of
expired, so just sum
oxygen
up your
therapy.
slides.
That were the major. Yes, sir. Yes, ma'am. So we found a greater incidence among the ROP babies with comorbidities of oxygen with RDS and apnea, and then hypoglycemia, seizures, and who were exposed to the oxygen therapy. This was the finding which showed more significance of these following risk factors. And also there is a need for better screening guidelines, or also better interpretation for ROP. Yes, ma'am. Thank you.
So, with so much of Indian literature already present, what is the clarify the relevance of your study in this present context?
Yeah, because still in the tier 2 and tier 3 cities, ROP is generally not, many times pediatricians just don't refer to the ophthalmologist for ROP studies. Likewise, we also here also it was like a few years ago, there was almost very less references to the ophthalmologist for ROP screening. And overall, since the better NICU facilities are upcoming, more preterm babies are surviving, and I think we are having more number of cases of ROP. So it is better to be screened in a much larger scale.
Okay, does your study add anything new to the current literature?
Almost the similar findings only, although it compares the comorbidities of sometimes here, like here we found more relation to duration of oxygen and apnea. So in some other studies, it is different incidence rates.
What was the limitation of your study?
It was a spot study, so all the babies who were in NICU were screened basically.
In methodology section, you should have written it like a methodology. You should not have discussed it. What should be done? It should be written in a format ki what you did. Okay, that should be taken care of. Okay, I thank all the participants for the we'll give the marks. We'll send the marks. So.
Thank you all the participants and Dr. Shweta, thank you. With this, we are concluding this session.
Thank you.
क्या कर रहे हैं ऑटो?
Good afternoon, everyone. Welcome to all the participants and our esteemed judges, Dr. Abhishek Dave, Dr. Srilata, and Dr. Sandeep. Ma'am, can we start?
Sure. I think if the presenters are here, we should start our session.
Yes, ma'am. So the first speaker with us is Dr. Shailendra Batham, who will be speaking on acute visual dysfunction following phenytoin-induced toxicity.
Hello?
Yes, you're audible.
Okay, my video isn't starting because the host has stopped it.
No problem. You change it to full screen mode, the screen, and you can go ahead.
Full screen mode. I have to share my screen.
You have already shared your screen. Just go to bottom right, change it to full screen mode.
Okay.
Not there, left. Yes.
Like this?
Yes.
Can I start?
Yes.
Okay. Hello and good morning to all judges of 2020 Annual DOS Conference organizers for providing me a public platform to discuss my case today. Topic of the case today is acute visual dysfunction in an 18-year-old patient following phenytoin-induced toxicity and presented by me, Shailendra Batham, Junior Resident Ophthalmology, Non-Induction by Medical College, Jhansi. In the outline, we will discuss case history, examination, both systemic and ophthalmological, management, and possible clinical course. The patient we have hand is an 18-year-old female patient who is referred to our site from Department of Internal Medicine as a case of Stevens-Johnson syndrome following acute phenytoin toxicity, given her ocular involvement after having a severe reaction to her anti-epileptic treatment, presented with chief complaints of blurred vision, redness in both eyes, swelling around the eyes, cracked lips, and rash on body and face. She had a 3-year-old history of seizures previously managed by herbal medication, with last known episode about 1 month back, for which she was advised oral phenytoin, and she presented 15 days later with maculopapular rash with crusting over face and extremities comprising about greater than 70% of the body, hemorrhagic eruptions over lips and oral ulcers, and diffuse conjunctival congestion in both eyes. Upon medical and personal history, she had no history of diabetes, hypertension, family history, social history, and past ocular history were not contributory. She had history of no allergies or any adverse drug reaction in past. She had no history of any addiction or substance abuse. On physical examination, patient was fully conscious and oriented, normal height, weight, BP, pulse rate, and SpO2. She had maculopapular rash over the body and extremities with hemorrhagic lesions on lips with perioral edema. Rest systemic examination was within normal limits. On lab investigations, she had mild alkalosis, mild eosinophilia. Patient was also anemic. She was non-reactive for HIV, HCV, and HBsAg. Serum phenytoin was found to be 17 microgram per ml. Rest was within normal limits. On ophthalmic examination, patient has a visual acuity of right eye 20 by 125 and left eye 20 by 60. On slit lamp examination, she had a mild anterior blepharitis in both eyes. Conjunctiva has a mild diffuse injection of bulbar conjunctiva in both eyes with adherent bulbar and palpebral conjunctiva membranes laterally, with mild inflammation near lateral canthi bilaterally. Cornea had diffuse corneal edema with superficial stromal infiltration, staining positive with fluorescein, with fine punctate corneal epithelial defect involving 80% of the right eye. Anterior chamber, iris, lens, and anterior vitreous was within normal limits. This picture shows the examination of the patient in diffuse ocular examination. Color vision was within normal limits. On dilated frontal examination, she had a clear disc margin and peripapillary area in both eyes, increased CD ratio in both eyes with normotensive pressure in both eyes. Foveal reflex was normal with normal vessels and periphery. On the basis of clinical findings and examination, we came to a differential diagnosis of following as Stevens-Johnson syndrome, immunodeficiency states, HIV infection, toxic epidermal necrolysis, alcohol and substance abuse, post-herpetic rashes. On follow-up of patient, the diagnosis was phenytoin toxicity-induced SJS with ocular involvement with simlifron in both eyes. On medical management, phenytoin was completely stopped. She was put on IV levetiracetam 500 mg 12 hourly for seizures, IV methylprednisolone 1 gram OD initially for 3 days, followed by oral prednisolone 1 mg per kg per day tapered doses for skin and perioral lesions. Tablet hydroxyzine 25 mg HS was given for supportive management. For ocular management, she was administered moxifloxacin topical eye drops 4 times a day, carboxymethylcellulose gel 6 times a day, ointment tobramycin and pantothenic acid gel 3 times a day, and along with oral antioxidants and multivitamin supplements. On follow-up after 15 days, visual acuity was improved along with ocular symptoms. She had clear cornea in both eyes, but still persistent simlifron with requiring surgical correction at a later date, and facial and perioral lesions have subsided with residual crusting of lips present. As we discussed, visual acuity of the patient was improved to a right eye having a visual acuity of 20 by 32 and left eye with 20 by 25. On discussing clinical course, the phenytoin toxicity usually causes long-term ocular side effects like dyskinesia, nystagmus, ophthalmoplegia, blurred vision, disturbed color perception, but can also cause acute dysfunction, visual dysfunction following phenytoin-induced SJS. Severe sequelae of corneal damage in form of scarring or limbal stem cell failure is the most severe ocular outcome. Conjunctival scarring may cause chronic microtrauma with blink reflex, while simlifron can lead to poor film dynamics and severe dry eye contribution to corneal pathology and subsequent visual impairment. There is evidence that early surgical treatment with amniotic membrane can lead to improved ocular outcome. As we found out that phenytoin may cause acute visual dysfunction as a previously unknown phenomena. For higher doses at prolonged period can cause toxicity manifestation, but toxicity can manifest within days. Signs of phenytoin toxicity manifest as 15 microgram per ml. Our patient had 17 microgram per ml. Where in the further treatment of the patient, toxic effects are reduced by withdrawing and reducing the drug dosage and replacement by a non-aromatic anti-epileptic drug. As for all patients, close monitoring of serum phenytoin level with early drug cessation and conservative management is essential for a favorable outcome and speedy recovery. Thank you.
Thank you, Dr. Shailendra. Judges would make make some comment, please.
Okay.
Dr. Shailendra, I want to know, why did you label these cases because of phenytoin toxicity? Because Stevens-Johnson doesn't necessarily have to happen with toxicity. Even at normal dosing, a patient can develop a Stevens-Johnson syndrome. And
yes, ma'am. But our case had a history of herbal medication which changed to phenytoin, and the SJS and ocular symptom developed because of the toxicity caused by the phenytoin.
Would you still label it as toxicity, or because it was a normal dose that was given and that causes Stevens-Johnson's? It wouldn't be called as toxicity. That's what I'm trying to kind of rephrase it probably.
Truly, the phenytoin toxicity develops over a prolonged period after chronic taken by a patient. But in this case, the manifestation of the toxicity, much like the adverse drug reaction, occurred within a month of period after commencing the treatment.
All right. And I hope the patient is going to be on long-term follow-up, because Stevens-Johnson syndrome, it's not that it has a presentation only in the acute phase, because as we all know, as you mentioned, the patient develops simulation.
And so patient presented to our OPD during the early months of this year in February and March. After that, the COVID lockdown was implemented and the patient did not come out for follow-up. Once or twice she contacted by telephonically, and she was advised to continue her treatment for the same and contact whenever she was able to for further surgical management.
All right, that's it. Thank you.
Okay, ma'am.
Thank you, Dr. Shailendra. Please stop your screen share.
Okay.
I request all the participants to strictly adhere to your time limit of 6 minutes for the presentation and 2 minutes each after the discussion. I now invite Dr. John Sarkar. He will be presenting on melted by molten metal but can be salvaged.
Am I audible?
Yes, yes.
Yeah, I'm just sharing my screen. Is the sound is audible? Sound is audible?
Sound is audible.
A very good evening, morning to all of you. I'll be present. Am I audible?
You have not started your screen share.
Yeah, I will share. No, I'm sharing my screen.
It has not come yet.
One video actually is a video presentation. Is it? Yeah, I've already shared it.
Not running.
Is it?
A blue background has come, but it's not running.
Is the videos running?
No.
1 minute. Just give me 2 minutes. Is it visible?
No, no, no.
1 minute. Just why? What is the problem? I'll share my screen. Can you see my presentation?
No, no, no.
Is it visible?
No, it's not visible.
Dr. Shohini, is it visible?
No, 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 it's not visible. It's not visible.
Just give me 1 minute.
Dr. John, have you tried playing the video? Because we can see your screen, but the video, of course, is not yet playing.
What is that problem?
The DOS team members will be helping you shortly.
Is it now?
Yes. But it's not running.
Sorry?
It's not running.
Have you
Yes.
seen?
Yes, yes. Now it's
Can you see?
running.
Hello?
It's running.
Sorry?
The video is running.
It's running? Sound is coming?
Sound is not coming, only the video we can see.
1 minute. Now the sound is coming?
No.
Now the sound is coming?
No, no, no. Is there some audio background with this?
Yes, audio background is there.
It's not coming.
Can you ask the technical team to help me?
I have already asked them. Can we move on to the next speaker? Till then,
Yeah, that's it.
please stop your screen share. I now invite Dr. Kanika Bhardwaj, who will be speaking on porphyria, look beyond the eye.
Very good morning. Is my is my slide visible?
Yes, you can go ahead.
Good morning, one and all. Today I will be presenting on porphyria, look beyond the eye. My name is Dr. Kanika Bhardwaj. I'm a resident from Eye Care Eye Hospital and Postgraduate Institute, Noida. So a patient, 25-year-old male, presented to us with complaints of redness in his left eye from past 15 days. His visual acuity in right eye was 6/9, and in left eye, the affected eye was 6/12. As far as the patient gave us history, there were no other known systemic illnesses as of then. In his left eye, on examination, we saw there was a scleral necrosis patch about 3 into 4 millimeters dimension radially. There was avascular scleral necrosis, and there was surrounding inflammation and vascularization, and overlying the scleral necrosis were discharge and debris. So we presume that the scleral necrosis in a country like ours, it can be most probably it can be infective, but there can be non-infective causes and there can be other not mentioned causes as well. So the infective causes commonly, as we know, can be leprosy, tuberculosis, syphilis, sarcoidosis, and many more. Non-infective autoimmune causes, which are more commonly seen, are rheumatoid arthritis. They can be vaginal, they can be relapsing polychondritis, or even systemic lupus erythematosus or polyarthritis nodosa. However, there are other diseases also which are not that frequent in causing such symptoms like graft versus host disease or even porphyrias. So in our patient, when we investigated further on his clinical workup, we could see that he had lag of thalmus in both his eyes. There was scleral thinning and necrosis in left eye along with discharge. However, both the eyes, the lens was clear and the fundus was within normal limits. On general examination, we could notice that the patient has leonine facies. He had very mottled skin of his face and indurations noted. Scraping was done for the necrosis and discharge, and sample was sent for microbiology. The smear, which reported as gram-positive cocci, and there was no other organism noticed. On the anterior segment OCT, it confirmed marked scleral thinning, but there was no uveal exposure. So, assuming this as a scleral necrosis, we started the patient on fortified cefazolin eye drops 1 hourly, along with lubricants, which were preservative-free, and oral doxycycline 100 milligrams BD. Day 3 after starting the treatment, we could still see there was scleral necrosis and surrounding vascularization. However, the overlying discharge and debris had subsided and disappeared by day 3. Now, the question was that though the discharge had disappeared, was it just an infectious status? Here, I would like to mention that we should not miss the forest for the trees. While just focusing on a few important presenting features, we should not miss upon the general things which are there. So we also examined the patient's right eye. The right eye cornea was clear. However, there was a patch of scleral thinning, maybe because of a previous similar episode in his right eye. However, there was no scleral patch, but there was no uveal exposure noted. So we then confirmed and asked the patient further history. He also showed pigmentary changes and there was this saddle nose deformity. We could see also cartilage changes and on repeatedly asking the patient again and again, he finally disclosed that his urine color was a different color. It was some dark orangish in color. Based on this and his general findings, here we can see the resorption of distal phalanges. So based on these findings, we sent the patient for a dermatology review, thinking that maybe it may be leprosy. However, it was discarded by the dermatologist. And we also were thinking of relapsing polychondritis because of the ear cartilage changes that we observed. and that was also discarded based on the blood investigations. So basically, the patient was diagnosed as having phototoxicity also, and he had this history of urine changing color and becoming dark orange. So the patient also went for systemic review at LNJP, though people at LNJP hospital confirmed it was a phototoxicity induced and hence porphyria. However, the reports were not shared with us. So the patient was then started on oral and topical steroids, and the scleral thinning was carefully monitored. The right eye diagnosis was actinic keratosis, though it was again confirmed that because of the phototoxicity, the patient had symptoms. Infective can be super added, and the inflammatory necrosis was again from phototoxicity because of the porphyria. After 2 months, when we saw the patients, there was no gross inflammation. The sclera was thin, but again there was no uveal exposure, so the patient was managed conservatively. So the take-home message from my case presentation is that we should always look at the patient as a whole, because in this case, initially we were only seeing the scleral necrosis, and we did not focus on the general symptoms, but on prodding the patient, we finally found out that the patient had porphyria, of which the ocular symptoms are a very rare presentation. So we should always look at the patient as a whole. Thank you.
Thank you, Dr. Kanika, for that nice presentation. Dr. Srilata.
Yeah, yes, Dr. Kanika, that was a well-documented case. You could just present the entire, the systemic features of the patient, and the workup was complete, and that helped you to clinch at the final diagnosis. So that was well presented.
Yes.
Thank you.
Thank you, ma'am.
I now invite Dr. Gunjan Budhiraja, who will be presenting on the topic Chance Favors the Prepared Mind.
Yeah, I'm sharing my screen.
Yes.
Is my screen visible?
Yes.
Good afternoon to the esteemed panel. I'm Dr. Gunjan Budhiraja, and I'm going to present my case called Chance Favors the Prepared Mind.
Actually, your volume is low, Dr. Gunjan. I'm not able to hear you well. You could probably speak a little louder, please.
Can you hear me now? Can you hear me now?
Please speak a little louder.
Am I audible?
Yes, yes.
Yeah. So as we all know that phacoemulsification is currently the most commonly performed cataract surgery. Descendants membrane detachment or tears may occur as a complication of intraocular procedures. The incidence of DMD has been reported from 2% to 6% during the extracapsular and phacoemulsification cataract surgery respectively. So I'm presenting a case of a 75-year-old female who was a resident of New Delhi. She presented to a hospital on 26 December 2018 with the complaints of Descemet's membrane detachment, with the complaints of corneal edema, and the visual acuity was very poor, which was 20/200. On examination, we could find out that there was a Descemet's detachment superiorly, and there were DM folds and corneal edema. On ASOCT, we could also find out that there was a Descemet's detachment. She had a complaint of decreased vision and pain in the left eye since 1 week, and she gave a history of phaco surgery done elsewhere. So, investigating further, we could get in touch with the operating surgeon, and they told us that the surgery that was done was for a hard cataract and small pupil. The intraoperative events he disclosed were that there was a Descemet's detachment noted, and for that air bubble was left. There was a minimal visual regain after the surgery. Therefore, they referred the patient to our center. So we planned for a left eye desmetopexy with C3F8 under GVP. On investigating further into the right eye, we could find out that there were in diffuse illumination, we could see that there was a dense arcus and there were dispersed speck-like material on the endothelium. So we went ahead and made a provisional diagnosis of left eye Descemet's membrane detachment, SP phaco-IL, and right eye posterior polymorphous corneal dystrophy with immature senile cataract. So for the Left eye, we went ahead with desmetopexy. And on the first day, we could see that although the air bubble was present as 40% in the anterior chamber, there was severe corneal edema and there was a folded DM superiorly, and the DMD still persisted even after the C3F8, and the pressures were normal. On follow-up in subsequent visits, we could find out that there was a persistent stromal edema and DM folds with epithelial bullae, but the PCL was stable in the back. So at that time, we made an impression of persistent large Descemet's membrane detachment, and then we planned for a left eye Descemet stripping endothelial keratoplasty under guarded visual prognosis. We went ahead with the Descemet's Descemet's endothelial keratoplasty under LA, but after the surgery, we could find out that there was a still interface fluid present here, although the lenticule was attached here, and although there was no pupillary block. So we went ahead for a rebubbling under air. After rebubbling, we could find out that the lenticule was attached in all the places, and there were the flaring up, and AC was formed. On finding out the histopathologic reports, we could find out that there was a epithelium that was 3 to 4 layer thick and stratified, and the Bowman's membrane was also thickened, and Descemet's membrane was thrown into folds, and endothelial cells were 1 to 2 in number. And also we could find out that the Descemet's membrane thickening was there, and they appeared, the endothelial cells appeared like stratified squamous epithelium here. This one. After subsequent follow-ups, she was doing well, and after 3 months, she reported to us with decreased vision in right eye, that was with a vision of 6/60. So as we previously had noted that she had posterior polymorphous corneal dystrophy and nuclear sclerosis and cortical cataract with a non-dilating pupil. So we planned for right eye phaco iris hooks with DSEC and PCIR under GBP. We could also see on the retroillumination that the specks were diffusely distributed all over the cornea, and anterior segment also showed hyperreflective endothelial layer. Her pentacam was completely normal, and we could do the specular microscopy in both the eyes, so we could find out that there were large donut-like discrepancies in the endothelium. So we went ahead with the surgery. First, we completed the phacoemulsification along with the iris hooks, and then DSEC was performed in her, and it was uneventful. On day 1, the DSEC lenticule was attached, although there were a few interface fluid pockets seen. So now, in this right eye, she is doing well, and the DSEC lenticule is attached with maintaining a vision of best corrected visual acuity of 6/9 parts. So coming to the discussion, the posterior polymorphous dystrophy was done by described by Capes in 1916, and he reported bullous lesions on the posterior corneal surface with iris adhesions. It's a very rare dystrophy and is a bilateral autosomal dominant disorder. Primarily, the innermost corneal layers, Descemet's membrane and endothelium are involved. Biomicroscopically, it presents as geographical lesion, bands, and vesicles. Coming to the review of literature, the clinical characterization of posterior polymorphous dystrophy in patients of Indian ethnicities, this was done to characterize the clinical presentations, and they concluded that 12/53 patients, they required keratoplasty for visual significant corneal edema, and the patients who needed keratoplasty were bilaterally affected. Coming to cataract surgery posterior polymorphous dystrophy patients, they reported 2 patients with PPCD who successfully underwent phacoemulsification, and they did not show any influence of outcomes of phacoemulsification when the proper technique was adopted. This report also that was given by UK Center, that they said the endothelial cell loss and complication rates with combined LASIK and cataract surgery in a UK center. They found that mean endothelial cell count and complication rates were comparable at 6, 12, and 24 months in routine cases. So they support the combined endothelial keratoplasty with cataract surgery in appropriate patients. So my take-home message will be that the careful evaluation and this person who and breaching endothelial dysfunction can size. Combined phacoemulsification with endothelial keratoplasty can also give a comfortable option for patients with hard cataracts and endothelial dysfunction. Thank you.
Thank you, Dr. Gunjan. I now invite our next speaker, Dr. John Sarkar, who will be speaking on melted by molten metal but can be salvaged.
That was an excellent case, Dr. Gunjan, in terms of being able to diagnose this rare condition. Probably the point would be that even before the first cataract surgery was done, if there was something abnormal in the endothelium, it's always prudent to just run a specular before the surgery, and that could have probably picked up even before the left eye surgery and the patient landing up in decompensation. Otherwise, I think the surgery was well done and well managed. Thank you.
Dr. Praful, can you mute yourself? Thank you. Dr. John Sarkar? Is your video running now? Dr. John Sarkar?
Yes.
Is someone assisting from the DOS team? Hello? Dr. John?
हाँ जी मैम, वो कॉल पे है मैम.
Ma'am, should I move on to the next presenter?
Yeah, I think it would be better to have the next presenter on.
Since two participants, Dr. Soumya Ish and Dr. Suman Lata, they are not with us. We are moving forward to the next presenter, Dr. Pradnya Kumar Bole, who will be presenting on autologous Tenon's patch graft, followed by DSEC in a case of sterile post-traumatic corneal fistula. Dr. John, please unshare your screen.
Hello, am I audible?
Yes, yes.
Okay, a very good afternoon to all. I am Dr. Pradnya from M&J Institute of Ophthalmology, Ahmedabad, and I will be presenting a case of post-traumatic corneal fistula with persistent corneal edema, which was successfully managed by an autologous Tenon's patch graft followed by DSEC. So, a 46-year-old male presented to the emergency eye department with acute pain, redness, and decreased vision in the right eye since 4 hours. He had history of trauma to the right eye by metallic nail while working, and the visual acuity on presentation was counting finger near face. The slit lamp examination revealed a paracentral area of corneal thinning with adjacent stromal edema, a shallow anterior chamber with no iridocorneal touch, and early cataractous changes. The Seedles test was positive. The radiography revealed no evidence of intraocular foreign body. So we actually took the patient in the OT with the plan of maybe suturing the wound or maybe gluing the wound. But when the patient was taken for wound exploration, it was an intraoperative surprise that the area of thinning just gave away after the application of the wire speculum to reveal a 3 mm by 3.5 mm full thickness corneal defect. Now, with no availability of donor cornea in such an emergency situation, but with the availability of amniotic membrane, we went ahead and did amniotic membrane graft with cyanoacrylate glue and DCL. The anterior chamber was better formed with this procedure, though it was shallow. As seen in this photograph, in the next post-operative day, the AC stayed shallow. We decided to wait and observe the patient for the next 48 hours for the formation of the anterior chamber. But with no success in this and with no availability of the donor cornea, we decided to go ahead with autologous Tenon's patch graft. Now, Tenon's patch was taken from the superinasal quadrant of the eye and a tuck-in technique was used. In this technique, a 360-degree corneal stromal pocket is made at the site of the perforation, and the Tenon's patch is customized to the site of the size a bit little larger than the size of perforation, and it is tucked inside the stromal pocket. This was supplemented with a double-layered amniotic membrane graft inlay as well as onlay with fibrin glue and sutures 10-0 nylon with BCL with formation of the anterior chamber with air. Post-operatively, as can be seen in the photograph, the amniotic membrane and the Tenon's graft were in place with a deep anterior chamber. The patient was started on a tapering steroid eye drops, topical antibiotic, artificial tears, and cycloplegic. As seen in the photograph, a complete healing was noted at 8 to 10 weeks. However, even after 12 weeks, the corneal edema was persistent and the cataract had matured. Now the patient needed a keratoplasty for visual rehabilitation as well as cataract surgery. So we decided to plan or dissect for this patient with phacoemulsification. As the opacity due to the Tenon's was paracentral, a dissect was advisable in this patient. So a dissect with phacoemulsification with IOL implantation was done after 4 months of the Tenon's patch graft, and post-operatively on the second day, right eye dissect graft was well centered with a well-formed anterior chamber and IOL in place. Post-operatively after 1 month, the graft was clear and the IOL was well centered and in place. Now, therapeutic success was achieved according in this patient as far as the visual rehabilitation is concerned, that best corrected visual acuity at the end of 4-month follow-up period was 6.9. So the use of Tenon's patch graft with tuck-in technique was first described by Dr. Vajpayee in a video presentation in 2012. He had used this with fibrin glue and sutures. A similar technique was described by Sharma et al. In their study in 2019, where they used cyanoacrylate glue and BCL with the Tenon's patch graft and sutures for larger size perforation. The use of amniotic membrane in the present case along with the Tenon's patch graft was to ensure adequate closure of the wound and to suppress inflammation and to promote epithelialization. The persistent corneal edema in this case might have been due to the prolonged shallow anterior chamber post-trauma, and also because of probable pre-existing low endothelial cell count, as the specular microscopy report of the other eye showed significantly low endothelial count and poor endothelial cell quality. So to conclude, a post-traumatic corneal fistula can present as a surprise when you least expect it, and an autologous Tenon's patch graft can act as a savior in such cases. It is a simple, inexpensive biological tissue to seal the smaller corneal perforations, especially in emergency, in the absence of a donor cornea, thereby helping in maintaining the integrity of the eye and enabling visual rehabilitation at a later stage, as was done in this case when the patient underwent corneal transplantation for visual rehabilitation. Thank you.
Thank you, Dr. Pradnya. Dr. Srilata would like to make some comment.
I would say again, it's a wonderfully managed case, and I think Dr. Praful, who is the main author in many of these cases where Tenon patch graft has been done, he's here in the call if he wants to add something. But otherwise, it was an excellent case. Yeah.
Thank you, Dr. Pradnya. Even I find Tenon's patch is a very useful technique. One thing, did you use Tenon's just for inhibiting vascularization, or the primary aim was to get some tectonic support?
Primary aim was to get the tectonic support, because we tried the aim with AMG, and because with the multi-layered AMG also the AC did not form. So we did Tenon's, then we placed AMG over the Tenon's.
And
so mainly it was done for tectonicity.
And you just the sutures, or you use fibrin glue?
Fibrin glue as well as 10-0 sutures, because I had done it for the first time. I was not sure whether it will hold or not.
Now, this is in fact our experience is also like that. If you don't apply suture, it usually doesn't stay.
Yeah.
Good part is your size was it's not small. It's not small Tenon's patch. It's a huge Tenon's patch, so it's better that you applied suture there.
Yes,
and
yes.
What did you do about the suture? Did you remove them?
I removed the sutures. Yes.
And on slit lamp or microscope?
In the OT, sir.
Yeah, because slit lamp it's very difficult to remove suture.
Yes. In the OT, when I planned dissect, before that I removed the sutures.
Yeah, because I feel that is in fact the only limitation currently with Tenon's patch, and we are working to improvise that. You can also do some improvisation.
Yes.
Because putting the small sutures and getting them tucked in cornea is a very
Okay.
difficult task.
Yes, yes.
Most of the time you have to put a BCL because it's not possible to bury all the knots.
Yes, we put a BCL after we did that. I mean, with the
I'll
primary
be
procedure.
to do more such cases and come out with some new idea.
Yes, it was really nice experience doing this. I mean, we are really thankful to you to promote this Tenon's patch. It is helping a lot.
It's very rewarding. If Srilata permits me, I'll share one experience of mine.
Yeah, sure.
When I went to AIIMS Bhubaneswar, just for a transient period of 6 months, one patient of corneal fistula, just like you mentioned here, came to
Yes.
me, and she was like, "I don't want to go to private practice. Whatever you have to do here only."
Okay.
And all the night I was thinking, what can I do? Then I thought, okay, let's try Tenon's patch. And from there only I got this idea, okay, Tenon's patch is at times it's eye saving. We don't realize sitting in tertiary care hospital, but once you go to peripheral center, even it's very difficult to get cyanoacrylate glue.
Yes, yes, yes.
For those cases and those practitioners, this technique is at times eye saving. They should learn
Yes.
this technique.
Rather, we should promote it more, especially in the COVID times when
Yeah,
there is
yeah.
paucity of donor corneal tissue.
Thank you. I'm very happy to see that people are doing this. Thank you.
Thank you, sir. Thank you.
Yeah, that was a wonderful discussion. Thank you, Dr. Praful, for your pearls of wisdom and experience. Thank you.
Dr. John, are you ready?
Yeah, I can try again.
Please start your screen share.
हाँ वीडियो नहीं दिखाई दे Why? 1 minute. नहीं दिखाई दे रहा वीडियो दिखाई दे रहा है
I'll be presenting melted by molten metal.
तो ऑफ कर दिया now okay hello
Dr. John? I will be moving forward to the next speaker.
hello
Uh,
already shared remove these things ma'am now the video is not running
Please sort it with the DOS team. I'll remind them once again. The next speaker is Dr. Prafulla Maharana, who will be speaking on methotrexate induced corneal epithelial toxicity
Yes.
managed with
Yes,
topical
they can-
ibupropofol drops. Please stop sharing your screen, Dr. John.
hello yes madam
Dr. John, please stop sharing.
yeah stop share
Yes.
yes
The next
yes
speaker is
yes
Dr.
yes
Prafulla Maharana. Please unmute yourself.
Yes.
Please mute yourself.
yes they already they switch over to another speaker again
Please mute yourself.
okay
Thank you, Sohini. If my PPT is visible to you.
Yes, sir.
Okay, thank you, Sohini. So let me start with my interesting case. Okay, I think there is some problem. If somebody else is running my PPT or what? Why is it moving on its own? Okay, so this is an interesting case of methotrexate induced corneal epithelial toxicity that we came across few months back. So it was a 49-year-old female. She presented with redness, foreign body sensation to our OPD. So my resident, he started on lubricating antibiotic, thinking that there was a history of diffuse large B-cell lymphoma. The patient was diagnosed with that 2 years back, and she was on chemotherapy. So he thought it may be a chemotherapy-induced dry eye. So only lubricating drops are given and one prophylactic antibiotic. And the patient was referred to us to the cornea clinic. So when the patient presented to us, as you can see, this is the picture of right eye. If the image is clear, you can see there is a sheet-like opacity here. The epithelium is hazy and loose. It's not like a regular epithelium, but the central part was little bit clear. This is again a picture of right eye. You can see there is a heart-shaped area where the cornea was clear, but rest of the area, the epithelium was not healthy, and there was a sheet-like opacity was there in right eye. Then I examined all the limbuses carefully as well as fornices, and there was no abnormality there. This is the image of the left eye. If you notice carefully, again the epithelium was not healthy. Simultaneously, there was some area of limbitis and some conjunctival congestion. So in this image, you can see there is a clear demarcation between the healthy epithelium and the unhealthy epithelium. You can see this ridge here. So this was the limbitis, and the fornices were also congested. So when I stain the cornea, we see that, okay, the entire cornea was taking stain, and there was diffuse SPKs along with some filament formation in the left eye. So the history was not corroborating. So after doing all the doctor tricks, I could recognize that the patient is not clear about her history. So after insisting, then she finally opened up. The patient, although her systemic chemotherapy led to resolution of the breast lump and the lymphoma part was under control, but she developed floaters 3 months back, for which she went to a private practitioner. Initially, the primary treating physician, where she was getting chemotherapy, there they had done a vitreous biopsy for vitreous clumps in vitreous cavity, and that came out to be positive for intraocular lymphoma. Then they started giving intravitreal methotrexate. She had already received 5 doses of intravitreal methotrexate. Following the 5th injection, she developed photophobia, blurring, and watering complaint. And there was some misunderstanding between the treating physician and the patient. So she went to a local ophthalmologist rather than the treating physician. Local ophthalmologist, they treated with for around 1 week for in the line of dry eye. However, there was no response. So this referred the patient to us. So leaving apart the complicated history part and the thing that the patient were hiding, we were sure that okay, we are dealing with a case where maybe intravitreal methotrexate is the culprit. So I asked my SR, you got 30 minutes, go back and study and then come back. Then we can plan something for the patient. So we found 3 large series on this topic. One by Smith et al., where they found that intravitreal methotrexate can lead to corneal epithelial toxicity, transient limbal stem cell deficiency in 58% of their cases. Frankel et al. Found this epitheliopathy in almost all their cases. Jeong et al. In a recently published study, they found that almost 22.7% of cases, those receiving intravitreal methotrexate, they do develop some form of corneal epitheliopathy. So this is the proposed mechanism. Whenever you are injecting intravitreal methotrexate, there is some local spillage, and this methotrexate is harmful to the mitotically active limbal stem cell, and that leads to a transient state of limbal stem cell deficiency. And this may manifest as epithelial defect or multiple superficial punctate keratopathies, or maybe filament formation, and the patient will have symptoms like watering, photophobia, and blurring of vision. However, the difficult part was the management part. What we found that management is not well defined in literature. In one study, for example, the Smith study, they just reduced the frequency of intravitreal. Rather than weekly, they make it monthly regimen, and the epitheliopathy resolved. In the second group, only topical lubricant worked in the Frankel group, and all of their patients resolved. But there was a 2-patient case series by Goroboy et al., where they found that these measures doesn't help, and they had to go for oral as well as topical folinic acid. So we were a bit confused. Then what we did, we went through individual characteristic of those patients, and after reviewing all the patient details, we come out with this concept that if there is a methotrexate induced epitheliopathy, if it is mild means only few SPKs are there is no epithelial defect, and the visual axis is not involved yet. In those cases, you can simply get away with using topical lubricating drops or tapering the methotrexate. However, if the entire cornea is involved with SPKs, or there is an epithelial defect, or the central cornea is involved. In that case, you have to rely upon folinic acid. Folinic acid, just a revision of our MBBS knowledge, methotrexate, what it does, it inhibits folate-dependent enzymes. So there is a transient state of folate deficiency. Folinic acid, once you give supplement with folinic acid, that step is bypassed, so that part is taken care of. So we started with we started with topical folinic acid eye drop, and it is easy to prepare. It's available as a freeze-dried powder form. You can dilute with distilled water and make a concentration of 5 milligram per ml. The standard dose is 3 times a day. Simultaneously, to take care of the limbitis part, we added a mild potency steroid like loteprednol and lubricating drops. And there was some dry eye component too. So we added cyclosporin also. Now this is the day 7 after starting the treatment. As you can see, although the congestion part has reduced, but there was not much improvement in corneal epithelial status. You can still see this epithelial haze here as well as in the left eye also. But by 6 weeks, there was complete resolution of the epithelial toxicity part. The limbal stem cells that were in a transient deficiency state, they were recovered. However, some congestion was still persisting. So we decided to continue the management for dry eye part. So to conclude, intravitreal methotrexate toxicity, especially in those hospitals which are multi-speciality, where they may be dealing with intravitreal tumors or intraocular lymphoma. If they are giving this, they should be worried about the epithelium. They should regularly check it because it can lead to transient stem cell deficiency and corneal epitheliopathy. If it is visually significant, you can get away topical folic acid therapy. However, the unfortunate part was that the patient refused any further treatment at our center and she went back to the primary physician. But this was a learning experience for us because this was the first time I was dealing with such case. So I thought let's present it here. Thank you very much. And with this, I'll conclude my talk.
Thank you, Dr. Praful, for showing us such a nice and interesting case. Dr. Srilata, comment, please.
Yeah, again, it was a very unique and rare case of the couple, very well worked up, and the way you dug up into the literature and you could come up with your own treatment plan. Again, it's the innovator's mind as always. We look up to you. That's great. How do we explain the other eye epithelial abnormality? Because the intravitreal methotrexate was received only in the left eye. If I understood it
No, she was receiving intravitreal methotrexate in both her eye. Both her eye had intraocular lymphoma. And they were hiding all the medical records to us, but maybe some medical legal issues may be there. They may be suing the primary physician for some issues, but this is what maximum thing that we could get from them.
That's amazing. Thank you so much.
Thank you.
We are moving forward to the next speaker, Dr. Rahul Bafna, who will be presenting us with the topic titled Biological Encerclage.
Thank you, Dr. Sohini. I'll be sharing the screen right now. Is my video visible?
Yes.
Okay. Can you check for the audio, please?
Yes.
His audio is
present a very rare complication of an extremely rare clinical entity, Trabulsi syndrome. There are many reasons of finding a bleb in the eye, but a spontaneous bleb is hard to find, and the rarest cause is this genetic disorder. Mapped to mutations in the aspartyl hydroxylase gene, this syndrome presents with the typical facies of malar hypoplasia, broad nasal bridge, and peak nose. Ocular findings include lens dislocation, anterior segment abnormalities, and spontaneous filtering blebs. How rare is this disorder? Well, as rare as it gets, with only 15 cases reported worldwide till date. Our patient was a 31-year-old lady. She gave no pointers towards the cause of her eye having a bleb. However, she had a history of consanguineous marriage. So to put things in perspective, this lady with one seeing eye at high risk of losing her little remaining useful vision came to our specialty clinic in the hope of preserving her right eye. The eye had a flat AC because of multiple overfiltering spontaneous blebs, the superonasal having such a large scleral defect that it became staphylomatous. ASOCT confirmed multiple fluid pockets in the subconjunctival space. The other eye had no perception of light owing to sequelae of the same events. A case which had been issued her visual death sentence by many had presented to me as an opportunity to make the best use of all my learning and skills. I looked up the sparsely available literature only to find no reported cases where any active intervention had been done in a case of Trabuzzi syndrome. My mission was simple: salvage the globe, restore the integrity. We decided to use cross-linked cornea to decrease chances of infection. The surgery for this biological encerclage began with a liberal peritoneum. All of the subconjunctival tissue was dissected to expose the sclera beyond the staphyloma completely. Hemostasis was then achieved with red field cautery. A 1 mm stab entry was made into the staphyloma, collapsing it partially. A stab entry was then made into the AC and OVD injected to fill the AC partially. The stab incision on the staphyloma was then enlarged using Vanna's scissors, and the subluxated lens was visco-expressed through the defect. The lens diameter was measured to be around 7 mm using gastrometer caliper. After wound site vitrectomy, ciliary processes could be seen through the defect, confirming the location of the scleral defect. Continuous interlocking vicryl sutures were placed to close the defect. To reinforce the eye wall in this region, cross-linked therapeutic grade corneal tissue was used. The tissue was refined and fashioned to form a crescent of adequate width. This width was measured to be 4 millimeters. In order to match the curve of the limbus, 2 wedges of corneal tissue were excised, leaving a hinge at the inner margin. And the arc radius was increased by closing those wedge defects to exactly match the limbus. In order to give a smooth edge at the limbus, a tuck-in graft was performed. This involved creation of a beveled inner edge of the graft crescent and a corresponding corneal pocket along the superior clear cornea. This corneal pocket was meticulously fashioned in the clear cornea, just abutting the superior limbus using a crescent plate. The graft was then tucked under the corneal pocket and sutured using monofilament nylon to provide adequate strength to the weak intercalary zone. The remaining scleral rim was used to prophylactically perform the same procedure inferiorly and reinforce the perilimbal sclera. All sutures were buried and 2 side ports were made into the AC. Bimanual irrigation and aspiration was done to wash the OVD, and vitrectomy cutter was used to enlarge the pupil inferiorly. All wounds were hydrated and the AC formed. Conjunctiva was then closed 360 degrees. Post-operatively, the patient performed much better than expected, and on serial follow-ups maintains a vision of 5/60 with aphakic glasses. With this case, I would urge all my fellow surgeons to never give up on a patient.
Thank you, Dr. Rahul, for that excellent presentation. Dr. Srilata, comments, please.
Yeah, I would say that was a Herculean task, Dr. Rahul. That was amazing the way you could manage this case. How did you prepare the cross-link cornea, Dr. Rahul?
Pardon, ma'am? How did I?
How did you get the cross-linked donor cornea? What did you do and how do you do it?
Ma'am, actually in the OR, I have done cross-linking of the donor cornea. There is a paper published from a center where we have used cross-link corneas for therapeutic PK to decrease the chances of infection. As we all know that cornea also cross-linking also stiffens the cornea. So to increase the and augment the scleral perilimbal scleral support, I have cross-linked the cornea. So at the time of
That you have used for the cross-linking of the donor cornea?
riboflavin, isosmolar.
Okay, but is it like a normal Dresden protocol that you do, or what is the entire protocol that you do for the cross-linking of the donor cornea?
Actually, we mount in the artificial chamber. We debride the epithelium. Generally, for therapeutic grade tissues which are more than 400 microns, so we use isoosmolar riboflavin, and we do conventional cross-linking.
That's exactly what I want. Okay, so you mean 30 minutes of riboflavin followed by 30
Yes,
minutes
yes.
of radiation?
While the patient was getting intubated, we have started cross-linking, and we have done for 30 minutes the cross-linking.
Okay. And in how many cases have you used cross-linking cornea so far in your center in your experience?
Ma'am, there is a thesis which is done by my senior Dr. Anjana. She has done with the cross-link cornea, but for me, it was the first case just to support this one-eyed lady, because as there were no other surgical options, I don't want to do a second graft in this patient, because I thought that second graft would be a mess because of lot of fibrosis. So I have proceeded in a keeping in mind present and future of the patient, and did a prophylactic inferior encerclage.
All right. Thank you, Dr. Rahul. That was a wonderful presentation.
Thank you, ma'am.
Thank you all the participants and judges, Dr. Srilata ma'am. With this, we can conclude this session.
Sure. Thank you so much, Sohini, for your coordination. Thank you. Yes, I think we can end the session.
Thank you.
Good afternoon, everyone. I would like you all to be ready for the next session, Retina Free Paper 4. I would like to invite our judges, Dr. Mayank Bansal, Dr. Punita Sodi.
Yes, I'm here.
Yes, ma'am?
Yeah, I'm here. I'm ready. Can you hear
Oh,
me?
yes, ma'am. We can see you. Our first presenter is Abhishek Upadhyay. Sir, are you there?
Yes, I'm here.
Can you please start sharing your screen, sir?
Yeah, sure.
Yeah, a very warm welcome to everyone. We look forward to all the talks and presentations. And over to you, Dr. Abhishek.
Is my screen visible?
No, sir.
Not yet.
No, we can't see your screen.
Can you tell the time allotted and the maximum marks?
A total of 6 minutes is allotted for each speaker,
Yeah.
followed by 2 minutes of discussion on each topic. So please stick to the time limit.
And marks is 10 maximum.
Yes, ma'am.
In case Dr. Abhishek is having a hard time sharing the screen because of connection, should we move on to the next talk?
Yeah, you can. Dr. Meenakshi.
Dr. Meenakshi, please share.
Hello.
Hello, Dr. Meenakshi, please start sharing your screen.
Okay, fine. Is it visible, ma'am?
Yeah, but no, not so. Yeah, now I think it should be one slide only, no? Like,
Okay. Is it okay now?
yeah.
Okay. Can I start, ma'am?
Yes, yes.
And my voice is clear, ma'am?
Yes, you can start the timer. Who is the...
Yes, ma'am.
All right. Good afternoon, everyone. My name is Dr. Meenakshi Dalal. I'm a senior resident. And today I'm going to present a case series on retinal arterial macroaneurysm and efficacy of anti-VEGFs in its management. First, before discussing the case series, I would like to give a brief introduction about this disease entity. Retinal arterial macroaneurysm is a focal aneurysmal dilatation of an arteriole, and it usually found within the first 3 orders of the retinal arterial system and generally occurs in the temporal quadrant and involves the points of bifurcation or arteriovenous crossing. Clinically, it is classified into three forms: quiescent, which is an incidental finding; hemorrhagic, in which the patient presents acutely with the deterioration of vision, and you can see multi-layered hemorrhages in the fundus in such patient. In exudative RAM, it follows an indolent course. In this, there is lipid deposition due to leakage from the lesion, and patient can present chronically with reduced vision. So various researchers have tried different kind of options, treatment options in case of retinal arterial macroaneurysm. And it was seen that most of the RAMs, they involute spontaneously. However, when it is accompanied with macular edema, exudates, neurosensory detachment, or in case of hemorrhagic RAM, if it involves the macula and uh, the hemorrhage is not getting reabsorbed, in that case you need to do intervention. So people have tried laser treatments in these, but the laser treatments were not very successful. They had a lot of side effects. So now the people have started using anti-VEGFs because, recently in the past few years, anti-VEGFs, they are on boom, and they have been tried for treatment almost of everything in retina. They have become retinal specialists' best friend, I guess. So I am going to describe three cases of RAM in this presentation, which presented to our institute, and we also tried using NDVGF for their treatment. And then they, so as normally, all patients come, we have taken detailed medical history of all the three patients, and a complete eye checkup was done. So this was the first patient who presented to us. He was a 60-year-old male, and he was hypertensive. And he presented with a vision of 6/60 to us. And when the fundus examination was done, a superior temporal lesion was seen. You can see the exudative maculopathy is present, and an inferior hemorrhage can also be seen. The OCT pictures are attached along with. So we did, to confirm the diagnosis of RAM, we did FFA in this patient. FFA is an ancillary investigation, and I guess it should be done in all cases of retinal arterial macroaneurysm, because it clearly delineates the lesion and it can help you confirm your diagnosis. So you can see that in early cases, there is filling up of this lesion, and you can see the fusiform dilatation. You can see the lesion clearly. You can see the blocked fluorescence, which is because of the inferior hemorrhage, which we saw on the fundus. This is the second case of RAM which presented to us. This was a 55-year-old male. He was both diabetes and hypertension, and he presented with this inferior temporal lesion. In this case, the lesion was like not very much typical of a RAM. So we did OCT, which shows the presence of these exudates, and edema was there. So again, we did FFA in this patient also, and you can see this in this now demarcates the lesion. It fills up in the early phase, and later it shows the leakage. The third case which presented to us was very ambiguous, sort of. The patient presented with this large macular hemorrhage. We tried to do FFA in this patient, but the media was very hazy. We didn't get the very good pictures. We did ultrasound as well in this patient, because but there was no retinal detachment, nothing other sort was seen. So and our institute is a very small setup, so we don't have any more investigations that we could have done. So in for the treatment, what we did is, in the first two cases, we directly gave the ranibizumab. The anti-VEGF we used was ranibizumab. The standard dose of 0.5 mg was given in both the two patients. This is the first fundus picture you can see with exudative maculopathy. This is the first 1 month post-operative picture of the patient. You can see the hemorrhage has dissolved. The exudative maculopathy is still present though. And you can see the OCT, the correlating OCT of the patient. The second picture, the fundus picture, which you can see where there is complete involution of the RAM, the exudation has also been absorbed. This is the 6-month follow-up picture of the patient. First month, the vision improved from 660 to 624. And after 6 months, when we saw patient again, the patient was having 612 vision. And this was just by one injection. We just gave one injection to the patient. In the third patient, where the patient presented with a large pre-macular hemorrhage, in that case, we first tried the laser subhyaloidotomy, but it didn't work out in a good way. We then gave anti-VEGF ranibizumab injection in that patient as well, and that patient also showed reduction in central macular thickness, and his vision also improved, and his hemorrhage also got cleared. So the various researchers have tried different treatment options, and the three major studies which are done in RAM patients shows encouraging outcomes with the intravitreal injections of anti-VEGF. And in our series also, we have found that the best corrected visual acuity has improved, the central macular thickness got reduced, and we found no complications post these intravitreal injections. So it's not a very big study, but yes, definitely out from these three cases, what we have learned is that anti-VEGFs are worthy treatment options for symptomatic RAM patients, and they give a quick visual recovery and involution of RAM lesions. Plus, I guess only one injection is sufficient enough for the involution of RAM. So definitely, I guess the message I just want to impart from this presentation is that in all cases of symptomatic RAMs, rather than going for a laser, I guess anti-VEGFs is definitely a better treatment option. Thank you. Hello.
Okay, Dr. Meenakshi.
Yes, thank you.
You have shown the treatment of 2 patients only, no? Only the third one you've not shown that how he recovered back.
Ma'am, actually the pictures were these only that we have.
And what part recovered? Only the central macular edema recovered, and vision improved, or something else also recovered?
These lipid deposit, these exudation was also gone, ma'am. And we could see the involuted RAM, the hemorrhage around that RAM also resolved, and there was no, on the further follow-ups, no further exudation or any other hemorrhage was seen.
Follow up till how much time did you follow up? 1 month or like?
No, ma'am, 6 months. Both these three patients, we have followed till 6 months.
Okay. We may go to the next presenter.
Can we have Dr. Monica?
Yes, ma'am, I'm here only.
Please share your screen, ma'am.
Okay. Good morning, everyone. Myself, Dr. Monica, I would like to present a case of Takayasu arthritis presenting as a neovascular glaucoma. Takayasu arthritis is an aortic arch syndrome, which is also known as a pulseless disease. It is a large vessel granulomatous vasculitis with massive intimal fibrosis and the vascular narrowing. It mostly affects the young or middle-aged women of the Asian descent with a female to male ratio of 9:1. That is a very significant preponderance for the females. It mainly affects the aorta and its branches as well as pulmonary arteries. Neovascular glaucoma secondary to bilateral OIS has never been reported as an initial presenting manifestation of Takayasu arthritis. We present a case of 32-year-old male who presented with an insidious onset of gradually progressive loss of vision, which was associated with chronic pain in both eyes since 6 months. There was no other known systemic illness. On general physical examination, patient was well oriented to time, place, and person, but his pulse was very feeble in the upper limb and there were normal pulses in the lower limb with no audible murmur. His BP was recorded 130 by 80 mmHg in the lower limb, as BP was not recordable in the upper limb. There was no other significant illness, and the rest other systemic examinations were within normal limits. On ocular examination, his best corrected visual acuity was 1/60 in both eyes, and the ocular adnexa was normal, but the pupil was mid-dilated and non-reacting to the light. On anterior segment examination, there was mild ciliary congestion with the grade 1 flare, and there was gross neovascularization of iris all around the 360-degree. When we did the gonio, we found a 360-degree angle closure with the neovascularization of angle, and IOP by GAT was recorded 34 mmHg. These are the anterior segment pictures showing the NVI in the both eyes with the mid-dilated non-reactive pupil. On fundus examination, right eye showed the NVD with the sclerosed vessel and the bony spicules in the mid-periphery, while the left eye fundus showed NVD with the attenuated arteries with few dot blot hemorrhages in the mid-periphery. When we carried out the investigations, his ESR was quite raised with a value of 53 millimeter per hour and the CRP was 18 milligram per liter. When we ordered a carotid Doppler, there was a bilateral common carotid artery occlusion with the echogenic thrombus till its bifurcation into the internal carotid artery and the external carotid artery. Bilateral ICA showed the minimal central flow on the color Doppler with peripheral thrombus occluding lumen. On CT NG of neck, there was a soft plaque which was completely occluding the bilateral common carotid artery. There was complete occlusion of first part of left subclavian artery, complete occlusion of brachiocephalic trunk, and the attenuated caliber of the right proximal internal carotid artery. So there was a young age of onset with pulselessness, with elevated ESR and CRP, with the radiological features of vascular narrowing of the proximal aortic artery branches, which led to the diagnosis of the Takayasu disease. So the patient was started with the systemic steroid with a dose of 1 milligram per kg body weight with the topical beta blockers, alpha agonist, and the carbonic anhydrase inhibitors to control the IOP. And he was urgently referred to the vascular surgeon for extracranial intracranial arterial bypass surgery as there was complete occlusion of common carotid and the internal carotid artery. Patient came for follow-up after 1 month of his surgery and his symptoms got improved with a decrease in ESR and CRP. IOP was 18 mmHg in the both eyes. However, unfortunately, his vision didn't get improved. But diagnosing a life-threatening condition like Takayasu arthritis and a prompt referral can be life-saving for the patient. Ocular ischemic syndrome is a rare sight-threatening condition with an incidence of 7.5 cases per million. It is usually misdiagnosed as the retinal venous occlusion or the diabetic retinopathy. Bilateral involvement is seen in 22% cases only, and it is caused by the ocular hypoperfusion, mainly seen in elderly with a mean age of 65 years. Patient can present with loss of vision, pain, sign of anterior segment ischemia. On fundus, there are narrowed retinal arteries with dilated retinal veins, but no tortuosity will be seen. There will be mid-peripheral retinal hemorrhages with NVD, and it's DDR, diabetic retinopathy, and the moderate CRPO. Most common etiology is atherosclerosis. However, the other less common causes are Takayasu, giant cell arteritis, aortic arch syndrome, Behçet's, thyroid, hyperhomocystinemia. Systemic association, mainly it is associated with hypertension and diabetes mellitus, and the mortality rate is 40% within 5 years of onset, which is usually secondary to cardiovascular disease and the stroke. Its management is multidisciplinary. Ocular treatment is aimed to treat the ocular complications and prevent further damage. Topical steroids are given to suppress the anterior segment inflammation, while topical cycloplegics are given to stabilize the blood-aqueous barrier. Prostaglandin and anticholinergic drugs should be avoided as it may increase the ocular inflammation. If NVG develops, IOP control become refractory. So the surgical options are trabeculectomy, aquashunt implants, dyed laser, and if there is painful blind eye, we can go for cycloablation and the retrobulbar injection of alcohol. Carotid and arterectomy, carotid artery stenting, and the extracranial intracranial arterial bypass surgery are other options. It's DDR, diabetic retinopathy, and CRBO. In diabetic retinopathy, we will usually see the hard exudates, and in CRBO, the hemorrhages will be all around and there will be tortuous vessels, not only dilated. So the take-home message is ophthalmologist, we need to be specially alert while dealing with the OIS, as it is not only a sight-threatening condition, but also a life-threatening. We should always look beyond the eye when we see a patient of NVG. OIS may present for the first time as NVG without any preceding ischemic events elsewhere in the body. Along with ocular treatment, a prompt referral to the concerned specialist is very important because it can be life-saving for the patient. Thank you so much.
I think we can, yeah. So the take-home message is that in ocular ischemic syndrome, there will be, what are the basic characteristic feature of ocular ischemic syndrome? What are the features we should look for? One is pulselessness. Second is, what should we look for? Can you tell in the take-home message?
Yes, ma'am, for sure. If we see a patient of ocular ischemic syndrome, we should look for the other systemic association, as the most important is hypertension and diabetes mellitus. But if a diabetic retinopathy patient present, as there are 20% cases where OIS is also associated with the DR also. If we are seeing asymmetrical diabetic retinopathy in the both eyes, we should look for OIS. Other than that, we should look for the other less common causes like Takayasu, Behçet's. There are less cases, but yes, they are reported.
Now, what are the systemic ones? Like systemic is one you have told is pulselessness. What
Yes.
other systemic features should alert us to the presence of ocular ischemic syndrome?
If there is abnormal carotid pulse, or if there is on the carotid Doppler, we are seeing any occlusion or the less flow.
So
And
we
other than that,
should,
radiological
we
features.
should take the help of our like other colleagues of medicine and cardiology.
Yes, yes, ma'am. Radiology, cardiology, and the vascular surgeons are very important. As only we cannot treat such disease. It is a multidisciplinary approach.
Okay, good. We can go to the next one.
Thank you, ma'am.
Dr. Siddharth Madan, are you there, sir?
Yes, I'm here. Am I audible?
Can you start sharing a screen?
Okay. My screen is visible?
Yes, we can see your screen.
Okay. So good afternoon all. I'll be presenting a different case of late onset suture-related endophthalmitis. A 65-year-old female presented to us with diminution of vision in her left eye for past 6 days. She had accompanying redness, pain and watering in the same eye for the same duration.
Sir, can you make it full screen?
Yeah, I'm trying to do that. Is it moved to a full screen?
It's okay, continue.
Okay, so a 65-year-old female that presented to us for diminution of vision and redness, pain and watering in her left eye for past 6 days. She was given some topical treatment elsewhere, but no improvement in the vision was noted by the patient. She had undergone a complicated extracapsular cataract surgery in this eye 20 years ago with an anterior chamber intraocular lens implantation. However, she had a satisfactory post-op visual gain. The right eye was aphakic as the patient underwent a cataract surgery without IOL implantation 25 years back in an eye camp. However, the visual gain was satisfactory with aphakic glasses and she had no systemic illness. On ocular examination, her lacrimal apparatus was normal in both the eyes. However, the left eye demonstrated a lid edema and the conjunctiva was congested. Her best corrected visual acuity in her right eye was 6/12 with aphakic correction. However, the left eye could only perceive light and there was inaccurate projection of rays in 2 quadrants. To note was that the digital tension was decreased in her left eye. On examination of the cornea, the size and shape were normal. However, there was a central corneal edema which was present in the left eye. At 12 o'clock position, there was an infiltrate of size 1/1 millimeter which was seen over an area of corneal melting underneath that infiltrate with 2 loose sutures with another infiltrate at 1 o'clock and 2 pus points could be seen at the site where the suture ends could be visible. Other eye obviously demonstrated a intracapsular cataract surgery scar mark, and there were vertical scar marks for the previous sutures. In the left eye, the patient had anterior chamber cells which were 2+. There was a peripheral iridectomy at 12 o'clock with infiltrates at the same point, and the pupil was sluggishly reacting. There were the exudates which could be seen behind the pupil in the left eye. There was dense vitritis, and the fundus had no glow. The other eye fundus examination was normal. A diagnosis of suture-related endophthalmitis was made in the left eye. She was started on intravenous and fortified topical antibiotics. On day 2 of antibiotics, her vision remained the same. Exudates could be seen along with choroidal detachment in the left eye. IOP was 8 millimeters of mercury. The patient underwent anterior segment TAP with anterior vitreous biopsy with suture removal, all of which were sent for biopsy and for the histopathological examination. and a bandage contact lens with cyanoacrylate glue was placed over the site of corneal melting, along with intravitreal injection of vancomycin and tazobactam. On the next day, her vision remained the same, IOP remained low. However, gram stain and KOH turned out to be negative, and patient was started on 40 milligrams of oral steroid. On day 6, her PR had turned to be accurate. IOP started to build up to 10 millimeters of mercury. Corneal edema persisted. Faint good glow could be seen temporally, and choroidal detachment was still present, as we can see in the ultrasound. However, the culture report at this point of time from AC tap had showed no growth. Fungal elements were negative on KOH, and culture report of suture also showed no growth. On day 7 of a presentation, another intravitreal injection was given with the intravitreal tap. Antibiotics included vancomycin, piperacillin, and tazobactam, along with dexamethasone, with AC tap, which was performed under topical anesthesia. Next day, her vision improved to hand motions close to face, and this maintained over the next 3 days. Choroidal detachment had started decreasing, and IOP was still 10 millimeters of mercury. So on day 12th of presentation, patient was planned for left eye pars plana vitrectomy with wound resuturing with conjunctival flap suturing at the site of corneal melting, with BCL placement with cyanoacrylate glue under local anesthesia under a guarded visual prognosis. So next day, her vision was perception of light, which she could perceive, and there was the PR was accurate. Faint fungal glow could be seen. Day 2nd of vitrectomy, the vision improved to hand motions close to face. IOP was 9 millimeters of mercury, and choroidal detachment had settled, and retina was attached. So in follow-up, on 9th day of vitrectomy, her vision improved to finger counting close to face. Good fundal glow could be seen, however, the details were not clear, and all the fortifieds antibiotics had been stopped. She was kept on topical moxifloxacin and dexamethasone along with hyperosmotic agents. On her progressive follow-up through day 23, vision improved by 2 meters. The fundus was visible, retina was attached. The last follow-up was at 10 weeks following vitrectomy. Her vision had improved to 6/60. There was dense stromal edema with BCL and glue which was still in place, and the patient is listed for DSEC. So this is a follow-up which we can see at the day of presentation. There was infiltrate and exudates behind the anterior chamber IOL. In figure 1C, we can see the glue in BCL. This had actually dislodged at the time of vitrectomy, and we had to re-glue and put a BCL at the time of vitrectomy. So to discuss, the suture-related infections are known in any intraocular surgery of the eye. However, late onset presentation in the form of endophthalmitis related to sutures in the eye are uncommon. Most reported cases have occurred after 2 to 3 years of ocular surgery in which suture caused keratitis and endophthalmitis. This case was challenging as loose suture site had corneal perforation, which gave track for infection to percolate into the posterior chamber, causing endophthalmitis and subsequently choroidal detachment. Cultures were, however, sterile, so there was a diagnostic dilemma which specific intravitreal antibiotic should be administered. So it is of importance to timely remove the sutures, preferably by 6 weeks, or if they are being left, if they are actually buried, the patient must be informed that he has to maintain a lifelong follow-up and should present whenever there is a need or he feels any kind of foreign body sensation. So to our knowledge, this is probably the first case reported of delayed onset suture-related endophthalmitis following 20 years after a complicated ECC. Thank you.
Yeah. Did this patient has any trauma or?
No, ma'am. There was no history of trauma. She just presented with diminution of vision, redness, and pain in her eye.
No, was there any systemic disease? Did you investigate for this diabetes and all? What was the blood sugar?
Yes, ma'am. Yeah, if her blood sugars, I mentioned in the first slide, she was systemically normal. There was no systemic illness. She was absolutely systemically okay.
And then did you give this piperacillin and tizobact eye drops to her?
Yes, ma'am. I had mentioned the piperacillin, tazobactam eye drops were also
At day
started.
8 to 11. Now, how are they prepared? Tazobactam and piperacillin eye drops?
These are actually come in the form of powder, and then we have to reconstitute just putting by the artificial tear drops, and then we administer them.
Okay. You can go to the next.
Dr. Abhishek? Can we have Dr. Abhishek?
Yes. Yes. Is my presentation visible?
Yes, we can see your presentation.
I'm sorry for the inconvenience. I'm Dr. Abhishek Upadhyay. I'll be presenting my case on spontaneous resolution of exudative retinal detachment in invoked Koyanagi-Harada syndrome. So our patient presented with the complaints of painless, non-progressive, sudden diminution of vision in both the eyes, right more than left, since the past 1.5 months. There was no history of any tinnitus, vertigo, headache, skin manifestations. There was no history of any chronic drug use. There was no history of previous ocular surgery or trauma. And the patient had presented somewhere else before coming to us. So during his previous history and examination, the vision in the right eye was finger counting 2 meters, and in the left eye it was 636. The primary physician had made a diagnosis of panuveitis with bilateral exudative RD. OCT macula was done in the outside center, and it showed a neurosensory detachment in both the eyes. And the patient was started on topical steroids and cycloplases. As we can see in the OCT photos, the right eye OCT showed a huge neurosensory detachment with a CMT of around 1242 micrometers. In the left eye, we see a shallow SRF, and the CMT was around 264 micrometers. When the patient presented to us, this was day 17 after the initial presentation. Now the vision had improved to finger counting 4 meters in the right eye and 6/36 in the left eye. The AC was quiet with bilateral pharmacological dilated pupil with pigmented and crenated KPs. The IOP was within normal limits in both the eyes. There was no significant refractive error or lenticular opacity. Bilateral anterior vitreous cells were present in both the eyes. However, the fundus showed changes. Both eye media were clear, but the right eye showed choroidal folds and the left eye had disc edema. As we can see on the upper left corner photo, the right eye shows choroidal folds. In the left eye, we can see disc edema very evidently. OCT macula was done on the same day, and to our surprise, the RD had settled without the use of any systemic steroids. In the upper photo, we can see that the right eye OCT shows a CMT of 233 micrometers with no SRF, from a CMT of 1242 directly to a CMT of 233 micrometers. And the left eye, the CMT was around 193 micrometers, no shallow SRF was present. FFA was done the next day. It was seen that there were bilaterally multiple hyperfluorescent pinpoint leaks in the early phase. And as we can see on the right corner photo, disc leakage was seen in the left eye in the late phase. So a plan of action, a diagnosis of probable leakage was made, and the RD had settled by then. So the patient was started on oral steroids in view of the disc edema and the leakage seen on FFA, and topical steroids after getting the necessary investigations. Post 2 weeks follow-up, the patient's vision had improved. The vision in the right eye was now 612 parts, improving to 612, and the left eye it was 618 parts to 612. Resolution of left eye disc edema was seen along with disc pallor. And we can see that the disc edema has resolved. Now, the OCT was again repeated and it showed further improvement. There are no RP undulations and the choroidal inflammation seems to be subsided. The discussion, systemic high-dose corticosteroids still remain the cornerstone of initial treatment for VKH. Along with corticosteroids, immunosuppressive agents have also been used to successfully treat VKH. However, acute VKH must be treated aggressively with corticosteroids initially for a minimum period of 6 months, along with introduction of corticosteroid-sparing agents. In a reported article where they have correlated the resolution of subretinal fluid with systemic corticosteroid treatment in acute VKH, they've also told that the serious retinal detachments generally resolve in a matter of 36 plus minus 24 days in patients with acute VKH, but they were all treated with oral corticosteroids. A similar case also been reported, early resolution of SRF in a pregnant patient, where they only used topical betamethasone, and there was full resolution of bilateral subretinal fluid in a matter of 19 days. However, the patient was receiving 5 mg prednisolone OD for the last 8 years for rheumatoid arthritis. So in conclusion, there are very few cases reported in literature in which there is spontaneous resolution of SRF in VKH. So we present a case in which a middle-aged man with spontaneous resolution of bilateral exudative RT with a diagnosis of probable leakage without the use of any oral or systemic corticosteroids in a span of 17 days. The patient was using topical steroids, which may have helped in the resolution. However, the precise mechanism behind this still remains unclear. Thank you so much.
Yes. What were the other systemic features patient was having of VKH?
No other systemic features were present. He did not have any complaints apart from vision loss. He did not have headache or fever, nausea, any tinnitus, any ocular problem, auditory problems. He did not have any depigmentation. So there was no other systemic abnormalities.
So you diagnosed it on the basis of multiple exudative detachments the patient was having.
Yes, ma'am. There was also anterior uveitis for which the patient had been treated. And the FFA showed characteristic findings that were more pointing towards VKH.
Okay.
A diagnosis of probable VKH was made, ma'am.
Okay. We can go to the next presenter.
Dr. Sayali, are you there? Dr. Sayali?
You can hear me?
Yeah.
Yeah. Please share your screen.
You can see my screen?
Yeah, we can see your screen.
Slideshow. Ma'am, I'll start.
Yeah.
Slideshow. Yes, ma'am. So, ma'am, the title of my topic is Optic Disc Edema, an Insight to the Inside. Coming to the introduction. So, optic disc edema, as we know, is a swelling of the optic nerve with variety of etiologies. Clinical causes associated with unilateral disc edema are optic neuritis, NAION, optic neuropathy, red RVOs, and diabetic papillopathy, etc. Cases with bilateral optic disc swelling are often associated with papilledema, toxic optic neuropathy, and malignant hypertension. So, therefore, a detailed history about the chief complaint, a systemic history to find the association of any, and a complete ophthalmic examination is crucial to clinch the diagnosis. Optic disc edema, depending on the time since it has developed, could or could not affect the visual acuity, but an early diagnosis could lead to a better prognosis of any visual loss or of the associated systemic disorder. So I'll be talking about 4 such cases who actually who had no systemic complaints, who presented to the ophthalmology OPD to us and were diagnosed with a systemic condition based on an ophthalmological examination. So the first case was a 45-year-old male who presented with blurring of vision in the right eye for distance since 5 days. So his distance visual acuity in the same eye was 6.9, which was improving to 6.6 partial with pinhole, with a near vision of N6, and the other eye was normal. Anterior segment, a best corrected visual acuity was improving to 6.6, but on a dilated fundus examination, there was a right eye optic disc edema with a central retinal vein occlusion, as you can see in the top picture, and left eye was normal. On panel of investigations, the patient came out ANA positive, and after rheumatology physician's opinion, he was diagnosed with SLE. A second patient was a 65-year-old male who presented to us with diminution of vision in the left eye since 20 days. Visual acuity in the same eye was counting fingers at half meters with a near vision of N36. He also showed a grade 3 relative afferent pupillary defect in the left eye. Otherwise, the anterior segment was normal. On fundus examination, the left eye showed optic disc edema. On investigations, his blood sugar levels were raised with a raised HbA1c levels of 8.1. Therefore, we suspected diabetic papillopathy, and a physician reference was again taken, and the patient was therefore diagnosed with optic neuritis secondary to diabetes mellitus and was managed medically. The third case was a young female, a 22-year-old female who presented to us with a complaint of diminution of vision in both eyes since 1 week, which was sudden and progressive. She had a positive history of taking AKT for the last 7 months. She was on second line. Also had a history of peripheral neuropathy 2 years back, which was just managed with oral vitamin B12 supplements. On examination, her visual acuity was decreased in both eyes for distance and near. It was finger counting at 2 meters. And color vision was defective in both eyes. It was 2/17. Fundus examination revealed optic disc edema in both eyes. The patient had a history of taking the drug linezolide for a period of 7 months, and because she was not on ethambutol, she was on linezolide, which was we suspected to be causing the toxic optic neuropathy. And a discontinuation of the drug improved the vision to 6/6 and color vision to 17/17 over a period of 1 month, which confirmed the diagnosis of ATT-induced toxicity secondary to linezolide. The fourth case was a 40-year-old male who presented to us with a diminution of vision in both eyes since 1 day. His visual acuity was counting fingers at 2 meters, not improving with pinhole in both eyes. Color vision was defective, and he also had a grade 3 RAPD in the left eye. Rest anterior segment was normal. Optic disc edema was noted with disc hemorrhages and attenuated vessels in both eyes. And on checking his blood pressure levels, they were 200 by 100 millimeters of mercury. So therefore, we suspected hypertensive papillopathy and referred the patient to the physician. All these patients, due to the early referral, the visual acuity improved very well. So therefore, we would like to say that on complete ophthalmic and further systemic evaluation, one patient had disc edema due to inflammatory cause like SLE, one other patient had due to toxic cause like linezolide toxicity, and other two had it due to vascular causes like DM and hypertension. So each patient is medically managed and visual acuity improved. As seen in all the above cases, patients presenting with sudden decreased vision or sudden loss of vision need a complete systemic workup in addition to a complete history and ocular examination. In many of these patients, visual loss may be the only telltale sign of an underlying systemic disease, which may be vision threatening or life threatening as well. Also, patients who are on multiple systemic medications for tuberculosis or MDR tuberculosis may develop vision threatening side effects, which if diagnosed early could be reversible. Therefore, the vision monitoring in this group is very important. Therefore, in conclusion, the eyes are not only a window to one's soul, but quite literally windows into one's body. As seen in the above cases, each case's initial presentation happened to be a visual loss and no other systemic symptoms. Complete ophthalmic examination showed disc edema. All the patients had an underlying systemic condition, hence every patient presenting to the emergency room with visual loss and found to be having disc edema must undergo an extensive history and complete systemic evaluation, which can sometimes help to diagnose even life-threatening conditions. Hence, not just ophthalmologists, but even physicians should know how to do a direct ophthalmoscopy. So basically, we thought of working on this because we wanted the physicians, actually the residents in the ER, the medicine residents or the emergency medicine residents, to also keep this in mind, because ophthalmology residents are not always available in the ER per se. So that was the... Thank you, ma'am.
Ninth is fine. Ninth is fine with me, Honor. Ninth is fine with me. Ninth is second Saturday, na?
Yeah.
Ninth is Tuesday, Saturday.
Okay. We can go to the next
February.
speaker.
Dr. Vaibhavi, can we have your presentation?
Just hold on, please.
Am I audible? Yeah.
Is my screen visible?
Yes, we can see your screen.
Please keep it in the morning.
Yes, ma'am. Your screen is visible.
Thank you. Good afternoon, everyone. My today's topic and purpose is to evaluate use of intravitreal biosimilar anti-VEGF as an adjuvant treatment in case of a choroidal tubercle. I will like to share the case history of a 25-year-old male who represented to us with a history of diminished vision in left eye since 10 days, weight loss, evening rising fever since 6 months. He came with the complaint of diminished vision in left eye, which was 0.6 log MR, that is 6/36 at that day, with IOP in both eyes 14 mmHg. We did the detailed examination of the patients, including visual acuity, fundus examination, OCT, fundus photographs, angiography, systemic investigation, including HRCT thorax. Patient was given AKT with the systemic steroids, and due to persistent SRF after 1 month of the systemic treatment, we decided to give intravitreal ranibizumab. Here we can see the fundus photograph of the patient, which is showing yellowish white choroidal mass with SRD in left eye. We did angiography of the patient as well, which showed in both eyes early and late hyperfluorescence, along with late pooling due to SRD in the left eye. In OCT examination, we could find the choroidal bulge and SRF as well. There was increased EDI as well. On B scan, we could see the hyperreflective foci as well. In complete systemic evaluation, we discovered the associated lesions like Coats spine and miliary tuberculosis. Thus, we decided to give AKT to the patient along with the systemic steroids. Despite 1 month of the treatment, he showed us the persistent SRF, for which we decided to go with the intravitreal ranibizumab. After which we could see that the visual acuity, which was 0.6 log MR pre-treatment, post ATT after 4 weeks it was 0.6, post anti-VEGF after 3 weeks it come to 0.2, and post month it come to 0, that is 6/6. Central macular thickness, which was 779 pre-treatment, came to 705 after ATT, and after anti-VEGF it come to 399 and 271 after 4 months of the anti-VEGF. The same results can be seen in the EDI as well. We can see it in the OCT findings as well. That is, after 4 weeks, there was persistent SRF, after which we gave the anti-VEGF, which caused a decrease in SRF. And post 4 months, we could see the complete resolvement as well. So our result, which we saw, was primary outcome suggestive of fast of the tubercle, resolvement of the SRD, and secondary outcome was improvement in visual acuity, change in the central macular thickness, and change in the choroidal thickness as well. That is because of the high vascular nature, which is evident by angiography, and increased expression of the VEGF within the retinal layers. In active ocular TB, the anti-VEGF restores the breakdown of the blood retinal barrier and reduces the granuloma vascularity, thus causing prompt regression of the granuloma, preventing visual loss and decreased recurrence rate as well. Thus, it is a useful adjuvant treatment. So, I would like to conclude that intravitreal anti-VEGF decreases the tubercle size and SRD along with ATT. Thank you. Hello.
Okay, thank you, ma'am. Can we have?
Yeah, I was just want to ask, is the first case where this choroidal CMT and choroidal thickness has been measured in a patient on ATP?
Ma'am, there are 2 cases in which one article by Dr. Rima Bansal and one article by Dr. K. Babu, in which both have used bevacizumab. Here we have used ranibizumab, and both articles shows that there is decreased SRT and CMT as well. And in the Rima Bansal ma'am's article, they have also shown that there is no recurrence till 1 year. We have followed the patients for 4 months, and we will like to follow him up till 1 year.
Recurrence of what? Like decreased of vision, or what recurrence?
What, ma'am? Recurrence of the recurrence of the tubercle as well, the SRD, and any symptomatic presentation from the patient side. Patient is maintaining 6/6 vision till date, ma'am.
Okay. You can go to the next one.
Thank you, ma'am.
Dr. Anil Solanki, can we have your presentation?
Yeah, am I audible?
Yes, you're audible.
Is it visible?
Yes, we can see your screen.
Okay. I will be talking about a case of sustained elevation of intraocular pressure in treat and extend anti-VEGF regimen for wet AMD. Okay. My patient was 82-year-old male who was doctor by profession. He came with the complaint of diminution of vision and metamorphosia in his right eye in June 2019. The duration of symptoms were from last 2 weeks. On examination, best corrected visual acuity in right eye was 612, in left eye it was 6x. Intraocular pressure by non-contact tonometry was 12 and 14. On slit lamp examination, both eye was pseudophakic, rest anterior segment examination was within normal limit. So we did the dilated fundus examination. On that, we could see both eye disc and vessels were within normal limit. Where in the right eye, we could see a grayish membrane and retinal hemorrhages at the macular area in right eye, and drusen's were seen in the left eye. So we did the OCT. In the OCT, we could see the hyporeflective spaces in the retina as well as sub-RP space suggestive of intraretinal fluid and serous PED. So we went ahead with the FFA for the conclusion. In the late recirculation phase, we could see the hypofluorescence corresponding to the hemorrhages as well as hyperfluorescence, which was increasing in size as well as intensity with time suggestive of leakage. So we reached at the diagnosis of occult CNVM in right eye and dry AMD in the left eye. So we advise the patient for right eye intravitreal injection Eccentrix for 3 loading doses starting from the July 2019. Patient underwent the injection, and after 1 month, at 1 month follow-up in August 2019, the best corrected visual acuity in right eye was 619, intraocular pressure was 16 and 15, and there was minimal intraretinal fluid. So we went ahead with the injection and again followed up after 1 month. So in September follow-up, the acuity was maintained and there was no intraretinal fluid, but IOP was increased in the right eye. So we suspected there must be something. So we did the gonioscopy. In gonioscopy, angles were open. Because of the raised pressure, we started the patient on eye drop travoprost and gave the injection and followed up again. So if we compare the right eye pressures, after first injection, before first injection was 12, after first injection there was 16, then it went 24. Then we planned the patient on treat and extend regimen for further course, and the next injection was planned in the mid-November after 6 weeks. In November follow-up, his pressure was 28 despite on putting one anti-glaucoma drop. There was no intraretinal fluid and pressure was 28. So we increased the anti-glaucoma drops. We added timolol and brimonidine, and because of the raised pressure, and we gave the injection in mid-November. We again follow up him in the January before in the second injection after 8 weeks. Despite 3 drops, his pressure was 26. Everything else was same. We discussed it with the patient and he said he want to go ahead with the injection. So we did, because of continuously raised pressure, we were concerned about the glaucoma damage. So we did optic nerve and RFL parameters also, but they were within normal limit. After that, the third injection of the treat and extend regimen was planned in the end of March, but because of the lockdown, we couldn't give that. And the patient was followed up after March, he followed up in July, and the pressure on 3 drops, it was 19 in the right eye, and without any drop, it was 18 in the left eye. So because there was no edema, we followed up on him without giving any injection in August, September, October, and pressure is borderline with 3 drugs. So which raised the question, did the anti-VEGF therapy which we gave contributed to the patient increased in IOP? So we did the review of literature, which showed that there are studies which showing this both short-term as well as long-term raised IOP. The short-term is very common. It was also seen in landmark studies like Marina and Anchor. In 90% of the patient, because of increased volume, short-term IOP increases, but it settled down after 30 to 60 minutes, and it typically doesn't require any treatment. Whereas long-term IOP is seen in 3 to 10% in different studies, and there are different mechanisms which are proposed, like damage to the trabecular meshwork because of increased volume in the eye, or because of inflammatory cells block it, or there's alteration of nitric oxide pathway. And recent studies also showing there's certain genetic predisposition showing CD36 polymorphism. Studies are showing that greater the number of intravitreal injection, greater is the association with the IOP elevation. Usually it is more than 6 injections, but in our case, it started even after 2 injections. And different study also found out that sustained IOP elevation is also associated with shorter interval between the injection, that is less than 8 weeks. If we compare the 3 anti-VEGFs, it is maximum with the bevacizumab, followed by ranibizumab, and least with the aflibercept. So primary risk factor seen with different studies are an elevated baseline IOP, pre-existing diagnosis of glaucoma, increased number of injection or decreased time interval between injection, and shorter axial length. Age and gender have not been shown to be the potential risk factors. So the take-home message from this case is we should always do a baseline IOP measurement prior to treatment, and we must monitor our patient closely and perform periodic IOP evaluation. It can even occur with the treat and extend, which is shown doesn't cause the raise in IOP, and they may require ocular hypotensive medication to maintain the normal IOP. Thank you.
Okay. So, how many cases have been reported in the literature of such kind? Like,
There are different. Yeah, there are different studies which have even seen 4,000 cases, and out of that they have seen that it is seen in 3 to 10% of cases. This is just a single case, but in our case it occur after 2 injections. Usually they have shown it occur after at least 6 injections. So we have to be careful if we are giving anti-VEGFs. And there was no
angle was open on gonioscopy?
Yes, ma'am. Angles were open. Baseline IOP was normal, and disc was within normal limits. There was no sign of pre-existing glaucoma.
Yeah, was the patient having family history of glaucoma?
No, ma'am. No family history.
And what was the axial length of the patient, of the eyes?
Ma'am, we didn't do the axial length. Yes, we missed that.
You have told that this is one of the risk factors.
Yeah, it is significant in hypermetro. So that is for short-term elevation.
Okay, we can go to the next.
Dr. Prashant Jain, can we see your presentation?
Am I audible?
Yes, sir.
Good morning, all. Sorry, good afternoon. I'm presenting real-world evidence of safety profile of intravitreal bevacizumab in an Indian scenario. So the aim of the purpose of my study is to evaluate the safety profile of intravitreal bevacizumab as an off-label pharmacotherapeutic agent for various ocular conditions. It's a retrospective analysis, and it was carried out on 3,806 eyes of 1761 patients that were administered with intravitreal bevacizumab injection at a tertiary eye care center in India. The injections were administered on a PRN basis for various indications such as AMD, diabetic macular edema, and retinal vein occlusion. Patients with less than 3 months of follow-up were excluded from the study. A computerized electronic medical record of the patient were created, and all the other ocular and systemic adverse events were noted. And those who were administered intravitreal avastin were evaluated thoroughly and included in the study. So the mean age of the study population was 61.8 with the standard deviation of 11.59 years. It's a range of 10 to 96 years, of which 59% were men and 41 were women. Out of 1761% patient, the 68.3% were having pre-existing diabetes mellitus, 44.9 were having hypertension, 8.1% were having history of ischemic heart disease, and 12 patients, that is only 0.7%, were having history of prior cerebrovascular accident. So the main indication for injection was DME in 27% of the patient, ARMD 26, BRVO, CRVO 11 and 12%. In vitreous hemorrhage, it was 10, PCV 8, and others was 6%. So the maximum number of injection were given in PCV 2.95 with the standard deviation of 1.78, followed by AMD 2.84 and DME 2.29. So the mean number of injection were 2.16 with the standard deviation of 1.56 and a range of 1 to 15 injection. there were no systemic adverse event noted in our study population. In the ocular adverse drug reactions studied on 3,806 sites that were injected with injection, 3 patients developed endophthalmitis, that was 0.07%, and 35 had IOP rise of more than 21 mm of mercury, that is 0.9%. But the p-value was not significant for IOP rise, even for endophthalmitis. The p-value was not significant. The IOP rise was more significantly seen in the patient with pre-existing glaucoma as compared with the patient without any history of glaucoma in the past. The p-value was 0.04. When we closely analyze the correlation of IOP rise with the various disease entities, we have found neovascular glaucoma and CRVO to be the significant associated with raised IOP post-injection, and p-value was significant. Also, subjects who have neovascular glaucoma were 9.15 times at a higher risk of developing a rise in IOP compared with the non-neovascular glaucoma patients. We did not find any significant correlation between the number of injection and occurrence of adverse events such as IOP rise and endophthalmitis in our study. And there were no reports of retinal break or cataract development because of the injection in our study. So in recent time, with the advent and increased use of anti-VEGF for the intraocular use, there has been a paradigm shift in the management of various medical retinal pathology, including neovascular glaucoma, DME, and RVO. Numerous trials were conducted worldwide like CAT, EVANS, ZEPHYL, MANTA, and thousands of patients have been shown intravitreal bevacizumab to be non-inferior to Lucentis, that is ranibizumab, in terms of efficacy and safety. Bevacizumab also has the advantage of reducing the cost of therapy, especially in developing countries where the population access to resources is limited, and it helps to reduce the financial burden of multiple injections. But in recent time, sporadic episodes of endophthalmitis post-intravitreal Avastin have created a big debate about the safety of Avastin as an off-label medication. And we carried out a thorough PubMed search, and it revealed a lack of substantial data on the safety profile of intraocular use of Avastin on an Indian population. So as a major tertiary eye care center in India, we decided to conduct a retrospective analysis on the safety profile, and which was performed in the past 3 years at our center. It was amounting to 3,806 injections. In our study, we observed endophthalmitis in only 3 patients, that was 0.07%, and which was comparable to the other studies conducted in the Western world. The factors contributing towards such favorable safety profile would include allocating and storage of Avastin under optimal septic precautions, maintaining excellent perioperative sterility, and giving intravitreal injection under strictly followed aseptic conditions. Of the 3 patients with endophthalmitis, 2 responded to intravitreal antibiotics, and whereas 1 underwent vitrectomy. Although bevacizumab continues to be an off-label therapy used in treatment of ocular disorders, it remains to be the preferred agent of retina physicians worldwide. For chronic diseases such as DME and AMD that require frequent dosing, bevacizumab provides an ideal economic choice of treatment, especially in the developing nations. However, allocating of Avastin and its potential ocular and systemic adverse reactions continue to remain the limiting factors for its extensive use. Our study, the first of its kind in India, provides real-world evidence regarding the safety profile of intravitreal bevacizumab for long term. We have analyzed the patient for 3 years. This data suggests that bevacizumab is a safe and economical pharmacotherapeutic agent that is used for the treating as a variety of ocular disorders, and favorable outcome can be achieved by maintaining optimal sterility during the allocating step, intravitreal injection procedure, and perioperative care. Thank you.
I just want to ask, though it's a very big analysis, but nowadays this is still an drug control of Journal of India banned drug, no, Avastin.
Yeah, but no, they have revoked that ban in 2017.
No, but still we are not finding it. Is it available in the market?
Yeah, it's available, and with proper guideline from Vitreoretina Society of India, we are doing proper allocating and we are giving the injection. Right now, presently also we are giving it. It was banned for a limited period of time for 3 to 4 months, but it was revoked in 2017 early, and they have issued the guideline, and now we are allocating the drugs and we are giving the drugs with the proper guideline from Vitreoretina Society of India.
You are allocating at your own center?
Yeah, we are purchasing that from Roche. They have even mentioned all the guidelines that we have to purchase from the Roche, and then we are allocating at our center, and we are discarding the medicine if they are not using within 14 days.
How are you allocating? Like you are having some pharmacy over there?
No, we don't have pharmacy. Generally, with a single prick injection, we are making this many injections, like 14 injections we used to make from one particular medicine, and then we used to keep it in under safety precaution, and then we have to use it in within 14 days.
But that is not a Actually, what is allocating means that it should be single dose actually.
See, the thing is that allocating right now, which you are talking, it's presently only AIMS is doing that allocating, but under the guideline which VRSI has VRSI has started in 2017. According to that protocol, we are allocating the drugs.
Okay. We can go to the next speaker.
Thank you.
Dr. Pratiru, please start sharing your screen.
Yes, I'm here. Am I visible?
Yes, we can see your screen.
Okay. I'll start.
Yes, please start.
Good afternoon. Today I'll be talking about the efficiency of intravitreal ranibizumab in diabetic retinopathy, monthly versus PRN protocol. Diabetic retinopathy is the major complication of diabetes mellitus, which remains a leading cause of visual loss in working age populations. The most common cause of vision loss in patients with diabetic retinopathy is diabetic macular edema. Diabetic macular edema is characterized by swelling or thickening of the macula due to sub and intraretinal accumulation of fluid in the macula triggered by the breakdown of blood-retinal barrier. Intravitreal administration of anti-VEGF agents is currently the mainstay therapy for both early and advanced stages of diabetic retinopathy. Ranibizumab is a recombinant humanized IgG1 monoclonal antibody fragment that binds to and inhibits vascular endothelial growth factor A. Ranibizumab binds to the receptor binding site on VEGF-A, which inhibits the binding of VEGF molecules to their receptors on the surface of the endothelial cells. The recommended dose of ranibizumab in DME is 0.3 milligram administered once a month by intravitreal injection. Now, the objective of our study was to compare the macular thickness in patients with non-proliferative diabetic retinopathy with CSME after receiving intravitreal ranibizumab following monthly and pro rata or PRN protocol. The patient profile we selected were patients who were attending the OPDs with diabetic retinopathy in Midnapur Medical College. Our sample size was 50 patients with NPDR with CSME. Our age distribution was between 55 to 72 years with an average age of 64.2 years. The sex and ethnicity was matched. HbA1c of each patient was done, and it was less than 77%, signifying a good control. 50 patients were divided into two groups of 25 each. Group A consisted of monthly protocol and Group B consisted of pro rata protocol. The central macular thickness was measured pre-injection and on each follow-up using spectral domain optical coherence tomography, and BCVA was also recorded using Stennon's chart. The PRN protocol consisted of 3 loading doses were given monthly, followed by 4 weekly assessment. Retreatment was giving an increase of CMT by 100 micron at appearance of any new subretinal or intraretinal fluid. Follow-up was continued for 12 months. Now here we can see in Group A, where the patient received monthly injections, the pre-injection and post-injection post-injection follow-up at 12 months, we can see that there is a significant decrease in the macular edema. Here we also see there is a significant decrease in macular edema in Group A patients. Now in Group B patients, where the patient received by PRN protocol, there were certain decrease in central macular thickness, but still there's some amounts of edema remained. In this case, we see that even there is an increase in central macular thickness at the end of the 12-month follow-up. Now from this chart, we can see that the decrease in central macular thickness in case of patients receiving monthly injection was significantly greater than PRN protocol. Here also we see that the change in central macular thickness between the two groups was significantly different. Now we see that in case of PRN protocol, the number of injections received were less than the monthly protocol at 8.23%. But the best corrected visual acuity was also less, with only 3.89 lines improvement in comparison to 5.13 lines improvement in case of monthly protocol. Now, Pruenci in his written study confirmed the well-established efficacy and safety profile of ranibizumab and demonstrated that ranibizumab treat and extend regimens were non-inferior to PRN in patients with mild to moderate vision loss. Yoshiro M. et al. In their study showed significant decrease in CMT following intravitreal ranibizumab at 2 hours, 1 month, and 2 months post-injection. Jiang Wei et al. In their study concluded that the use of ranibizumab 0.3 milligram PRN resulted in suboptimal visual gains and decrease in CMT. Our findings indicate that monthly intravitreal ranibizumab is superior to PRN dosing in decrease the central macular thickness of patients with NPDR with CSME. Thus, PRN cannot be used as an alternative for monthly injections for the treatment. The limitation of our study was our sample size was small. We were not able to age match the sample population in the groups. We had no associated financial benefit. These are my references. Thank you.
Could I ask that in the first group you gave monthly injection for 12 months?
Yes, ma'am.
Means you gave 12 injections and then you assess the patients for CMT and all and best corrected visual acuity. And the other
we did a monthly follow-up, but the injection was there is a protocol that if you have to give the injection for 12 months so that there is a complete resolution. So we went for 12 months on that one.
Injections you have given in one group, and in the other group you gave 3 injections and then you followed up and gave injections according to CMT. This is what, no?
According to CMT, yes, ma'am.
On an average, like how many injections were given in PRN group? Like 12 in the first group to each patient, and if you ran up all the patient on average,
8.23 injection. About 8.5 injections were required in case of the PRN group.
Oh, thank you very much. Please go to the next presentation.
Dr. Ritesh, can we see your presentation?
Hi, am I audible?
Yes, you're audible.
Yeah, I'll share my screen. Is my screen visible now?
Yes, we can see your screen.
Hi, good afternoon all, and I'll be talking about reactivation of ROP following bevacizumab monotherapy in aggressive posterior retinopathy of prematurity. And this is not a single study, but a compilation of different studies we have done at our center. So why I've written it as a wonder drug in my first slide is because it causes immediate regression of APROP on the next day. As you can see in this picture, which is 29 weeks APROP patient. This picture was taken 16 days post-injection, which shows a rapid regression of the plus disease. So reviewing some of the things in this context, the APROP was defined by ICROP in 2005. And in 2011, the BEATROOP trial, they published for the first time for the efficacy of bevacizumab, which was followed by a literature boom. And then in 2016, they again published to tackle the reactivation following the bevacizumab injection. And now we have the RAINBOW trial, which is now propagating ranibizumab. And there are so many gray areas regarding the use of bevacizumab in APROP. So we started investigating the drug to find out the incidence of APROP at our institute and the timing and risk factors for reactivation after the injection. We also try to define the follow-up period after the injection, the use of the double frequency green laser, and the IOP rise post-injection. So this study was conducted from August 2019 to July 2020, wherein we injected intravitreal bevacizumab in bilateral eyes of the APROP patients in a single sitting in our operating room. And the injection was given 1.5 mm from the limbus, and the drug was injected directly into the midvitreous cavity after visualizing the needle in the midvitreous, and a tamponade was given for a few seconds. And the post-operative regression was defined as complete regression of tunica vesculosa lentis or complete regression of plus disease and neovascularization as seen in this picture, which was taken at 4 weeks after the injection. Post-operative reactivation was defined as recurrence of plus or the progression of neovascularization either at the original edge or at the secondary edge after the retinal progression of retinal vascularization, as you can see in this picture, which has a zone 1 reactivation at 12 weeks post-injection. So we total of 355 patients were screened in the study period, and the incidence of ROP at our institute is 27.6%, out of which 11.2% were treatment requiring ROP, and 12 patients developed APROP in bilateral eyes, and they received intravitreal bevacizumab in both the eyes. So in our study, multiple pregnancy, a lower mean birth weight, and in neonatal morbidities, the sepsis and necrotizing enterocolitis were significantly related to the development of APROP. And reactivation in our study was in 33% of our cases, whereas in the Western studies it has been reported to be 31 to 41%. And there are various treatment modalities for reactivation, including repeat injection, laser, or a past planar vitrectomy, but we performed laser in all our cases. So the mean time between the initial treatment and reoccurrence was 11.8 weeks, and the mean post-menstrual age was 44 weeks. And Blair and Shapiro have mentioned a 19.2 weeks in their study, the time of reactivation. We also measured the intraocular pressure by a tonopen on preoperatively day 1 week, and 1 month post-injection, and we found that on day 1, the intraocular pressure is significantly higher than the preoperative, and it returns to baseline at 1 week and 1 month follow-up. But we have not taken the intraocular pressure immediately post-operatively because of the speculum, because of the confounding factor by the speculum, as it causes rise in intraocular pressure. And because there is a varied regression patterns of the APROP due to chronic vascular arrest and immature retina with peripheral shunting, so the follow-up is not well defined in literature. So we followed up all our patients weekly for the first 3 months, then bi-weekly, and then we followed up monthly. Either there was a complete revascularization, or we performed laser in these babies. And we recommend the strict follow-up till 3 months post-injection. And we have also published regarding the safety of double frequency laser in ROP spectrum. And the technique is pretty much simple, same as the diode laser. And we propagate delayed laser when there is reactivation as compared to adjuvant laser with the injection, as it causes early washout of the drug from the vitreous cavity and early reactivation. And we also started measuring the HB levels in these babies, because we had a case where there was a delayed reactivation, where the vessels had reached in zone 3. There was a zone 3 chronic arrest of the vessels, but there was a reactivation of plus disease, and the baby had HB of 4. So, but there was no significant difference between a type 1 ROP and APROP and the reactivation group in terms of the hemoglobin levels. But these should be kept in mind when we are talking about the reactivation. So the key messages in our study is there is always a risk of reactivation post-injection, and that there is transient IOP rise should be expected after the injection, which can return to baseline in 1 week and 1 month follow-up. And persistence of avascular retina and chronic vascular arrest occur in most of these babies, and these should be followed up to 5 years. And delayed laser should be performed in these cases when there is reactivation. And other systemic causes should be ruled out when there are cases of delayed reactivation. That is all. Thank you.
Okay. Dr. Ritesh, how many injections did you give to each? Only one injection to each baby?
Yeah, ma'am. We give a half dose injection in each eye.
Yeah, at one sitting only bilaterally.
Yes, ma'am.
And then when was the laser given in them? You tell that we did delayed laser.
Yes, ma'am. So the laser was only done when there was reactivation. So the average time between the injection and reactivation.
APROP does not. You must have seen something in zone 3, no? Then only you must have done laser.
No, ma'am. There are, in some cases there is zone 1 reactive. Only one. We had total of 4 babies which had reactivation in both the eyes. Only one patient had zone 1 reactivation, and rest of the 3 patients had zone 2 reactivation in both the eyes. So we did perform a laser in all these cases, and the mean time between injection and the laser was 11 to 12 weeks. That is around 44 to 50 weeks of post-menstrual age. Most of the cases.
How frequently did you follow up them after the injection?
Ma'am, initially we follow them up weekly, then for 3 months, then we try to follow bi-weekly and then monthly. If there is because most of these babies goes into chronic vascular arrest in zone 2. So we have to follow them up to 2 years or up to 5 years whenever they agree for laser or they agree for follow-up. So depending upon that, but we have almost lasered all the babies. 11 babies we have lasered in these cases, ma'am. Only one is on follow-up from past 1 year.
This was a study on how many babies?
So this was done on 12 babies, ma'am, but we currently have 34 babies in which we have injected.
So this means that APROP, even if it is injected, but still it will require a laser, not regress, as far as your study says.
Yeah, ma'am, it will require, because most of these, they go into a chronic vascular arrest in zone 2. So either they'll persist into zone 2, there will be some area of retinal, when there is avascular area, there is always a risk of reactivation or the retinal detachment from that area. So we have to perform laser in that avascular area. The avascular area remains in most of the babies. We have to laser it.
So you recommend that all the patients of APROP, even if they're after their injection also, they should be followed till 4 years of their age. This what?
No, at least 2 years. if there is a vascular arrest and there is a avascular area, they should be followed up. If there is a complete vascularization till up to 1 disc diameter is left, then we can, follow them up monthly or after 2 months. But I think they require a lifelong follow, ma'am. We can't leave these babies.
Thank you very much.
Thank you.
Dr. Diksha, can we see your presentation next?
Yes, ma'am. Am I audible?
Yes, you're audible.
Okay, I'm just starting screen sharing.
Yeah.
One second, please. Is my screen visible?
Yes, we can see your screen.
Okay. Good afternoon, everyone. My name is Diksha Gupta. I am a resident doctor at Civil Hospital, Ahmedabad. Today, I am here to present a case on anatomical and functional outcome of ERM peeling surgery. Epiretinal membrane is a thin sheet of fibrous tissue that develop on the surface of macular area of retina, which mostly does not cause any disturbance in vision, and mostly patients are asymptomatic. But there are cases which cause marked distortion of vision and cause macular distortion and macular edema, which induce clinicians to recommend ERM removal surgery by pars plana vitrectomy in such patients. This study is to assess the visual outcome and central foveal thickness in patients of ERM via pars plana vitrectomy. My study is of prospective cross-sectional type in which I took the 25 eyes of 25 patients with presence of ERM on macular area. To include the patients in the study, we made an inclusion criteria in which patients between the age group of 20 to 80 years with intraocular pressure less than 21 mm of Hg and unremarkable slit lamp examination with normal pupil size, shape, and reaction, patients are included. Preoperatively, we confirmed the presence of ERM on OCT as well. Clear media is patients with clear media taken for OCT, and patients included in this study must have visual acuity less than or equal to 6/12. That is on the logMAR of more than 0.3. Exclusion criteria, we put the patients less than 20 and more than 80 years of age with high intraocular pressure and poor fixation, or cataract patients which cannot be taken for OCT, or patients with having pre-existing retinal problems like macular hole, optic atrophy, VMT, CNVM, and such patients are excluded from the study. To start the study, first of all, we took the detailed clinical history of the patient, followed by the clinical examination, including vision without glasses, torchlight examination, slit lamp biomicroscopic examination. For fundus examination, we first take the slit lamp on slit lamp with 90D, direct and indirect ophthalmoscopy, followed by the OCT examination. Preoperatively, patients were assessed for all these three, and subsequently, patients were taken for the pars plana vitrectomy with ERM peeling. Post-operatively, I reassess the patient for best corrected visual acuity after 4 weeks and after 12 weeks of surgery. After assessing all the patients and analyzing the data, we find out the outcome that most of the patients of ERM having a distortion of vision are mostly in the age group of 60 to 70 years, followed by the age group between 50 to 60 years. Least patients are present below 40 years or above 70. Gender-wise distribution, male and female sex ratio is approximately equal with slight preponderance for the female. Best corrected visual acuity, the mean visual acuity of all the 25 patients was previously 1.04 on logMAR visual acuity chart, which improved to 0.86 after 4 weeks and 0.72 after 12 weeks, which after statistics come out to be statistically significant. Associated with central foveal thickness is also improved. Preoperatively, central foveal thickness was found to be was found to be 388 millimeter, followed which improved to 353 millimeter after 4 weeks of surgery, and 308 millimeter after 12 weeks of surgery. Both these findings are statistically significant. Later on, we try to associate between the decrease in the central foveal thickness and improvement in the visual acuity. So this scatter diagram revealed that there is a marked improvement in vision with reduction in central foveal thickness after removal of ERM. As the traction at the macula decreases, patient's metamorphosis symptom decreases, which gives the quality of vision to the patient. Previously, also various studies had been done on such topic. On such which give the similar result that there's a linear regression between the visual acuity and central foveal thickness of the patients. Associated with this, other studies are also previously happened on the ERM. So I conclude this case with that epiretinal membrane peeling surgery is in selected cases which have a marked diminution of vision, improved visual acuity after ERM peeling. Central foveal thickness and foveal architecture also significantly improves with ERM peeling surgery, which explains the good functional visual acuity. Thank you.
Okay. Like what are the indications according to you in which ERM peeling should be done?
Ma'am, patients with lesser visual acuity, in this case, we took the visual acuity with less than 612, or having a patients are having a functional problems. They cannot, they are not happy with their vision, or unsatisfied patients, lesser visual acuity, which shows in a fundus examination, fractional bands are present, which due to which patients cannot see properly. Such patients are taken for the surgery.
So does the grading of ERM also influence, or only you have symptoms of the patients will influence whether we should do surgery or not?
Ma'am, of course, we took the grading into consideration, but some cases are like that on fundoscopy is only grayish like membrane of first stage of ERM is present, but patient's vision is less or not any other pathology is seen. So we can at least explain the patients all the pros and cons, and if patient is willing, then we'll take, and it is seen that such patients also improve significantly.
What was improvement in your patients? How much by mean improvement in BCVA?
Ma'am, I took the visual acuity on logMAR visual acuity chart. So patients' mean visual acuity, which was previously 1.04, improved to 0.72 after 3 months of surgery, which is significant. And it is seen there. Okay, ma'am. Thank you, ma'am.
Thank you very much.
With this, we conclude this session. I would like to thank Dr. Punita for judging this session. And we'll start with the next session in 4 minutes.
Okay, I'll submit the marks in the mark sheet which has been given on my email just now.
Yes, ma'am.
Thank you very much.
Thank you, ma'am. Good afternoon, everyone. Good afternoon to Professor Rajpal Vora, who
Good
will be
afternoon.
good afternoon, sir. Sir will be judging this session for today. Since our first speaker is not there, I would like to request Dr. Sonam to start sharing her presentation. Dr. Sonam?
I'm here. Am I audible?
Yes.
Dr. So,
To remind everyone, each speaker is given 6 minutes for the presentation, followed by 2 minutes for discussion on each topic, and you'll be scored out of a total of 10 for your presentation. So, Dr. Sonam, please start with your presentation.
Warm greetings to the judges and colleagues. I am a junior consultant at Dr. Kishan Eye Care and Laser Surgery Center at Indore. My topic is of anti-VEGF non-responders. It's a case-based series. So the most common retinal pathologies which we are dealing with in our OPDs where we are required for anti-VEGF therapies are DME, retinal vein occlusion, ARMD, CNVM, ROP, and iris neovascularization where we inject intracamerally. So over the years, we have the anti-VEGF family to which the newest addition has been brolucizumab. All have different mechanisms of action. So here we have first the role of prognosticating markers, which are very much essential to study the progression, selection of therapies, and monitoring their response from time to time, and tailoring the management accordingly to further to counsel the patients about the probable outcome, which we understand from the condition of the retina. The biomarkers can be further divided into drug-related or disease-related, but both are quintessential in the management. My cases will include DME, RVO, and ARMD with case details and clinical pictures, non-responsiveness in the concerned cases, and solution pertaining to the problem, followed by biomarkers to be correlated with these entities. So the first case is of 72 years old female, a pseudophakic diabetic and hypertensive patient who had a history of intravitreal aflibercept given 3 years back, and followed by a steroid implant. She had a recurrence with complaint of blurring and presented with visual acuity of 3/60. Diagnosed with moderate NPDR and macular edema, she was given a trial of 2 aflibercept injections at the interval of 4 weeks. On switching to intravitreal dexamethasone implant, the visual acuity slowly improved to 624 with a steady improvement in her drill on the OCTs and also as per visual recovery. So here DEXA implant was helpful in way of combating the recurrence in tachyphylaxis. The second is of a 56-year-old male patient who was a diabetic and hypertensive. With 3 shots of ranibizumab, when we saw no improvement on OCT or visual recovery, aflibercept was then chosen, which caused resolution of cysts and edema as well, causing better visual recovery. So OCT can show the features, but at the same time, OCTA helps in quantifying these over the period of time and non-invasively assessing macular ischemia. The third case is of a BRVO patient. She was 62 years old, morbidly obese, diabetic hypertensive with varicosity and history of angioplasty. Complaint of blurring and visual acuity of 4/60. She was suffering from STBRVO with macular edema. Advice for steroid implant looking at her cardiac events recently, but she took aflibercept in elsewhere. And when she came, there was no improvement on OCT or the visual side. So we chose to give the DEXA implant. Over the months, another was repeated, and in between we gave a grid laser trial also, which caused better recovery with vision restoring up to 624 parts. The OCT biomarkers for RVO are presence of ERM, intraretinal cyst, drill, and ELM disruption. Fourth is a case of a neovascular AMD, where the person was, the gentleman was 71 years old, male. Angioplasty and dyslipidemia were the history, and the presenting vision was of 636. Over 2018 and 19, there was steady decline in height of PED because of ranibizumab given 4 weekly intervals and later on extended, but soon it was not resolving the subretinal and intraretinal fluid. So we gave aflibercept. Pre-lockdown, there was still some fluid left. So finally, when the patient could come, we gave him brolucizumab thrice. And at the last visit, only the subretinal fluid is now left with an improvement up to a 6/9 of vision. The OCT again helps to diagnose such cases and prognosticate, but at the same time, OCTA helps in seeing the other causes which might be cause of refractoriness. My take-home message will be that investigate thoroughly before labeling a patient as non-responder, whether to a molecule or a group has to be decided upon very carefully. Also, OCT and OCT angiography are a non-invasive prognosticating tool of very much importance with the recent biomarkers coming up. The wide field OCTA definitely will be a boon where FFA and ICG are contraindicated. For effective intervention, the basic need of all patients will be the stable metabolic control, and lastly, but not least of all, brolucizumab being the newest anti-VEGF. For that, the patient selection should be very careful with extreme precautions for reactions. I would like to end my talk here. Thank you so much for the opportunity and your patient listening.
What criteria, very well presented, what criteria you have taken for resistance cases in DME, non-responsive?
Sir, good afternoon. First of all, for the resistance cases, here I had seen the patients who were either had previous such presentation and were not responding to, a history where anti-VEGF was not very fruitful. And secondly, if usually what we go for is if we give 3 injections and we don't see any change on OCT, or there's visual recovery is not more than 3 letters, then we go for changing the agent given. And
Okay,
first of
thank
all,
you,
in the
Dr.
same
Sona.
group.
Thank
you,
you.
sir.
Thank you. Can we now have Dr. Nitin? Dr. Nitin, please start with your presentation.
Yeah, I'll start my screen sharing. Are my slides visible?
Yes, we can see your slides.
Yeah. Good afternoon, everyone. So good afternoon, sir. So my presentation is the paper I will be discussing is the outcomes of patients on second line ATT who were rifampicin resistant detected on RPOB genes sequencing. I have no financial disclosures to make. So for the introduction, diagnosis and management of intraocular tuberculosis is a challenge. The challenge is even greater when we have to manage the cases which have rifampicin resistance. Data on intraocular tubercular patients with rifampicin resistance is limited, and long-term follow-up of these patients is not available in literature. So our study aimed to explore the role of second-line ATT and need for immunosuppressive drugs in these patients. So we enrolled 7 patients who had been diagnosed as rifampicin resistance IOTB based upon the RPOB gene sequencing on the vitreous fluid analysis in these patients. The current study intended to assess the outcomes of these patients on second line ATT, which were having recurrences and persistent inflammation in spite of starting these patients on the second line treatment. So as far as the results are concerned, we enrolled 11 eyes of 7 patients, 2 were males and 5 females. The main presentation in our cohort was serpiginous-like choroiditis in 6 eyes and choroidal granulomas in 5 eyes. All these patients have previously received antituberculous therapy for at least 6 months and were later initiated on second-line ATT based upon the RPOB gene sequencing, as we suspected drug resistance due to non-response to the antituberculous therapy. However, in spite of starting these patients on second-line ATT, all these patients had recurrent inflammation and recurrences even on second-line ATT. So these are the demographics of our patients. We can see that most common presentations was the serpiginous-like choroiditis and choroidal granulomas. Most of the patients were diagnosed as resistant to rifampicin based upon the RPOB gene sequencing, which was done on the vitreous fluid of these patients. As we can also see, the most of the patients were young patients with all of them age less than 45 years. And in spite of being started on second line ATT, these patients were having persistent inflammation and recurrences. So these had to be started on second line ATT. And even after starting second line ATT, they were still having inflammation. And so we had to start these patients on immunosuppressive drugs. So this is one of the representative case, a 28-year-old female who presented to us with decreased vision in the left eye. The right eye vision was already less because of the inflammation in the right eye, which I will be showing in the subsequent slides. The patient had been diagnosed outside as viral retinitis, treated elsewhere as with antivirals. Then she was given a diagnosis of choroidal abscess in the right eye. So she was having a lot of this chronic uveitis going on. So this is the presentation. At presentation to us, the right eye was having this large scar at the macula. However, the left eye had vitritis cells and presence of this choroidal abscess in the nasal quadrant, which was seen very well on the FFA with a lot of leakage during the late phases. So we had injected this patient with ranibizumab, and simultaneously a vitreous tap was done, which showed the presence of Mycobacterium tubercular genome in the fluid, and along with that, rifampicin resistance was detected. So patient was started on oral steroids. The lesion started healing and was looking well healed at 3 months. However, again at 3 months of follow-up, there was an increase in the inflammation. The media went down, and there was activation of the inflammation along the edge. So the patient had to be injected with a intravitreal Ozurdex implant. However, after this, the patient also was started on azathioprine, and at least at the last follow-up of about 36 months, 3 years follow-up, the patient regained good visual acuity. However, there was some cataract was present, and there was no residual inflammation at three years of follow-up. So as far as the results were concerned, most of the patients had a chronic uveitis which had not responded to either ATT or second line therapy. So these patients sooner or later had to be started on immunosuppression. Mean time to start immunosuppression was at least 6 months. As there were 7 patients, 6 had to be started on oral azathioprine, and 1 required methotrexate oral methotrexate. However, we had also augmented the treatment with intravitreal methotrexate as well as Ozurdex injections. The main important point in this slide is that mean duration of IST immunosuppression required in these patients was at least 16 months, and we could follow up these patients for at least mean of 50 months. So there was not much improvement in the visual acuity, as these were already very inflamed eyes having a significant past history of chronic uveitis. So our study provides the first insights into the management of drug-resistant intraocular tuberculosis, as data on these patients is very sparse in literature. We highlight that the importance is that these patients, in addition to the second-line ATT, may require immunosuppression as well. This is the first study which shows such a long-term follow-up of these patients who were started on second-line ATT. And to conclude, the management of intraocular tuberculosis with drug resistance is challenging, and these patients may require long-term immunosuppression and then may respond fairly to treatment. Thank you so much for your patient hearing.
So what are the criteria of drug resistance?
Sir, basically these patients who were not responding, the non-responders to the main ATT, the normal regime which we are instituting, the ATT regime, we suspected the drug resistance. And then these patients were, the vitreous fluid was analyzed for this specific RPOB gene, which showed the positivity, and this sequencing led us to the diagnosis of this resistant tuberculosis.
So immunosuppressant was also started along with second line therapy.
Sir, immunosuppressant was not given initially. It was the patients were given second line therapy and oral corticosteroids, but still we noticed that at least at 3 months of follow-up, these patients were not even responding to second line treatment as well as we were expecting. So at this point of time, we suspected a delayed hypersensitivity type of reaction, which is seen in the normal patients who are started on ATT. That is why we started these patients on immunosuppression.
Okay, thank you.
Thank you so much, sir.
Can we have Dr. Rishabh with his presentation? Dr. Rishabh, please share your screen.
Yes, I'm doing that. I don't know, they're showing unsupported document type. Please select. I don't know. I'm not able to share. Give me 2.
Okay, till then we'll continue with the next speaker, Dr. Khushbu. Can we have your presentation?
Sure, ma'am. Is my presentation visible?
Yes, we can see your presentation.
So I'll start. Good afternoon, sir. My title for today is Posterior Segment Involvement, a solitary manifestation in a case of ocular sarcoidosis. An informed consent has been taken by the patient for sharing the details for academic purpose. Ocular sarcoidosis, as we know, is a multisystem granulomatous disorder and is one of the leading cause of inflammatory eye disease, which can involve any part of the eye or adnexal tissue. Ocular involvement is the presenting symptom in approximately 20 to 30% of the systemic sarcoid patients. Anterior segment involvement is seen in 80% of the patients. Posterior segment along with anterior segment is seen in 20%. However, the only posterior segment disease without any anterior segment involvement is very unusual. The most common anterior segment involvement seen is in the form of anterior uveitis followed by conjunctival nodules. And majority of these are bilateral and chronic in etiology. This is a case that I'm going to present had only posterior segment involvement, which appears to be a rare sign of ocular sarcoidosis. A 60-year-old female presented with blurring of vision of both the eyes, left eye more than right eye since 1 month. It was gradually progressive and painless. There was no other ocular history in the past. She's a known diabetic and hypertensive, which was controlled by oral medication. On examination, the best corrected visual acuity of both the eyes was 618. Normal intraocular pressure and color vision of both eyes. Anterior segment, the adnexa, the conjunctiva, and the iris tissue was normal. Gonioscopy revealed open angles with no granuloma, synechia, or neovascularization. Fundus showed media haze due to vitritis grade 2 in both the eyes. The top left 2 images is the first day of presentation when the patient came, showing optic disc edema in both the eyes with blurring of all the 360-degree margin, more in the left eye. The papillomacular bundle of the left area showed a few hard exudates, and in the right eye inferior periphery, we could see multiple small snowball opacities suggestive of intermediate uveitis. I'll come back to the rest photos later on. The patient OCT was done for macula, both eyes was normal. Systemic investigations showed higher AC levels, which was increased to 98 units per liter. LDH level was also increased to 340 units per liter. Chest X-ray showed bilateral hilar lymphadenopathy, which is shown in the photo here. The other investigations such as MON2, gamma interferon assay, C-ANCA, P-ANCA, and RA factor were negative. Thus, a diagnosis of presumed ocular sarcoidosis was made. She was started on oral steroids 1 milligram per kg dosage, tapered weekly, followed by a maintenance dose of 10 mg for another 4 months. Topical treatment was stopped later on as no anterior segment involvement was seen. On subsequent follow-up, the visual acuity had improved to 6.6. The left lower two photos are at 2 months follow-up. The optic disc edema had resolved. The hard exudates had resolved. The inferior periphery was noted and recorded in the same area, and the snowball opacities had also disappeared. So, according to the first international workshop on ocular sarcoidosis, which was conducted in 2007, the international criteria for diagnosis of ocular sarcoidosis consists of 7 clinical signs, 5 lab investigations, and there were 4 diagnostic terms which were given for ocular sarcoidosis. So the 7 clinical signs were mutton fat KPs, iris nodules, trabecular meshwork nodules or synechiae in the peripheral anterior synechiae, snowball or stinger pearls vitreous opacities, chorioretinal peripheral lesions, nodular or segmental periphlebitis, optic disc nodules, choroidal nodules, and bilateral inflammation. Investigations include a negative tuberculin test, elevated AC level, a positive chest X-ray showing bilateral hilar lymphadenopathy, abnormal liver enzyme test, and an abnormal chest CT scan in a patient with a negative chest X-ray. However, the gold standard for diagnosis is tissue biopsy, but sometimes the suspected lesion may not be accessible. So this criteria is very helpful in diagnosing the patient. So according to the case that I presented, we had a diagnosis of presumed ocular sarcoid, as we could see bilateral hilar lymphadenopathy with a compatible uveitis, although the biopsy was not done. So in a clinical practice, normally when we start diagnosing a patient, the chest X-ray is the first modality that we get done, and reserve the chest CT scan for a highly suspicious patient or for whom in which the diagnosis may change the therapy. Also, the blood tests such as AC level, lysozyme levels, and the liver enzymes are not very sensitive or specific for the diagnosis. But the whole criteria, if we combine the chest X-ray along with the blood investigation, we can still come to some diagnosis, ruling out the other possible etiologies. Thus, I would like to conclude by saying that ocular sarcoidosis may present with a wide variety of ocular symptoms. The diagnosis may be difficult owing to the presence or absence of diagnostic criteria and the variety of presentations that it comes with. Thank you. Hello.
Thank you. This is only one case.
Yes, sir. Actually, there were 2 more cases who were presented, but due to lockdown, the case follow-up was not done.
What are the indication of immunosuppression?
Sir, in cases of ocular sarcoid, when the patient is either intolerant or resistant, or they start developing side effects to steroids, we can switch over to the immunosuppressive agents.
Okay, thank you. You are Khushbu Chawla.
Yes, sir. Khushbu Chawla.
Okay, thank you.
Thank you, sir.
Next.
Dr. Rishabh Rathi, can we have your presentation? Dr. Rishabh, are you there? Dr. Sneha, can you present?
Yes.
Please share your screen.
Yes. Is my screen visible?
Yes, we can see your screen.
Good afternoon, everyone. I am Dr. Sneha Shah, third-year resident in Department of Ophthalmology, Surtee Hospital, Bhavnagar. I am going to present a case on clinical study of fundal changes in myopia. Introduction. Word myopia is a Greek word which means to shut or to close the eye. Myopia is a type of refractive error in which parallel rays of light coming from infinity are focused in front of retina when accommodation is at rest. It is also known as near or short-sightedness. Based on degree, myopia can be classified into low, medium, and high myopia. Low is less than -3, medium is -3 to -6, high is more than -6. Various degenerative changes are seen in myopic fundus, which are associated with degree of myopia and age. Peripheral degenerations are common in retina. This study is to correlate fundal changes with age of patient and degree of myopia. Visual impairment due to myopia may be prevented by early detection of common cause by appropriate investigations and treatment. Example is peripheral retinal degeneration and laser. Methodology: this is observational cross-sectional study on myopic patient attending ophthalmology outpatient department in tertiary care hospital after approval from Institutional Review Board from November 2018 to August 2020. 150 patients were enrolled, out of which 50 were low myopic, 50 medium, and 50 high myopic. Total 300 eyes were examined. Inclusion criteria: patient willing to give written informed consent, patient between 10 to 50 years of age group, all degree of myopia, any visual acuity. Exclusion criteria: patient not willing to give written informed consent, patient below 10 years and above 50 years of age group, other ocular disease affecting vision except those related to age changes, aphakic, pseudophakic, systemic disease affecting vision, undergone ocular surgery or sustained trauma. This patient underwent best corrected visual acuity measurement by Snellen stat for distant vision, Jaeger stat for near vision, and cycloplegic retinoscopy. Anterior segment examination by slit lamp, corneal curvature by manual Bausch and Lomb keratometer, intraocular pressure by Goldman applanation tonometer, central corneal thickness by optical coherence tomography, axial length by ultrasound A scan using immersion method, dilated fundus examination by Hinz indirect ophthalmoscope using 20D lens, ultrasound B scan, retinoscopy and dilated fundus examination done using cyclopentolate eye drops 0.5% instilled every 10 minutes for 3 times. Result and discussion. Maximum patients were in age group 20 to 29 years, followed by 10 to 19 years, followed by 40 to 50 years, followed by 30 to 39 years. There were more females than males in study. This table shows the association between fundal changes and degree of myopia. This table shows association between fundal changes and high myopia in other studies like Venkatesan and Kumavavel study. Our result showed significant association of all fundus findings with high myopia than with low and medium myopia, except choroidal neovascularization, which did not differ significantly with degree of myopia. This table shows association between keratometry K1 vertical axis and degree of myopia and keratometry K2 horizontal axis and degree of myopia. All degree of myopia showed highest percentage of keratometry value K1 between 42 to 43.99 diopter and K2 between 44 to 45.99 diopter, with lowest percentage of K1 between 46 to 47.99 diopter and K2 between 48 to 50 diopter, indicating flatter than normal cornea to compensate axial elongation in myopic patient. This table shows association between axial length and degree of myopia. Axial length increased with severity of myopia with value more than 28 mm in 15% of high myopic patient and none with low or medium myopic patient. Association between central corneal thickness and degree of myopia. Highest percentage of central corneal thickness value in all degree of myopia was between 500 to 549 micron, followed by 450 to 499 micron. Decrease in CCT underestimates IOP and is contraindication for laser surgery in this patient. Association between fundal changes and age group. 100% of high myopic patient had tessellation. It did not differ with age. Temporal crescent was common in higher age group. Peripheral retinal degeneration was common between 20 to 29 years of age. Posterior staphyloma was significantly associated with patients between 30 to 39 years. Retinal detachment did not vary with age. Information derived through limited number of 150 patients cannot be extrapolated to generalization considering large subset of myopic population. Visual impairment conclusion. Visual impairment due to myopia may be prevented by early detection of common cause by appropriate investigation and treatment. Early diagnosis of peripheral retinal degeneration with indirect ophthalmoscopy and prophylactic laser treatment can prevent retinal detachment. Early diagnosis of choroidal neovascularization and its prompt treatment with anti-VEGF factors may prevent vision loss. Ocular parameters are altered in pathological myopia. Axial length is increased and their increase is proportional to refractive error. Central corneal thickness is decreased, which underestimates intraocular pressure, thus easily missing coexisting glaucoma. Therefore, it should be mandatory that fundus of all myopic patients must be examined as routine with good mydriasis. Effective reduction of visual impairment is available with optical correction by spectacle, contact lens, refractive surgery. Periodical monitoring is essential. My references. Thank you.
Thank you.
Yes.
What are the factors which increases the myopia? Although this is not related with your study, but
Genetic factors and environmental factors. Hello.
Any treatment, drug treatment?
Yes, atropine 0.1%. It can prevent the progression of myopia and not treat myopia.
Okay, thank you.
Thank you.
Next, can we have Dr. Rishabh Rathi with his presentation?
Yes, am I audible?
Yes, you're audible.
Can you see my screen?
Dr. Mohit is also there?
Yes,
Dr.
you can
Mohit?
see your screen.
Good afternoon, sir. I joined halfway through the last presentation. I had a talk which in another session which
Okay. Welcome on online. Okay, thank you.
Good afternoon. I'll be presenting a paper on study over macular thickness in myopes and emmetropes. I'm Dr. Rishabh Rathi, Junior Resident in Department of Ophthalmology, MMIMSR, Maulana University, Ambala. Myopia is an important cause of visual disability in both the developed and developing countries. Its prevalence varies from different parts of the world in different age groups and ethnic groups. Prevalence of myopia is high and approximates to about 80% in Asia and 25% in other parts of the world. Myopia usually starts in school age and becomes stable by the end of second decade of life. Changes as atrophic and degenerative in myopic eyes are commonly seen particularly at the posterior pole, particular as depicted by the histological studies and thereby associated with higher incidence of macular abnormalities and hence the purpose of the study. Assessment of macular thickness is essential for diagnosis and monitoring of the disease, of the problem. Optical coherence tomography is used as the tool to measure the macular thickness. OCT is a non-invasive imaging modality for the objective evaluation of the central retinal morphology as well as the measurement of the retinal thickness. The relationship between refractive error or axial length and the macular thickness have been inconsistent among the studies. Macular thickness measured through OCT shows a high variability with values ranging from 190 micrometer at the center point to 387 micrometer from superior inner and nasal inner zones of macula. The retinal macular on a multitude of factors including age, gender, ethnicity, axial length, and refraction. It is difficult to ascertain any one variable as the reason for the change in the retinal macular, as ethnicity is one of the factors affecting the retinal macular. It is of interest to a possible relationship between the retinal macular thickness with respect to the refractive status of the eye in the Indian population. OCT, the material methods that I used, it is a basically cross-sectional OCT based study was done on randomly selecting 30 patients, emmetropes and myopes, regardless of their age and their sex. Subjects were divided into two groups on the basis of their spherical equivalent. Myopic in this study were considered anything above than -1, and emmetropes were between -1 and +1. All subjects were subjected to general examination, systemic examination, ocular examination, which included visual acuity with and without pinhole by Snellen's chart, retinoscopy assessment for best corrected visual acuity, and subjective spectacle correction, fundus examination by ophthalmoscope and plus 90D lens, slit lamp examination, and finally the optical coherent tomography for assessing the macular thickness. Macular thickness measurements were obtained. The central circle has a diameter of 1 mm. Any one eye of each patient was used for statistical analysis. Statistical analysis with having a p-value more than 0.5 was considered. Mean deviations. Data was compiled and analyzed in SPSS software. The OCT systems, Osiris Edge OCT, on a spectral domain OCT software, macular thickness was scanned using the fast RNFL protocol, which uses an aiming circle with a default diameter of 3.46 millimeter. Operator manually adjusts this aiming circle such that its center coincides with the center optic disc. In this study, the central macular thickness based on a cube of 6 millimeter into 6 millimeter captured by a macular cube scans. This provides the qualitative and quantitative evaluation. Central macular thickness has been taken into consideration in this particular study, which was automatically calculated by existing CIRUS SD-OCT software. Inclusion criteria include myopic patients of both gender with best corrected visual acuity of 6/6 and less than 40 years of age. Exclusion criteria exclusion criteria were any other disease of the eye which can affect the retinal nerve fiber layer, like disease of retina or optic disc, refractive errors other than myopia, that is astigmatism, patients with any corneal disease, patients with glaucoma or ocular hypertension or strabismus, patient with a history of any other ocular surgery or ocular trauma. The results over central macular thickness in eMetrope showed 244.50 plus minus 10.2. It showed 251.10 plus minus 20.1 micrometer. The analysis showed this, in which is higher when compared with emetropia, the macular thickness, but it is statistically insignificant because after evaluation the p-value came out to be 0.11. The findings seem similar with Walkintani et al. And Zhang et al. That in myopic eyes there is a thicker central macular thickness. This is said to serve as a compensatory mechanism at an expense of a thinner peripheral retina in order to preserve the fovea, which is more essential to the vision. The present study shows that myopes, the central subfield macular thickness is on a higher side compared to central macular subfield in emetropes. It is the limitations being, it is a single center study with a very small population size, so the result could not be generalized to the whole population. These are my references.
Okay, thank you. Dr. Mohit, any question? Please make your sound is not coming. Huh?
Sorry,
yes.
sorry, my bad, sir. So again, excellent presentation, Dr. Rathi. I just had one question. What new are you adding to ophthalmic literature regarding macular thickness in myopes and young myopes, because you just included patients less than 40, apart from what is already known?
Sir, I basically wanted to understand why there are age-related changes over macula. Why? Because macula is the part of retina that gives us the last vision. When we are losing vision, when there is some kind of degeneration, or if there is associated myopic glaucomatous changes, everything comes down to the central tunnel vision. So I just wanted to evaluate or to understand the relationship, because age-related changes in macula have been a point of interest, because as soon as people are getting older, there is something or the other that relates to it and gets macular compromised. So I just wanted to relate, is there any possibility of getting something out of axial length and macular thickness? That was my point.
Okay.
Okay, thank you.
Thank you, sir.
Thank you, Dr. Rishabh. Next presentation.
That's all for today, sir.
Okay.
Yes, sir. There are no more presenters.
Only I will only second Sonam, Verma, Rishabh, Nitin, Khushbu Chawla 8, and the
Yes, sir.
last
5
11.
of them are absent.
Who are absent? First one.
Yes, sir. Dr. Shailendra, Dr. Sayali, Dr. Khushbu Meena, Dr. Latika, and Dr. Gaurav.
Khushbu Meena absent. Latika absent.
And Dr. Gaurav.
Gaurav Shukla. Okay. Thank you so much. Where to deposit this in the?
Sir, you just email it back.
हैं?
email करना है सर.
किसको?
डॉक्टर नम्रता.
अच्छा ठीक है ईमेल भेज दो.
Yes sir.
ठीक है दे देंगे. ठीक है
Again,
ईमेल भेज देना. हाँ डॉक्टर मोहित, any discussion?
No, sir. I just wanted to know that we grade. So Dr. Navneet had actually opened that Google form.
Yes,
and
sir.
I was grading them on that. We need to grade them out of what? What's the
Out of 10. Out of 10.
Great. Okay, because I gave it out of 100, so that I just wanted to be
Okay,
double
sir.
sure. Thank you, sir. Thank you. Thank you.
Dr. Navneet?
Yes sir.
अच्छा you are handling. You are from RP
Yes.
Center ना?
Yes sir.
अच्छा. ये गूगल पे देना है या साइड में दे देंगे ऑफिस में?
आप ईमेल कर दीजिए डॉक्टर नम्रता को. मैं आपको उनका ईमेल भिजवा दूंगी.
स्नैपशॉट करके दे दें, भेज दें?
हाँ जी सर.
ओके थैंक यू.
ओके सर. Good evening, everyone. We'll be starting with the retina free paper, session 6. I invite Dr. Raghav, who is judging this session today. And each speaker will be given a total of 6 minutes for presenting, followed by a 2 minutes time for discussion. And you'll be scored out of 10. We have our first presenter, Dr. Aman. Dr. Aman, are you there?
Yes, I'm here.
Can you please share your screen?
Sure. Is it visible?
Yes, we can see your screen.
Yes. So I'm starting. A very good afternoon to all the judges, my seniors, and my fellow colleagues. The topic of my free paper today is dengue-induced ischemic foveolitis and outer maculopathy, novel retinal findings using swept source optical coherence tomography and optical coherence tomography angiography. The authors have no financial disclosure or proprietary interests. The purpose of our study was to assess the serial changes in the vitreous inflammation, the retinal structure and vascularity among patients with dengue maculopathy imaged using swept source OCT and OCTA. So during an outbreak of dengue fever epidemic, as we all know, India is an endemic for this virus, a subset of patients presented to our clinics with unique constellation of vitreoretinal manifestations where inflammation and ischemia were the hallmark features of the disease. So using high resolution swept source OCT and OCTA, we aimed at identifying these features, understanding their pathogenesis, and studied the longitudinal structural changes and functional improvement in these patients. The most common posterior segment manifestations of dengue fever, as we all know, include macular edema, hemorrhages, foveolitis, cotton wool spots, and microaneurysms. So we enrolled 16 patients, out of which 7 were males with dengue fever, which were positive for NS1 antigen serology and diminution of and who presented with diminution of vision. All the patients were imaged at baseline, first week, third week, 6th week, and 12 weeks, and 24 weeks with respective fundus pictures, swept source OCT, and OCTA. The FA was performed only at baseline. Along with this, clinical manifestations of dengue fever and platelet counts along with NS1 reactivity was noted. So all the patients in our series were started on oral corticosteroids at a dose of 0.5 to 0.75 milligram per day of oral prednisolone with a maximum dose of 50 milligram per day. And the corticosteroids were tapered on subsequent visits after 2 weeks based on the decrease in the vitreous cells, the vitritis, and improvement in best-corrected visual acuity by 5 milligram per week henceforth. And they were stopped in all patients by 3 months of follow-up. So in our results, the swept source OCT images, as I'll be showing in the subsequent slide, showed a presence of posterior vitreous cells in all the patients at the time of initial presentation, showing the inflammatory component of the disease. There was also presence of outer plexiform and outer nuclear layer hyperreflectivity in all the eyes. Hence, the outer layers of retina were getting involved in these patients, which we termed as foveolitis. And OCTA analysis revealed disruption of the superficial capillary plexus in 14 eyes out of 16 eyes with distinct flow deficit areas. And flow deficit areas were also present in all the eyes involving the deep capillary plexus. So the deep capillary plexus was involved more than the superficial capillary plexus, as it was also seen in the OCT, swept source OCT. So this is the fundus photography of one of the sample patients in which multiple retinal hemorrhages can be seen in the macula with grayish lesions present parafoveally in both the eyes. There was a perivascular foveal leak and blocked fluorescence which was present, which was corresponding to the retinal hemorrhages. This was the swept source OCT, which revealed vitreous cells, which could be seen clinically also, with hyperreflectivity of the reflectivity of the outer plexiform and outer nuclear layers. There was a incidental finding which we noticed. There was a hyperreflective conical elevation, which were seen in some of these patients, apart from the hyperreflective OPL and ONL. So at 3 months, there is resolution, as we see in further follow-ups, there is resolution of the vitreous cells and the normalization of the foveal contour, which can be there. The OPL layer shows significant thinning, which was hyperreflective earlier. that hyperreflectivity is lost in the further after treatment. This is the octa of the same patient, in which superficial capillary layer at baseline shows an area of flow deficit around this where the cursor is there, and in the perifoveal region. And the deep capillary plexus also shows an area of capillary deficit. On follow-up, after the treatment was done at 3 months, there was no change in the area of capillary flow deficit, thus changing that these ischemic changes are perhaps there permanently. So concluding my talk, the pathophysiology of dengue maculopathy involves both ischemic and inflammatory components, resulting in presence of vitreous cells and characteristic outer retinal changes, which was clearly seen in all the patients. An early institution of corticosteroid therapy may result in resolution of the inflammatory driven vitreoretinal alterations, but the ischemia of the deep capillary plexus, which is clearly seen in the octa, may persist, leading to permanent structural and functional changes. Thank you.
Thank you, Dr. Aman. I would like to invite Dr. Raghav for any questions.
Yeah, so just wanted to know what was the platform of the OCT angio that we used?
Sorry, sir?
The platform of the OCT angio.
So we use TopCon only.
Okay, so it's a step to OCT with what platform? Is it the SSADA or is it the OCT ARA?
So SSADA.
And we noticed more of the deep plexus, you said, right? So what
yes,
is
the deep capillary plexus.
Mechanism of foveolitis, the hypothesized mechanism for dengue foveolitis?
Sir, in the inflammatory component is very clear since the beginning only that the vitritis is there. But as we see in our swept source OCT, in which the clear delineation of the outer layers of the retina are visible. So the outer plexiform and nuclear layer were hyperreflective, showing there is an inflammatory component of the layers of the retina also, which get resolved with the corticosteroids. But subsequent in the octa, in which we saw the deep capillary plexus, which is near the outer plexiform layer only, there is the flow deficit is there, which persists even after treatment.
Right. So apart from the OCT findings, were there any other functional parameters which were evaluated in terms of vision, in terms of MFERGs, or in terms of other parameters evaluated in the study?
Sir, electrophysiology we didn't do in this study, but yes, baseline vision and subsequent vision was evaluated. And as the vitritis and the foveal contour became better, the patient had tremendous visual BCVA improvement.
Patient presented basically with scotoma, or what was the presenting complaint, or is it just?
So presenting was just diminution of vision. So incidentally, during that time there was an endemic going on. So after taking a comprehensive history, it was known that most of the patients had dengue, and when we to look back at their history, NS1 antigen was positive, and we repeated it if it wasn't done earlier.
All right. Okay. Thank you.
Thank you, sir.
Next, I would like to invite Dr. Anuradha for her presentation. Dr. Anuradha, are you there?
Is my screen visible?
Yes, we can see your screen. Please share your presentation.
Yeah. Is the presentation visible?
Yes, it's visible.
Okay. A very good evening to everyone. Today, I present before you a study of ocular changes in patients on long-term treatment with hydroxychloroquine. The authors have no financial disclosures. Hydroxychloroquine is a very widely used drug in rheumatological practice. It is used in the treatment of rheumatoid arthritis, systemic lupus erythematosus, and many connective tissue disorders. It was introduced as a safe alternative to chloroquine, which has been known to cause irreversible retinopathy and cornea verticillata. However, very soon, hydroxychloroquine was also found to have progressive retinopathy on long-term use. Hence, a plethora of studies were conducted over the last 6 decades, mainly comparing 2 to 3 investigative modalities to find an effective screening source. In our study, we incorporated a comprehensive clinical exam along with a battery of investigations to maximize detection of drug toxicity in the population that we studied, while also comparing the efficacy of the tests. We conducted a cross-sectional observational study of 100 patients over 1.5 years in a tertiary care center in New Delhi. The ethical approval was obtained from Ethics Committee of the hospital, and the patients were explained all the examination and investigation procedures in a language they could understand, and an informed consent was taken. Male and female patients aged 35 years or more who had history of hydroxychloroquine intake of more than 5 years were included in the study. Patients with any pre-existing ocular pathology, including congenital and acquired diseases of the optic nerve and retina, or any ophthalmic manifestations of systemic disease like diabetes, were not included. The patients underwent thorough clinical examination in the form of history of any visual symptoms, visual acuity testing using Snellen's chart, best corrected visual acuity, color vision assessment using Ishihara plates, Amsler grid assessment for any scotoma or metamorphopsia, slit lamp examination for corneal deposits, cataract, and a preliminary exam of the macula with 90D lens were done. Indirect ophthalmoscopy was done to look for a macular pigmentation, foveal reflex assessment, or to look for any bony spicule degeneration, arteriolar attenuation, or optic disc atrophy, and signs of bullseye maculopathy. Investigations included a 10-2 automated perimetry, a spectral domain optical coherence tomography, photographic documentation, along with a fundus fluorescence, angiography, and autofluorescence. A multifocal ERG was not done because of its non-availability in our center. We used descriptive and inferential analysis to analyze our data. Continuous measurements were reported in mean plus minus standard deviation, and categorical measurements were reported in percentage. This is a patient workup performer that we used to bring out the positive and negative clinical history and examination findings, indication, dose, duration, and cumulative dose of the drug. Systemic investigations and an exhaustive ocular examination were also done. Demographically, majority of our patients were aged between 35 to 50 years. 89% of our patients were women, which correlates with the higher prevalence of rheumatological disease amongst women. Cumulative dose was between 500 to 1000 grams in majority of the cases, with an increase in cumulative dose with age. 37 of the 100 patients reported visual symptoms. Most commonly reported symptoms were dimness in feeling of dimness, difficulty in reading, or discomfort to ambient light, or seeing a scotoma in the field of vision. During evaluation, 82 patients were found to have reduced vision due to a variety of causes, of which the most common cause of reduced vision was refractive error, followed by senile cataract. Hydroxychloroquine toxicity was determined to be causative in 2 patients. Assessment of the retina revealed irregular macular pigmentation and blunting of foveal reflex in approximately 10% of the cases. 1 patient showed classical features of late-stage toxicity in the form of vascular attenuation, optic atrophy, and bullseye maculopathy. Automated perimetry of central 10 degrees of visual fields revealed visual field defects in 21 patients, while 17 and 10 patients had abnormal OCT and autofluorescence findings respectively. The classical saucer-shaped defect reported on OCT was not seen in any patient. No significant abnormality was seen on FFA in any patient. This is a summary of the patients who had at least 2 abnormal tests out of OCT, visual fields, and fundus autofluorescence. As we can see, the age, symptomatology, and duration of treatment are very variable amongst the patients. Patient 10, who demonstrated bullseye maculopathy, had received the highest cumulative dose. Now let's have a look at some of the individual patients. These are the findings of a patient with features of hydroxychloroquine toxicity. OCT macula shows thinning of foveal, perifoveal, and parafoveal retina. Left eye worse than the right. Visual fields show scotoma in the inferior hemifield in both eyes. Again, left eye worse than the right. These are the fundus photographs and autofluorescence findings in the same patient. Another patient showing abnormality in OCT macula and 10-2 visual fields, suggestive of hydroxychloroquine toxicity in both eyes. And these are the fundus photographs and autofluorescence of the same patient. This slide depicts the examination and investigation findings of the patient with bullseye maculopathy. We can see severe foveal thinning in both eyes, Fundus photograph and fundus autofluorescence show characteristic bullseye maculopathy. Visual fields could not be assessed in this patient due to severely diminished vision. At the end of the study, we found that 15% of our patients showed features of early to advanced hydroxychloroquine toxicity. It was noteworthy that most of our patients were on a daily dose of 200 milligram and were asymptomatic. While objective tests like perimetry, OCT, and fundus autofluorescence provided effective screening tools, subjective tests and FFA did not provide much information. The results of this study emphasize the importance of the revised guidelines for screening of hydroxychloroquine toxicity as per the American Academy of Ophthalmology. The study did have its limitations. We had a small sample size of only 100 patients, and the patient demography did not follow a normal distribution. Even so, we were happy to have been able to conduct this study for the first time in the armed forces. These are some of the literature that we took reference from during the course of our study. Thank you.
Dr. Anwada there?
Yes, sir. Yes, I'm here.
Yeah. Nice presentation and very well collected data. Can you tell me what is the earliest autofluorescence finding in hydroxychloroquine toxicity?
So we find early hyperfluorescence and surrounding hypofluorescence, which later on progresses to hypoautofluorescence due to complete atrophy of the RP layers.
All right. So, regarding the risk factor assessment, did any of your patients had concomitant risk factors?
Sorry, sir, can you please repeat that question?
With all the patients who had chloroquine toxicity,
yes, sir.
What was the incident? Any test showing positive toxicity? What was the overall percentage out of 100 patients? How many showed toxicity?
So 15% cases, sir. Total of 15 cases, sir. After doing all our investigations, we focused on when we found that most of the investigations, the important investigations were OCT, FAF, autofluorescence, and fields. And we found that 15% of our cases were having abnormality in these tests.
Right. That is only retinal toxicity you're talking about.
Right, sir. Yes, sir. But we had done a complete evaluation and we did not find any corneal or lenticular toxicities in these patients, only retinal toxicity.
Right. And what was the most important factor from what you have evaluated? What was the most important factor causing toxicity in your patients? Was it the dosage what you mentioned as more than 200 milligram per day, or was it the duration of the consumption?
Sir, it was the cumulative dose of the drug that we saw was causing, it was directly related to the severity of the toxicity, because many of our patients were on 200 milligram per day. Some patients even had a break in the treatment when they were treated with hydroxychloroquine for a few months or 2 years, 3 years, then were given a break and restarted. And even then those patients had shown signs of toxicity. So it was the cumulative dose of the drug that was most important in the prevalence of the toxicity.
Right. And if the dose is discontinued after the toxicity is setting, is the changes reversible?
No, sir. The changes are not reversible because the drug it stays bound to the melanin in the RPE, and it keeps causing damage to the retinopathy keeps progressing even if the dose is halted in case of hydroxychloroquine.
Thank you.
Thank you, sir.
Next, I would like to call Dr. Vijender for the presentation.
Ma'am, is my screen visible to all of you?
Yes, we can see your screen.
Good evening. I'm from ISCOMS Jammu. I will talk about evaluation of visual outcome in combined phacoemulsification with vitrectomy in diabetics. Our aim was to carry out a prospective study to evaluate visual outcome in combined phacoemulsification with vitrectomy in diabetics. It was a hospital-based observational study that was conducted in the Department of Ophthalmology, GMC Srinagar. Study period was 1.5 years, and total number of eyes were 27 of 27 patients. Patients of vitreous hemorrhage with or without coexisting proliferative diabetic retinopathy, and patients with visually significant lens opacity with NS grade 2 to 6 and PSC of 2 to 5 were involved, and patients with rubeosis iridis and neovascular glaucoma were excluded from the study. The preoperative assessment, patients underwent preoperative
Excuse me,
assessment.
Dr. Vijender Kaur.
Yes, sir.
Yeah, I cannot see your PPT. It's still on the first slide.
Okay, sir. Sir, I'm starting it again. Is it visible to you, sir?
Only the first slide is visible.
Okay, sorry, ma'am. First slide visible.
You can click on the slideshow. Dr. Vijender?
Dr. Vijender?
Ma'am, I'm trying to make it visible to all of you, ma'am.
Okay.
Ma'am, is it visible now?
Yes.
Yeah, we can see.
Yeah.
Okay, ma'am, shall I start it from the scratch or?
Yes, please start. Please start again.
Okay. I will talk about visual outcome in combined phacoemulsification with vitrectomy in diabetics. It was carried out as a prospective study to evaluate visual outcome in combined phacoemulsification with vitrectomy in diabetics. It was a hospital-based observational study that was conducted in the Department of Ophthalmology, GMC Srinagar. The study period was 1.5 years, and the total number of eyes were 27 of 27 patients. Patients of vitreous hemorrhage with or without coexisting proliferative diabetic retinopathy, and patients with visually significant lens opacity with NS grade 2 to 6 and PSC of 2 to 5 were involved. Patients with rubeosis iridis and neovascular glaucoma were excluded from the study. The patients underwent preoperative assessment with full ocular and medical history, visual acuity by Snellen's chart, base-corrected visual acuity, slit lamp examination, intraocular pressure, indirect ophthalmoscopy, and D-scan ultrasonography. The other parameters that were assessed were HbA1c value at presentation, which were of the range of less than 6.5 in 4 patients, 6.5 to 7.5 in 17 patients, more than 7.5 in 6 patients, with duration of diabetes of less than 10 years in 6 patients, 10 to 20 years in 12 patients, more than 20 years in 9 patients, with blood sugar fasting of less than equal to 110 in 5 patients, 111 to 212 patients, more than 210 patients, and HDL to LDL ratio of more than 0.4 in 6 patients, and 0.3 to 0.4 in 10 patients, and less than 0.3 in 11 patients. Routine phacoemulsification with implantation of posterior chamber intraocular lens was carried out as an initial step by a single surgeon. Main port was sutured in all eyes. 4 patients had non-dilating pupil of 4 mm size, but phaco was carried out without the use of pupil expanders. 25 gauge sparse planar vitrectomy wasn't performed with meticulous shaving of vitreous space under a wide angle view with assisted scleral depression. Endolaser photocoagulation was performed in all eyes. Additional retinal surgery with siliconal insertion was done in patients with tractional retinal detachment. 27 eyes of 27 patients were enrolled in the study. 18 patients had vitreous hemorrhage, 5 patients had vitreous hemorrhage with tractional retinal detachment, and 4 patients had diabetic macular edema with vitreous hemorrhage. Preoperative laser photocoagulation was performed in 15 out of 27 eyes. However, all patients received endolaser photocoagulation at the time of surgery as well. Whereas 20 out of 27 eyes received anti-VEGF therapy preoperatively, and 7 out of 27 eyes received anti-VEGF therapy during surgery. Age distribution of study population, 30% were of the age group of 40 to 54 years, 37% were in the age group of 55 to 69 years, and 33% were above age of 70 years. 55.6 patients were males, and in 59.3% of the patients, left eye was involved. Preoperative visual acuity among the study eyes was hand movements in 13% of the patients, counting finger close to face in 5 patients, 1/60 in 3 patients, and 2/60 in 5 patients. Visual acuity was assessed post-operatively at 1 week, 1 month, and 3 months. Visual acuity was at 1 week post-operatively was hand movements in 1 patient, counting finger close to face in 3 patients, 1/60 in 6 patients, 2/60 in 12 patients, 3/60 in 4 patients, and 4/60 in 1 patient. And at 1 month post-operatively, visual acuity improved to 1/60 in 2 patients, 2/60 in 3 patients, 3/60 in 3 patients, 4/60 in 6 patients, 5/60 in 11 patients, and 6/60 in 2 patients. And at 3 months post-operatively, visual acuity improved to 1/60 in 2 patients, 3/60 in 2 patients, 4/60 in 3 patients, 5/60 in 7 patients, 6/60 in 10 patients, 6/36 in 3 patients, and 6/18 in 1 patient. Preoperative, the logMAR preoperative visual acuity was 2.42, which at 1 week was 1.71, which differed by 0.71 post-operatively, which was statistically significant, and at 1 month, which again was 1.22, which differed by 1.20 from the pre-operative visual acuity, that was statistically significant, and at 3 months it was 1.06, which differed by 1.36, which was statistically significant post-operatively at 3 months. Combined procedure of phacoemulsification with vitrectomy had several advantages over sequential procedure: improved visualization of fundus, faster visual rehabilitation, and elimination of cataract that would inevitably progress after vitrectomy. On the other hand, cataract surgery in vitrectomized eyes has been reported to present special challenges, which include the loss of vitreous support, unstable posterior capsule, weakened zonules, posterior capsular plaques, and deep anterior chamber. In our study, significant visual improvement was seen from mean preoperative logMAR visual acuity of 2.42 to 1.06 post-operatively. Similarly, when compared to study conducted by Hanan et al., which showed preoperative logMAR visual acuity of 2.62 changed to 0.7 post-operatively. At 1 week, 5 out of 27 patients showed improvement. At 1 month, 22 out of 27 showed improvement. And at 3 months, all except 1 patient showed improvement from baseline. At 3-month follow-up, 13 patients showed vision less than 6/60. In the case series reported by Handan, Kenan et al., BCVA increased in 79, and in 6 eyes, visual acuity remained unchanged. In our study, showed an improvement in visual acuity at 3 months from baseline. Vitreous hemorrhage developed in 2 patients who underwent revitrectomy. LNM patients developed fibrinous reaction, which resolved with topical steroids. Diabetic macular edema persisted in 5 patients post-operatively with vision less than 3/60. Rubeosis iridis developed in 2 patients who were constantly monitored for raised IOP and were put on anti-glaucoma medication, and pan-retinal photocoagulation was done. Vision didn't improve beyond 6/60. 4 patients with existing tractional retinal detachment underwent parchment vitrectomy, membrane peeling, delamination with silicone oil insertion. However, vision didn't improve beyond 5/60. The limitations were short follow-up period of 3 months. Because of small sample size, confounding factors like systemic status of diabetes mellitus, hypercholesterolemia, raised IOP was not compared. Thank you.
Apart from the advantages of a single setting surgery, what are the disadvantages of a single setting surgery?
In single setting surgery, if we are going for vitrectomy, again patients will develop cataract with time, and in diabetics, as we can see with the long duration, they can develop cataract, and later then they have to come for cataract surgery again. So
regarding disadvantages of a single step surgery, disadvantages of doing both together.
Okay. Sir,
advantages, we agree that there will be only one surgery, patient will further develop post-vitrectomy, the cataract is going to increase. But
yes.
Are there any disadvantages of doing a single step surgery?
Sir, it is time consuming. We can, one or two surgeons are required, but in our setup, only a single surgeon operated the surgery. So, and fundus visualization can't be sometimes there because of vitreous hemorrhage. So while we are doing the cataract surgery.
So what are the disadvantages of what difficulties will you face during cataract surgery, and what difficulties will you face during vitrectomy in a single stage?
So if we are doing cataract surgery, so there will be poor fundus glow, and that is one thing. And if we are performing vitrectomy, so there will be the posterior capsule will be flexible, and in while doing cataract, there will be deep anterior chamber. Then
we can go ahead with the next.
Next, I would like to invite Dr. Ankur Singh.
Hello,
Hello.
am I audible?
Yes, you're audible and your screen is visible.
So can I start?
Yes, yes. Please start.
Good afternoon, everyone. I'm going to present my presentation on efficacy of intraoperative OCT in various vitreoretinal indications. There are no financial disclosures. OCT in ophthalmology is a vital diagnostic and therapeutic surveillance tool and forms the very integral part of clinical retina practice. In past, it lacked portability, making it unavailable for the operation theater as well as for the intraoperative use. Microsoft Integrative OCT is a novel technology having the ability to provide real-time visualization of ocular anatomy during surgical procedures. Real-time images are displayed to the surgeon on the head-up display or the eyepiece of the microscope. This allows the surgeon to perform image-assisted or image-guided surgeries and thereby aiding in improving the post-operative outcomes. The purpose of the study was to evaluate the efficacy of intraoperative OCT in surgical decision-making for various vitreoretinal indications. It was a retrospective study. The data was retrieved from of the patients from July 2019 to November 2019. Participants included the patients undergoing any posterior segment procedures who underwent intraoperative OCT imaging with Microsoft Integrative IOCT system. These patients were divided into 4 groups. In a group A, where intraoperative OCT were used as an alternative to a surgical step that requires surgical adjuvants like various dyes, triamcinolone, or where we require proportional reflux hydrodissection. In group B, intraoperative OCT acted as a guide to a surgical step, as in the case while giving subretinal TPA injection, or in a case where macular hole surgery was done with using ILM tucking or autologous neosentinel retinal graft. In Group C, intraoperative OCT provided a new additional intraoperative finding, which led to additional surgical maneuver. These were the groups where intraoperative OCT provided additional information which was missed by the surgeon to the naked eye. In Group D, and this is a novel technique which we devised, this where intraoperative OCT acted as a diagnostic tool in uncooperative pediatric patients undergoing examination under anesthesia. So this is a collage of all our patients. Here what we see is that where we have used intraoperative OCT as a surgical adjuvant, and we did the surgery without the aid of the dye. Here, this is a case of macular hole, and where this is where the intraoperative OCT provided us the right plane to dissect. At the same time, it also helped us to not cause the damage to the adjoining retina. This is the group B, where intraoperative OCT provided us the surgical endpoint. And as in this case, where I'm going to discuss this further, as in this case where we were giving subretinal triamcinolone, this provided the endpoint. These are the group C's, are the groups which where we the intraoperative OCT provided the surgical endpoint, and in Group D was those cases. Group D was the cases where intraoperative OCT were used in doing assessment of the retina in pediatric cases non-invasively. So this is a small video, which is I'm going to elaborate how we use intraoperative OCT. So here we can see that there is a diabetic TRD where we can see that intraoperative OCT can visualize the cutter as seen over here and the right plane for the dissection. Although a proficient surgeon can do that without the aid of intraoperative OCT, but then intraoperative OCT can also provide us information after the completion of the surgery that the fovea is absolutely intact. Sorry. Yeah. While removing epiretinal membrane, intraoperative OCT can clearly visualize the epiretinal membrane. At the same time, it can also provide us the PIC areas, and thereby aiding in the removal of the epiretinal membrane without the need of any dye. As in this case, it also provides us a new information in the form of inner retinal corrugations, which were visible after we did the ILM peeling or ERM peeling. In this case, of the combined RD, intraoperative OCT was a very informative tool because it provide us with the information, like in this particular case, with this traction of this ERM was missed to the naked eye of the examiner or the operating surgeon. Interoperative OCT provided us this information, which helped us to remove this additional leftover membrane and thereby increasing the surgical outcome. In this particular cases, like where I was talking about, where interoperative OCT helped in us in giving subretinal TPA in the cases of subretinal hemorrhage due to ARMD, you can easily see that with by using Med1 cannula, the raising of the bleb shows us the completeness of the procedure, because this is the time we had injected the subretinal TPA. If we did not have the dye in these particular cases, after doing fluid exchange, interoperative OCT could visualize the integrity of the ILM and its right placement in the macular hole. Interoperative OCT was very useful in the cases where retina is difficult to visualize in myopic traction maculopathy. It same is in the optic disc maculopathy, because in these cases, if we did not use the dye after doing fluid exchange, with the chances of the ILM graft to dislocate, if interoperative OCT can act as a very beautiful tool to visualize the ILM graft tucked into the optic disc bed. Here in these pediatric cases, without going invasive, we can visualize the retina of the infants by doing the EUA. And this is the technique where we developed that interoperative OCT can provide us information about the retina of these infants without compromising the integrity of the globe. So there were 41 eyes of 31 patients. Interoperative OCT in 95% of the cases demonstrated successful image acquisition and provided useful information in 38 eyes. In group A, around 85% of cases, that is in 17 eyes out of 21 eyes, interoperative OCT was able to visualize the tissue of interest, and we were able to complete the surgical step without the need for surgical adjuvant. In group B, 100% of eyes, that is all 4 cases, interoperative OCT acted as a useful guide to a surgeon and helped him to carry out the surgical procedure without the trauma to the adjacent retinal tissue. In group C, interoperative OCT was done in 11 eyes to confirm the clinical diagnosis, and in those 11 eyes, 27.27% cases, it provided us an extra information. Thereby, the additional maneuver was done, and this improved the surgical outcome, because using interoperative OCT in these cases prevented us from leaving around any residual membranes. In group D, in around 80% of cases, that is 4 out of 5 eyes, interoperative OCT was able to visualize the retinal architecture in these pediatric patients. So in our experience, interoperative OCT has come up as an important promising tool in surgical decision making to achieve better results. It has the potential to reduce the various surgical adjuvants. The potentiality of MIOCT to become an impeccable surgical tool of future, that is that it can act as a non-invasive tool for OCT image acquisition during examination under anesthesia in neonates. It can prevent surgical complications as well as can act as a surgical endpoint guiding tools. And if we integrate this with the 3D display technology, it can be a great learning as well as teaching tools for postgraduates or fellows. Thank you.
Did you find any difficulties with the use of MIOCT? Like, what are the drawbacks of using microscope integrated OCT while doing vitrectomy?
Sir, right now, the problem is this, that the technology that exists, which we have used is with JAIS, that we need to, shift the focus of the, we need to move this square every time to the focus of the interest. So thereby, if we think that it's going to reduce the surgical time, it rather increases the surgical time, because you need to move around this cursor and look at those different areas. So if there could be a tracking, the automatic tracking, or the, something which can aid with the head movements, and you can directly visualize the area of interest with your head movements, it would rather decrease the surgical time. So we needed a person to, the surgeon needed to track to the area with this square, and he needed to move this with the joystick with the foot pedal. At the same time, there was one person busy who was trying to, improve the quality of the OCT, because sometimes with the movement of the eye during the surgery, the quality of the OCT came up and down.
Right. Apart from that, interoperative, anything else, any difficulties which we can face with currently whatever platforms we have? What are difficulties during vitrectomy do we face? Is it real time?
Yeah, it is real time, sir. It is real time. It's so beautifully shown into the eyepiece of the surgeon that it doesn't interfere with your surgical procedure. It doesn't make you feel that it is something in front of your eyes while you're operating. It's shown in the side corner. So whenever you want to, whenever you want to see, it gets actuated and you can visualize the area of interest. I would say it's very beautiful. I would say it's very beautifully used when we are, worried about that maybe I've left something, or do I need to, do peel more again. You can do an OCT at that there moment and see and feel safe now. Everything is done, everything is fine, the phobia is okay, and you are good, and you're good to close the case.
Okay. So apart from the advantages, there is always a certain lag period between the OCT acquisition and depicting it in your eyepiece. Moreover, it is only in one eyepiece that it is depicted.
Absolutely.
Right. So, and also the shadow effect of your cutter will always be there when you go and pick a membrane or you operate. So even in your videos, if you see, there is always a shadow effect which may hamper a bit of your intraoperative manipulation at that time.
Yes, sir. But then, sir, in these cases, that is what we need to develop. If we use plastic, if we look even the tip of the cannulas, they don't create that much shadow effect. But yes, the metal equipments which we have in our, VR, they do have a shadow effect. That is true. Absolutely
Precisely. So those were the difficulties which I wanted you to answer me. That what are difficulties can you face with current IOCT platforms?
Thank you, sir.
Right. Okay. Thank you.
Next, I would like to invite Dr. Bhumi for the presentation. Dr. Bhumi? Dr. Ankur, can you please mute yourself?
Hello.
Yes, Dr. Bhumi.
Is my screen visible?
Yes, your screen is visible. Please start with the presentation.
Good morning, everyone. Good evening, everyone.
Start a slideshow.
Yes. Sorry. Good evening, everyone. My topic for today's presentation is case series of role of oral eplerenone, which is a mineralocorticoid receptor antagonist for the treatment of the chronic central serous chorioretinopathy. The central serous chorioretinopathy is a disease of a choroid and retina that causes subretinal fluid to accumulate underneath the macula. CSCR is thought to be caused by an underlying abnormality in the choroidal vascular permeability along with a dysfunctional retinal pigmented epithelium pump mechanism. There are various etiology and risk factors associated with the development of the CSCR. One of the most important causes of the development of the CSCR is increased level of the mineralocorticoid. The mechanism by which the mineralocorticoid produces the CSCR is there are many receptors present in the inner layer of the retinal cells. In bipolar cells, amacrine cells, and Muller cells, there are mineralocorticoid receptor present. Due to upregulation of this mineralocorticoid receptor, there is vasodilatation of the choriocapillaries occurs, and which causes the fluid to accumulate underneath the subretinal space. In our study, I examined 8 eyes of the 8 patients diagnosed with the chronic central serous retinopathy without any other possible risk factor causing the disease. Presenting to the ophthalmology department was noted. All the patients received tablet oral eplerenone 50 milligram per day for 1 month of period. Visual acuity testing was done using Snellen's chart for each patient. Complete anterior and posterior segment evaluation was done using slit lamp biomicroscopy and indirect ophthalmoscopy with 20 diopter lens. The Optical coherence tomography was done for assessing different OCT parameters like subretinal fluid, central macular thickness. In our study, for the first patient, the visual on presentation, the visual acuity was 20/80. The subretinal fluid, the central macular thickness was noted in our OCT was 503. And there is a significant amount of subretinal fluid, which is 297 micrometer. After the treatment of oral eplerenone therapy, the visual acuity was significantly improved, and there was complete resolution of the subretinal fluid, which was noted in the OCT. The second patient presented with visual acuity of 20/60, and the central macular thickness was 429 micrometer, and the subretinal fluid height was 228 micrometer. After the treatment of 1 month of the oral eplerenone therapy, the central macular thickness was significantly reduced, and there is complete resolution of the subretinal fluid. The visual acuity was also significantly improved. There is another patient which presented with the central macular thickness with 318 micrometer, with the subretinal fluid height was 148 micrometer. In this patient also, after the treatment of oral eplerenone, the visual acuity was significantly improved, and subretinal fluid was also significantly resolved. The another patient which present with the central macular thickness was 517 micrometer with the in this patient, after the treatment of oral eplerenone, there was not complete resolution of the subretinal fluid, but there is significant resolution of subretinal fluid, and significant improvement of the visual acuity was noted. So these 5 patients, there was a significant improvement in the visual acuity, and the central macular thickness was also significantly improved. So excessive glucocorticoid dependent choroidal mineralocorticoid receptor activation in the choroidal vessels may be involved in the pathogenesis of CSCR. Eplerenone is a mineralocorticoid receptor antagonist. Oral eplerenone may be effective in the treatment of CSCR and should be investigated as a potential treatment choice in the chronic cases. Also, oral eplerenone is also less invasive than the laser treatment and anti-VEGF injections. After 1 month of this treatment, the best corrected visual acuity was significantly reduced, and there was complete resolution of the subretinal fluid was noted in most of the patients. So in my conclusion, the eplerenone therapy resulted in significant anatomic and visual improvement in the eyes with the chronic central serous chorioretinopathy, and it is also the most non-invasive therapy in the treatment of chronic CSCR. Thank you.
Dr. Bhumi, can you go back to your third or fourth slide?
Yes, sir.
No, stop. After that. Right. Okay. You may end your screen sharing. Dr. Bhumi, how did you define your case as chronic CSR? What was the case definition of your study?
The patients complain for decrease in the vision was more than 3 months duration. Then also in fundus examination, there were some RP atrophy present, and pigmentation also present near the macula.
So that was not mentioned in your inclusion criteria, that it has to be more than 3 months. Need to include that all the patients were more than 3 months.
Yes, sir.
That's how you define. Also, the fundus picture was relatively of a fresh CSR. And what all changes do you expect in chronic CSR?
In chronic CACR, first will be there will be some pigmentation also present. Then RP atrophy also present. Then retinal pigment epithelial detachment also seen in the fundus photography.
Okay. Right. How do you monitor? When you give oral eplerenone, is there anything that you should measure or you should monitor? What are the side effects of oral eplerenone?
There are side effects, systemic side effects are present like the diarrhea, then a decrease in the blood, hypotension.
Any particular test you carry before you start oral eplerenone? Any blood investigations you?
The bleeding, clotting time and bleeding time can be seen. So because bleeding are also one of the side effect.
Not a major side effect, but serum electrolyte levels need to be seen.
Serum electrolyte.
Okay, thank you.
Thank you, sir.
I would like to invite Dr. Chirag for the presentation now.
Am I audible?
Yes. Yes, you're audible.
Is my screen visible?
Not yet.
No, not yet.
Dr. Chirag, are you unable to share your screen?
Can you hold for 2 minutes? I'm trying actually.
Okay.
सर आपने बैकग्राउंड में अपनी पीपीटी खोली हुई है?
हाँ खोला हुआ है। हेलो।
तो सर क्या प्रॉब्लम आ रही है सर?
मेरा मैकबुक है एक्चुअली, तो उसमें वो जब वीडियो शेयर करने के लिए जा रहे हैं तो सिस्टम प्रेफरेंसेस के लिए वो बोल रहा है, एंड सिस्टम प्रेफरेंसेस में गए हैं तो कैमरा ऑन है वैसे जूम मीटिंग के लिए, बट उसके बाद नहीं हो पा रहा है।
Dr. Navneet, do we have any other presentations for the day?
Yes, sir. Yes, sir.
Do we have any other presentations for the session left?
No, sir. He was the last one.
Hello.
Yes, Dr. Chirag.
So may I suggest something?
Yes,
Please
am I visible
let-
now?
Yes, you're visible,
Okay.
but we can't see your presentation.
I'm so sorry. Actually, I'm unable to
Uh,
do it.
Hello.
Hello. Yes.
Please go to share screen in Zoom and then just start your presentation. Keynote or PowerPoint.
So click on share screen first of all.
Yes, yes. मैंने share screen किया है, but it's not happening only. So sorry.
Sir, when you're sharing the screen, what exactly notification you're getting?
एक स्क्रीन आ रहा है जिस पे डेस्कटॉप, व्हाइट बोर्ड एंड वो सब आ रहा है, बट उसमें कोई ऐसा ऑप्शन नहीं आ रहा है कि
Sir, choose desktop and open your presentation.
Yeah, choose your desktop and share your screen, then you can open your presentation.
ओके ओके डेस्कटॉप कर रहा हूँ, बट उसके बाद ओपन सिस्टम प्रेफरेंसेस आ रहा है, तो आफ्टर दैट इट्स नॉट हैपनिंग.
What are the options? So what are the options in that, in system preferences?
See, after clicking the camera, it's for the Zoom meeting, it's open. Matlab, I have clicked it. After that, it's not happening anything.
Yeah. If you're unable to share the screen, you can also email your presentation to us and it will be evaluated accordingly.
Okay, so can I share it now?
Yeah, if it's possible for you to share it now, you can do it. Will you be able to present?
It's not opening only. I'm
Okay,
trying actually.
then you can email it to us and it will be evaluated accordingly.
Okay. Hello.
Yes, Dr.
Yes,
Chirag.
I have sent you the mail actually. I am trying, but it's not happening actually.
Okay, it's fine. Then we'll evaluate your presentation that has been sent to us.
Yes, I have sent on the main mail ID.
Okay, thank you. With this, I would like to conclude this session. Thank you, Dr. Raghav.
Thank you. Thank you for having me. I would like to thank all the participants. Indeed, very nice presentations, and thank you, Dr. Navneet, for having us. Thank you.
Thank you, sir.